Guest on Professor Major General Obashino Ayodele Ogunbiyi, the pioneer president of I-CCSN, Professor Sanusi, our chief host, members of the executive committee of I-CCSN, in the person of Dr. Job Otokwala, president, Dr. Paul Febunam, secretary, Dr. Irene Ahideno, vice president, Dr. Nika Owade, treasurer, Dr. Ifeanyi Opara, rep of the trainees, Dr. Abiodun Ojedunyi, PRO, Professor Bibi Oshinaike, ex-officio, and Dr. Yetunde Daramola, Assistant Secretary General, all here present. Our special invited guests, representatives of participating organizations, participants, members of the media, ladies and gentlemen, you're welcome to the 11th Scientific Conference and Annual General Meeting of the Intensive and Critical Care Society of Nigeria. You are also welcome to the inaugural lecture, the Professor Major General Obashino Ogunbiyi inaugural lecture.
Recording in progress.
We shall be kicking off the events for today with a slight rearrangement on the program that you have. In order to save time, we'll start off with the presentation from the companies. So, Supreme Medicals, if you are available, we want you to step forward. Let's quickly take yours before we formally go into the affairs for today. Supreme Medical. Okay, if Supreme is not ready, I think next we have Mindray. Are you here? Step forward, please. Yeah, he's signal that he's ready.
You have slides? You have slides? I was going to present one. Okay. Yes. And you're not ready for today? Yes. So call the next one. Don't worry, let him pause this.
All right. Still, in order to save time, shall we have Lagoon Hospital step forward and make your presentation, please? Are the representatives of Lagoon Hospital here? Okay.
Come. Give me the PowerPoint.
There's something that saved you. He was on Lagoon Hospital.
L.
That's
That is the critical care.
Yeah.
Just wait. This?
Yes.
Wait. Yes, ma'am. And disturbing you guys, right? Everything na me.
Good.
Anesthesia and so
I'm presenting after him.
do you have your slide?
No.
Are you the same slide?
I'm using.
Are you Lagoon? No, you know we're online.
While we are waiting for Lagoon Hospital to step forward, the event today is indeed a very colorful one. The eminent personalities we have in this hall, and some of whom are still just outside waiting to come in, is immense, huge. We shall recognize individuals as we see them.
Thank you.
In that regard, may I recognize the presence of
You have
Dr.
Obio?
Omo, the Chief Medical Director of Federal Medical Center, Saba. You're welcome, sir. There are also quite a number of CMDs that are present in the hall. As we identify each person, we'll recognize your presence. And in the event that we miss out any, please forgive us. Lagoon Hospital, you have the floor.
Okay. Yes, I can. All right. Good morning, everyone. I'm Dr. Oyeniro Olubisi. I'm the MD of Iwosan Lagoon Hospitals, the Ikoyi branch, and I double as the CEO for the entire group. First, I would like to say thank you to the Intensive and Critical Care Society of Nigeria for the invitation and for giving us the opportunity to participate in this conference. My brief is very small, is to share our own perspective as a private hospital that operates at the tertiary care level on what our experience has been in providing acute care at, in my own assessment, the highest level in the country. I have a couple of slides, but please don't be distracted with what I have on the slide. I will emphasize a couple of things that I believe are most relevant so that we can enrich the conference. So this is who we are. And this slide is quite important to us as an organization. Every single thing we do, be it strategy, be it investments, be it the way we think about expansion or scaling, each of those decisions can be traceable or traced to something on this slide, right? And our vision is that we are a consistently patient-first, world-class healthcare services provider. Again, the wording of that vision statement is intentional because we believe that our future can be lived even from now. And then our values are those of empathy, we are ethical, we are knowledge-driven, we are innovative, and then we are accessible. And across our floors, our brand promise to all our customers or stakeholders is that we will look after you. Again, that's a stark reminder for us every day that we need to be customer-focused or patient-centric. And that's exactly what we aspire to be. Our history, again, lots of stories, but I will just emphasize one or two things. We were founded in 1986. Lagoon Hospitals clocked 40 years this year. And we established our presence as a full-fledged hospital in 1986. What is also most relevant is that the fact that in 2021, we got our quality accreditation from the Joint Commission International. That's a US-based, that's the gold standard of quality accreditation in healthcare, really. And we've been re-accredited back-to-back 5 times. So that's quite relevant to us. It speaks to the consistency of care we provide. And last but not the least on this slide is the fact that we changed ownership in 2021. We've had several cycles of ownership, and by 2021, we were acquired by a group of local investors called Iwosan Healthcare Systems. And since 2021 till date, I'll speak a bit more about the impact of Iwosan Healthcare Systems on Lagoon Hospital. One or two things to emphasize on this slide is the fact that across our group, we have about 110 beds. 19 of those beds are critical care beds. And our workforce, this is excluding our trainee doctors and trainee nurses. We have about 750 of them, both clinical and non-clinical. Okay. Just to give a perspective of how we are structured, I mentioned a bit earlier. So we are a network of 3 full-fledged hospitals, and then we have ambulatory clinics. So our hospitals are in Ikoyi, Ikeja, and then Ligali, Ayoride in Victoria Island. And then we run ambulatory clinics for a couple of companies, but we have outpatient clinics in Ijeja, VI, Alaro City, and then in Adini Jones in Ikeja. So those hospitals, the hubs, be it the hospitals and then the spokes being the ambulatory clinics, then feed into the healthcare system. Again, I'll speak a bit more about that. Just to mention a couple of people on our board of directors. Our chairman is Mr. Falajala, who, again, in the context of the discussion of the conference, these are people who have decided to invest their resources in healthcare. And they are all local. Mr. Diola co-founded Iwoso Investments Limited with Mrs. Lai, who happens to be the daughter of our founder, Professor Davidson. On our board, we have Professor Nelson Oyeshiko, who is a neurosurgeon from the US, and then a couple of other people in energy, in banking. We have Otuba Shiro from the Abuja Investment Limited. So that's the board. But on the management side, we have group functional leads, be it HR, be it strategic projects, be it finance, risk and compliance. So that's the way we are kind of set up. But from a governance perspective, the biggest council as far as clinical governance is concerned in Lagoon Hospital is our Medical Advisory Council, which is chaired by Professor Ishiko. And these are the some of the members. This is not exhaustive. Professor Goshalada, as the Vice Chancellor of the University of Lagos, sits on our Medical Advisory Council. I'm running very quickly. So each of our facilities, we have managing directors, and these are the managing directors of all the hospitals, as I mentioned earlier. So what we have then done with our facilities, again, because we are multi-site and we are trying to deal with the significant problem of fragmentation within the healthcare sector, is to sit some specialty strategies in each of our locations. So hospitals is a general hospitals. We provide general medical care, at least at the primary and secondary care level. But when it then becomes tertiary and maybe even higher, then decide where we want to provide that level of care. So for instance, our Ikoyi branch is where we do the bulk of our critical care work. I'm speaking a little bit more about Ikoyi because that's most relevant to this conference. And that's also where we do our complex surgical work. The branch is where we do our maternal and child work. The most active, the most complex mother and child gynecology work happens in the region. And then our cardiac center, our cardiology center is our Nigalia Yoruba branch, where we do interventional cardiology, we do our cardiac surgery work. And then we have our spokes in our military clinic. Again, what this has helped us to do, again, is to optimize in terms of efficiency, in terms of sitting our most experienced specialists in each of the relevant locations. Focus our investments in each of those locations. For instance, we have a robotic strategy now. It's very clear that that strategy is going to sit, or the investment is going to sit in our Ikoyi branch, where we do our most complex surgical work. Right. So, not to bore us too much, talking about people, this is just for some of us who have been to the Ikoyi branch, this is where the magic happens in critical care. One corner of the hospital, just to the bottom right here. Once we take that corner is where we have a 12-bedded critical care unit. Now, so again, this is our capacity. So we have a 9-bed ICU in this Ikoyi, and then we have an extension 3-bedded HDA.
Because this is my microphone.
In our VI branch, I think I have a picture as well. We have a 5-bedded coronary care unit to support the cardiac dialysis. Then we have a 2-bedded HDA. So if we do the sums, that's about 19 critical care beds across the entire government. And so the principles that then apply to us as we think about continuous improvement, as we think about expansion, as we think about scaling even our services, is clinical excellence, quality and patient safety, and then continuous learning. And if you permit me, I will share that we have a board of directors who really pride themselves as being impact investors. So they just want to demonstrate that local investors can actually make things work. And that's exactly what the experience has been over the last 5 years. And these are the principles that we live and die by. There must be clinical excellence. There must be quality and patient safety. And then for you to achieve both, then you have to be committed to continuous learning. And that's exactly why we felt partnering with this association for this conference is quite very important. So this is our governance framework in terms of it's so busy, but this, if you just follow my line of thoughts, it's very actually very easy to understand. At the very bottom of this slide is the fact that the foundational quality expectation of every member of staff in Lagoon. So for instance, even as from day one, somebody is telling you about incident reporting, you have to self-report if something goes wrong, right? Whether in the course of your work, whether it's something you observed in the colleague, right? So we have things like M&Ms, we do our reviews, we do our clinical audits. We have a dedicated quality team that then supports all this work. The way we collect data in Lagoon sometimes is scary. There's nothing that is not being measured. There's nothing that we don't keep track of. So that's the foundation at the base of this slide, right? But all of that foundational work reports into what we have then called our facility medical advisory committees. So we have 2 of those committees that meet every quarter, without fail we meet, right? And we have one of such committee that covers the island branches. We have the second one that covers the mainland branch. And reporting into those committees, we have 4 subcommittees: pharmacy and therapeutics, IPC, theater users, and then health and safety. Now, so all the foundational work we do at the base of this framework gets collated, gets analyzed into those subcommittees that then reports into what we have then called also Medical Advisory Council. So the facility committees then go to give account of quality, performance, quality outcome to the also Medical Advisory Council every quarter. This happens every month. And then the Medical Advisory Council itself then reports to the Board of Directors. So we spend a good time during our board meetings actually reviewing medical outcomes, having medical discussions, even though most of the people for that non-medical. But it just speaks to the commitment we have to sustaining quality. Why have I told all of this story? Why am I sharing all of this? This is what has helped Lagoon to sustain the quality of care we provide for the last 40 years. Right? Because it's very easy to get equipment. It's very easy to, people will come and go. But what makes that work really sustainable is the systems you have built around it. And in our own experience, that's made the difference. Some of the things we measure, nothing new to anybody in this room, I suppose. But we measure these things very, very deliberately. At our mortality meetings, every mortality gets reviewed, whether expected or unexpected, right? So that we can learn lessons. We check our average length of stay, we check our ICU readmission rates. It's a long. Our quality dashboard is actually quite significant. And we have people committed to doing this. But they are not doing it alone. They actually do it in partnership with the people who are actually doing the work. Some of them are actually in this role. Again, just to enhance the quality framework we have. So we believe, like I mentioned the other time, that the biggest investment we can make is in developing sustainable processes and systems. And to run those systems, we then believe we need to invest in our people. So those 2 take precedence for us. So our people, our process, we are obsessed about those 2 elements of the entire ecosystem. And then on top of that, then comes the infrastructure, the physical infrastructure. And we believe that the intersection of those 3 things, then really, that's where the strength of any system, even outside of healthcare, comes. Really.
Volume, raise your mic. Mike.
This is my last slide. Some of us might know a couple of things already because there's nothing here that's in the public.
Raise your mic.
Lagoon Hospital.
Raise your mic. They are not hearing you.
They're not hearing me.
Yes. Raise your mic.
Can you hear me now? It's better. Oh wow. Okay. So I was just sharing that within the some healthcare systems now, we have like a hospital, and then the acquisition of Hilton Memorial Hospital, and then Miracle Specialist Hospital, all in Lagos within that healthcare system. And of course, we have the also wellness. So what we are trying to do is to integrate, to have horizontal integration. So that means that we can have multiple doors, but through those doors, you can have access to any of our systems, right? So it's possible for somebody to go to, say, Pilon Memorial Hospital, have their cardiology consultation, and then require intervention, and that intervention will be done in the Lagon Hospital Legally branch, right? With any specialist there. It's possible for a staff in Lagoon to resume, say this week in the critical care unit in Ikoyi, and then by the next month will be in the critical care unit in Urake. Again, just to make sure that we have some level of integration and parity across the entire system. Now, that integration work is so significant, and we are actually taking learnings from the Bio Clinic in the US. This is a very matured system, and they have done this, in fact, several years ago. They've done it over and again. They've had several iterations of integration. So Mayo Clinic is helping us as we build our culture of excellence, as we build even our integration across financing, across our tariffs, across our staffing, across workforce development, across research. So we are doing this in partnership with them. Of course, we mentioned workforce development and then digital innovation. On top of everything I've said is the fact that it's very difficult to scale what you are doing without technology support. That's very apparent now. So we are very deliberate about digital transformation within Lagoon, be it autonomous transcription or support in critical decision making, or a lot of places abroad now they are building smart hospitals even. But what can work for us in our current context is what we are trying to leverage on. Technology has gone way beyond. And the message really is if you build a sustainable system, then it's very easy for you to then layer technology on and then scale if you do that. Because if the system is not strong or if the system is inefficient, then you make those inefficiencies amplified with technology. Last but not the least on what our aspiration is the fact that we're building a 140-bedded hospital at the site of the old nursing school on our way. For those who know Lagos, is a PPP with the Lagos state government. It's a 140-bedded level 5 acute hospital. So it's going to have a fully kitted diagnostic center. We have 2 towers of hospitals. It's going to have doctor's offices. It's going to have even patients' rooms and things like that. So it's a full medical panel. Why that we believe is relevant is that will be the peak of the level of care we provide. And so it will be the tip of the pyramid, meaning across the entire ecosystem, we can provide primary, we can provide secondary, and even tertiary. But the most complex of these things we then have to feed into Lagos Medipack. And one of the most, of course, important specialty there is going to be critical care, much more significant than what I've shared. So that's Lagoon story, and I really hope this will contribute to the discussion. So thank you. Thank you very much.
It's on the table now. No, just leave it there.
Thank you, Lagoon Hospital, for that presentation. So now we'll move into one of the key events for today's activities, and that is the inaugural Professor Major General Ogumbi annual lecture. So without much ado, can we have the So we await the entry. We are awaiting the entrance of the special guest of honor of the day, as well as eminent senior serving and retired officers of the Nigerian Armed Forces who are here to support. Okay, a small change to the program. Supreme Medical Services, are you ready now?
Share your screen.
Okay, so you're going to have 10 minutes to speak. All right, so while we're waiting for the arrival of the guest of honor and eminent invited guests, some of whom are already in the hall, we will take the presentation from Supreme. Thereafter, we're going to the program proper, starting with the national anthem. Supreme.
It's already using a system. Raise your volume.
Good morning, everyone. Thank you to the Society of Intensive Care, Intensive and Critical Care Society of Nigeria for this opportunity. I'm here on behalf of Supreme Meditech, who are our Nigeria partners. My name is Faith Akwaja. I work with Fisher and Paykel Healthcare. As you can see, we are based in New Zealand, Auckland. Most of you are familiar with us. For those of you that are not, we have manufacturing sites in Mexico, China, and New Zealand. We have customers all over the place. Local distribution, more than 180 partners. And in FY25 fiscal year, we served over 20 million patients. What are we about? So we're about a number of respiratory care space, the acute to chronic respiratory care, as well as surgery and obstructive sleep apnea. In the adult respiratory space, we have supported a number of hospitals. Up to about 10 hospitals have our devices now, the high flow. The high flow devices now in its 4th generation. So we've had the Evo 2, the Evo 3, and the Evo 3 Junior. One of the challenges I have seen working across West Africa is the challenge of giving cold, dry oxygen to patients, whether they're neonates, pediatrics, or even adults. And the emphasis now is on providing oxygen in a way that is not harmful to a patient's airway. So a patient can stay on the therapy for a prolonged period of time. And so that's what our device will do for you. You're able to look at the temperature of the patient and decide what temperatures you want your gas to be at. You want to make sure it's humidified so that the function of the mucociliary transport system is not compromised. You also want to make sure that you're giving your patient some pressure, not just oxygen. And also you want to make sure that your patient is comfortable so the patient can tolerate the therapy. Because of time, I'm not able to go into some of the scientific data, but the data is now showing that in a large number of areas of treatment, we are able to treat patients from that require mild to moderately severe respiratory support. We also play in the non-invasive ventilation space. We also support invasive ventilation. We have the consumables to support your patients. We have anesthesia and surgical technologies, which we are not doing yet in Nigeria. We are taking it step by step. We have the home care and obstructive sleep apnea, as well as infant respiratory support. So this is just our growth over the years. I think what is important is that as at 2022, we are now in the third generation of the high flows, but we have bubble CPAP, we have CPAP, sleep apnea, surgical therapies, as you know. I want to show you this slide. So now we're able to provide warm and humidified therapies from the hospital to the home. So for the OptiFlow, we play in the emergency department. What do we do? For hospitals that have emergency department, one of the challenges we see there is bed block, because there's so many patients coming in, they're not stabilized early, and then there's a lot of pressure on the ICU and the HDU. So when we're able to stabilize patients faster in the ED, we move them to areas of lower acuity versus putting pressure on your ICU and HDU. So that's where we come in. We support you with that. We also support you in the non-invasive ventilation. So with CPAP consumables, both for infants and adults, and then as well as sleep apnea at home. So we don't do a lot of high flow at home in Nigeria because it's emerging in this market. For neonatal is where we have a wonderful technology that houses one device that does both high flow and bubble CPAP. So it's no more complicated. You don't need blended oxygen. You don't need piped medical air. One small device does the work for you. This is critical in being able to move your patient from bubble CPAP, avoid necrosis because of the pressure of CPAP, and then have your patient still be on a pressure therapy, and your neonates are able to get better faster. We also play in the resuscitation space, and all of that, you can come to our stand and look at it. I'm just looking at the time. For pediatric, high flow has now become standard of care for non-invasive respiratory support. As you know, your patients that are in the pediatric age group are not able to tolerate CPAP. So what do we currently do for our children who require moderate to severe respiratory interventions, but we only give them oxygen, cannula? What do we do for them? Most of them do not require sedation or intubation. What are we currently offering? So in that space, that's where we come. We train your staff with you. We spend 7 to 14 days. We resume there every day, and we make sure that there's an integration of this therapy and an understanding of how to use it. So this is just basically showing our spread all over the place so that you know that we've been around for over 55 years and you can trust that what we're giving you works. I will ask that anyone that has any questions will come to our stand. One thing that's interesting is that across West Africa, we're domiciled in Nigeria. So Nigeria is serving West Africa, which is fantastic. Yeah, so I'm just rounding up. I've been told I have 2 minutes to go. So this is basically to show that even in Africa, we have 4 people in Africa representing fish and pickle, ensuring that we're not just talking. And one of the innovations is that we are now running clinical studies right here in Africa so that we can compare the results with the results we have seen across the globe, which is showing us that respiratory support is now moving away from more invasive therapies to non-invasive, and your healthcare supporters are Fish and Pickle and Supreme Meditech. Thank you so much for your time. I look forward to seeing you at our stands. Have a wonderful session of the conference. Bye.
Thank you very much, Supreme Health. Thank you very much, Supreme Health. for your presentation. We are standing by for the entrance of our special guests of honor for today. The general and all the generals present with him. In the meantime, let me take us through what the next event would look like. The next event is the inaugural lecture, the Professor Major General Obashino Ogumbi annual lecture. So we'll start off with the national anthem. Thereafter, we'll introduce the chairman, the co-chairman, and so upon the entrance of our guests, we will quickly take the national anthem, introduce our guests, the dignitaries, and a short citation of Professor Major General Ogumbi will be read by Dr. Job Otokwala, the I-CCSN president. Thereafter, a short video of Professor Ogumbi will be played. The citation of the speaker will be read, and the lecture proper will be taken by Professor Ezekiel Taiwo Adebayo. Thereafter, we'll have the chairman's speech and a vote of thanks, and we'll round up, trying as much as possible to catch up with our time, which has gone behind. So here we have the arrival of the special guest of honor, Professor Major General Ogumbi, and architect Mrs. Abimbola Ogumbi, and the generals retired and serving who are here to grace the occasion. You're welcome, sir. You are most welcome, sir. Without much ado, shall we rise for the national anthem?
Which one? Which stand?
Thank you very much. You may be seated. That serves us as the opening prayer. If you read the words of that anthem, you will know that it is indeed a prayer. So, the guest of honor, sir, Professor Major General Obashino Ayodele Ogumbi. Also here present the MNI. If I don't buy a job before the end of today, I'll thank my God. The special guest of honor, the former Chief of Defense Staff, the General L.E.O. Irabo, retired. Our eminent, the wife of the special guest of honor, architect Mrs. Abimbola Ogumbi, the chairman, retired Nigerian Doctors Association, General Umar, the Senior Special Assistant, Senior Special Advisor to the President on Health, Dr. Mrs. Anas Ibrahim.
This is a
Pastor Nkem Akubundu, Professor Soji Adeshuga, Professor Elizabeth Ubolimwaso, former faculty chairman for Anesthesia, West Africa College of Surgeons, Professor Mohammed Dati, Nigerian Society of Anesthesiologists President, the CEO, Cedar Crest Hospital, Dr. Felix Ogenebe, other special guests here present, invited guests, ladies and gentlemen. You're most welcome to this inaugural lecture, Professor Major General Obashina Ogumbi MNI lecture. This indeed promises to be an exciting event. And for some of us who have been privileged to serve under him in various capacities, we are most excited. The lecture for today will be delivered by Professor Ezekiel Taiwo Adebayo. And it promises to be a very, very exciting and enlightening lecture. Without much ado, may I invite Dr. Job Otokola to read the citation for Major General, for Professor Major General.
So am I projecting? What am I projecting? Who is projecting video?
So used to me, I started breathing me. I knew you, I knew you too. And just like a morning, you were too shy, but you were the only cause. So
I press on. Press. Please don't be open the mic. Just leave the mic on.
The chairman of the occasion, retired general, and other dignitaries who have been well acknowledged. This is the maiden edition of the inaugural lecture series by our society, one of our very best. Major General Professor Obashina Ogumbi, who was the past president of our association. It's a privilege that we have to honor him while he's still alive. And that is the reason why the executive committee of our society decided to inaugurate this inaugural lecture. So may I just have the privilege to read the brief citation of Major General Obashina Ogumbi MNI, who is a versatile healthcare researcher, examiner, who has a strong commitment to excellence. And this is being seen, being reflected in all activities around him. He is a professor of anesthesia and critical care at the International University of Management, Windhoek, Namibia, with interest in health systems. We know the role he played during the COVID era, all the efforts he makes to reduce the morbidity and mortality associated with COVID-19. He attended the renowned Methodist Boys High School, Lagos, Ibadan. Lagos, and then obtained the MBBS from the University of Ibadan in 1982. He was commissioned as a Major General in 20. He became a Major General in January 2012. I like the reaction. He was coming as a younger person, and then you got to the rank of Major General. We are proud of you, sir. We're only proud of you. I'm sorry of mission. I hope the generals will pardon me for that. He was a former corps commander of Nigerian Army Medical Corps, where he initiated and midwife the first mental health policy manual for the Nigerian Army. Can we give a round of applause for him? We all know Major General as a patriotic Nigerian who is free with everyone, both young and old. When you see Major General, reflects laughter, fun all the time. Major General Gumbi had a distinguished career with ending biological citation in the Millennium edition of the prestigious Marquis Who is Who in Medicine and Healthcare in the World. Can we clap for him, please? He is also an examiner after being a fellow of the National Medical College and a fellow of the West African College of Surgeons and Anesthesia and a fellow of the International College of Surgeons in 2000. He's also a foundation fellow of the Nigerian Academy of Medicine. I think he was the first in anesthesia to attend this site. Orogumbi, as is reflected in this short citation as a researcher, was a principal investigator for Nigeria's first critical care registry at Lagos State University Teaching Hospital last decade. He has been a collaborator in several other studies in critical care. He was the first African to become a member of the Council of the World Federation of Intensive and Critical Care, the first president. And one fantastic thing about General Gumbi, he retired, was that while he was leaving office, he was pulling Professor Yakubu, another Nigerian, to replace him. So he didn't just get down to the council and he left, but he left by having a replacement. And that has been the ethics of what he does all his life. General, thank you very much. He was the only African to have been invited as an author to a 2021 NIH Youth Global Network on COVID-19. His work on COVID-19 or other contributions made in critical care are everywhere. If you read most of the citations on critical care in Nigeria, it is that pioneered or written, edited or by General Obasino Ogumbi. So, apart from the medical life in him, he also had several other interesting aspects of him that all of us are here to learn. And can you please wrap up to your last
speech?
So his professional scholarships are enough. When we have the program, we see several of the citations, all the initiatives that he made, both in clinical medicine and his medical career as well. So, ladies and gentlemen, we are proud to have one of our very best, our past president, past council member of Intensive and Critical Society of Nigeria, in whose honor we have gathered this morning to pay respect to you while he's still here with us. And we are very glad to initiate this lecture series. It will be an annual event at our annual scientific conference and AGM onwards. If I is in perpetuity that we are doing this in honor of General Ogumbi. We are proud to have you. Thank you very much for coming to honor this our great son. I'm sorry that citation is very brief one. So can we have a short video of him before the lecture starts?
Professor Major General Obashino Ogumbi, MNR, a legacy of service, excellence, and impact. Every great journey begins with a story. Born in Lagos, Nigeria, Professor Major General Obashina Ogunbiyi's story is one of purpose, dedication, excellence, and a lifelong commitment to service. From his early years as a young boy growing up in Lagos, the foundation was laid for a life that would inspire generations. His academic journey began at Methodist Boys High School, Lagos, where he distinguished himself as a student with ambition and determination. In 1977, he began his medical education at the prestigious University of Ibadan, where he graduated as a medical doctor in 1982. Beyond academics, he embraced leadership, friendship, and teamwork, experience that shaped the values that would define his future career. Military career. His military career, spanning over 3 decades from May 1980 to December 2015, was marked by commitment, professionalism, and distinguished leadership. From the rank of second lieutenant in 1980 to major general, he served in various capacities, including command appointments that tested his courage, wisdom, and dedication. He represented Nigeria on an international platform, providing leadership in critical medical operations. In 2014, as Commander Medical of the Nigerian Army, he contributed significantly to advancing military healthcare and strengthening medical excellence. After decades of honorable service, Major General Ogunbiyi retired into the reserve in 2016, leaving behind a legacy of discipline, sacrifice, and impactful leadership. In 2017, history was made when he became the first Black African elected as a council member of the World Federation of Societies of Intensive and Critical Care Medicine in its 40-year history. Professor Ogunbiyi has served as a respected voice in medicine, leadership, and national development. As a keynote speaker and invited guest at local and international platforms, he continues to share knowledge and inspire future generations. Throughout his journey, Professor Ogunbiyi has received numerous recognition for his service, leadership, and contributions. From military honors to professional achievement, From community service to international recognition, each milestone represents a chapter of dedication and excellence. Today, Professor Major General Obashino Ogunbiyi, MNI, stands as a symbol of excellence, a physician, soldier, teacher, leader, husband, father, and mentor. His story is not about achievement, it's about impact. From Lagos to the world, from medicine to military service, from classroom to communities, his legacy continues. Professor Major General Obashino Ogunbiyi, MNI. A life of honor, a legacy of service, a story of excellence. In 1989, Major General Shino Ogunbiyi married architect Mrs. Abimbola Ogunbiyi at All Saint Church, Jericho, Ibadan, and they are blessed with Olusoya and Oluwafikumi as their children. Together they build a family found in love, faith, and shared values. Join me to welcome Professor Major General Obashino Ogunbiyi, MNI. Professor Major General Obashino.
Yes.
That was awesome. Seeing some of those pictures and videos brought back memories of some of the events that I was privileged to have witnessed under the command of Professor Major General Ogunbiyi. A lot could have been squeezed in, but there's just not enough time to read a proper citation of such a colossus. We're proud of you, sir. May I also recognize the presence of Brigadier General A.S. Ayeni, who is the representative of the Corps Commander, Nigerian Army Medical Corps. You're welcome, sir. So next, we will have the citation of the speaker, Professor Ezekiel Taiwo Adebayo. The speaker's citation will be read by the chairman of the local organizing committee, Dr. Harrison. Welcome. Okay, I'm sorry, small correction. Will be read by Dr. Rosemary Mokori on behalf of the local organizing committee.
Yes, lecturer. Yes, lecturer. Is it okay, lecturer? Yes.
Don't change. If I had it my way, you would know that it's you. The coach that I made in the morning. You're my sunshine in the morning when it's morning. Won't you give yourself to me?
May I quickly also recognize the presence of Dr. Ekanem Omo, who is the co-chair for today's event and the Chief Medical Director of Federal Medical Center, Asaba. You're welcome, sir.
Morning, the chairman of this occasion, dignitaries here present, and every other guest in the room. Please permit me to stand on the existing protocol as I read the citation of Professor Ezekiel Taiwo Adebayo, our inaugural lecturer of the first of Major General Professor Obashino Ogunbiyi Lecture Series. Professor Ezekiel Taiwo Adebayo is a distinguished oral and maxillofacial surgeon, an academic leader, public health specialist, and researcher with over 3 decades of professional experience in dental and surgical practice. He obtained his Bachelor of Dental Surgery degree from the University of Benin, Nigeria, and subsequently completed specialist training in oral and maxillofacial surgery at the Ahmadu Bello University Teaching Hospital, where he earned the prestigious fellowship of the West African College of Surgeons. He also holds a Master of Public Health degree from Ahmadu Bello University, Zaire. With more than 30 years of clinical and academic experience, including over 23 years as a consultant oral and maxillofacial surgeon, Professor Adebayo has established himself as a leading authority in oral health care, maxillofacial surgery, trauma management, and public health. His research contributions span a wide range of healthcare issues, including oral and maxillofacial trauma, facial trauma tumor management, obesity among military personnel, rational use of medicines, and broader public health challenges affecting Nigerians. Professor Adebayo has authored and co-authored over 80 peer-reviewed scientific publications in reputable national and international journals. His scholarly work has significantly contributed to advancing knowledge and improving clinical practice in oral and maxillofacial surgery and public health. He has also presented scientific papers and keynote lectures at more than 20 national, regional, and international conferences, earning recognition for his expertise and contributions to healthcare research and education. In recognition of his academic excellence and leadership, he was promoted to the rank of reader in 2019 and obtained the rank of professor in 2022. Since 2021, he has served as acting dean of the Faculty of Dental Services at the University of Medical Sciences, Ondo, where he played a pivotal role in strengthening dental education, research, and institutional development. In 2024, Professor Adebayo was appointed Deputy Chairman of the Medical Advisory Committee, Dental, of the University of Medical Sciences Teaching Hospital, Ondo. The same year, he was elected Chairman of the Committee of Deans of the university. appointed editor-in-chief of the Annals of Health and Allied Sciences, the official journal of UNIMED, and named chairman of the Senate Business Committee, reflecting the confidence reposed in his leadership and academic capabilities. A respected educator, mentor, clinician, and scholar, Professor Adebayo has dedicated his career to advancing oral health care, training future generations of health professionals, and promoting excellence in academic medicine. In January 2025, he delivered the 7th inaugural lecture of the University of Medical Sciences titled Man and His Oral Health, Exploits of a Maxillofacial Surgeon, a lecture that highlighted his lifelong commitment to improving oral health outcomes and advancing the practice of maxillofacial surgery in Nigeria and beyond. Professor Adebayo remains an influential voice in oral and maxillofacial surgery, public health, healthcare leadership, and medical education, with an enduring legacy of service, scholarship, and professional excellence. It's my pleasure to welcome you as I take your inaugural.
Distinguished Chairman, our special guest of honor, respected colleagues, ladies and gentlemen. Having listened to the citation of General Gobi, who I fondly call my Oga, you can understand my fears when he called me to deliver this inaugural lecture. And so I will not go too deeply into his citation, which is supposed to be a preamble to this lecture. But rather, I want to share with you a little story about a 35-year-old pregnant, febrile woman who was rushed into one of our comprehensive health centers in one of our suburban communities. And the maternity, the midwife, who was lucky to have a pulse oximeter, checked and found out that this lady's SpO2 was 82, and that this lady needed oxygen. Unfortunately, the last cylinder was used the night before, and they were waiting for the next supply. She did what a normal person could do, refer the patient to the general hospital. Unfortunately, the lady did not make it. The lady did not make it, not because we didn't know what to do. She didn't make it not because we are wicked people, not because Nigerians are bad. She didn't make it because our critical care system is not resilient. And that is why we are here today, to discuss how to build a resilient critical care system in Nigeria. It is both a privilege and a deeply personal honor to deliver the maiden lecture of this annual series, established to celebrate the life, the service, and the professional legacy of Professor Obashino Ayodele Ogunbiyi, member of the National Institute, distinguished service star, Bachelor of Medicine, Bachelor of Surgery, Fellow of the Medical College in Anesthesia, Fellow of the West African College of Surgeons, Fellow, International College of Surgeons, Certified Intensivist, Doctor of Medicine, Diploma in Health Service Management, and a Fellow of the Nigerian Academy of Medicine. Having known Professor Ogunbiyi as a senior colleague, collaborator, and friend for over 30 decades, I can attest that the honor of endowing this guest lecture series are not merely an acknowledgement of his many titles and decorations. They are a recognition of a lifetime dedicated to excellence, service to humanity, and an unwavering commitment to the advancement of medicine in Nigeria and beyond.
Let's know when to move the slides.
Go to slide 4.
Slide. So it's in the podium.
Okay.
Slide 4. That's the pointer.
Yes.
That's once.
I will just go to
back. Pointer is on the stage. Press back once. Yes.
Okay.
So
note has already been made of all the other achievements of Professor Gombi, and so I will not belabor them. Rather, I will say that Professor Gombi, we are here because of your vision, your sacrifice, and your enduring belief in what Nigeria and African critical care can become. And we thank you. The lecture this morning is about oxygen as lifeline, building resilient critical care systems in Nigeria. This lecture is based on 2 concepts. First, oxygen as a life-sustaining force. And second, how we can build resilient critical care system in Nigeria. It is quite opposite to consider these together, because having survived the COVID-19 pandemic, we know that critical care situations like mass casualty from security challenges or another pandemic would occur due to climate change, zoonotic spillovers, and increased global connectivity. And we need to be properly prepared as a nation. I will therefore present this lecture in 4 parts. The present status of the Nigerian health system in brief, the status of critical care in Nigeria, access to the lifeline medical oxygen in Nigeria, and then building a critical care system in Nigeria. Thankfully, the Senior Special Assistant to Mr. President is here on health, and so many of us are aware of these statistics. Nigeria is the most populous country in Africa, with an estimated population of 253 million by 2025. We have one of the largest youth populations globally, with 70% in 30 years of age, below 30 years of age. At a time of shrinking birth rates in the global north and east, our high proportion of young people confers on us a huge demographic potential when properly harnessed. However, the Nigerian population faces severe health challenges, shortages of financial, material, and human resources, pervasive insecurity, and rampant corruption. As of 2020, 5% of our population were aged 60 years and above, which, when juxtaposed with the high proportion of young people, shows a nation in demographic transition with an increase of non-communicable diseases such as obesity, hypertension, traumatic injuries, and medical health disorders. Socioeconomic challenges and population growth have worsened environmental deterioration and unchecked urbanization, with adverse effects on social equity, sanitation, and ultimately health outcomes. In 2019, enteric and respiratory infections were the largest contributors to mortality in Nigeria. Therefore, the Nigerian health system faces the triple burden of communicable diseases such as enteric infections, malaria, tuberculosis, and HIV, non-communicable diseases such as obesity, hypertension, and cardiovascular diseases, injuries, and violence. All of these 3 are seeking services from a sick health system. Life expectancy in Nigeria is increasing but still remains below the global average. The last 26 years of fairly stable democracy has improved our ability to translate health aspirations into policies. Examples include the Health Sector Reform Committee of 2021, which recommended expanding health insurance coverage, the Basic Healthcare Provision Fund, various state-level social health insurance programs, and increased investments in health-related teaching, learning, and treatment facilities under the Renewed Hope agenda. But despite these interventions, our health system lacks resilience. Population coverage under the new insurance mechanisms remain below 10%. This was what the minister announced last week, well below the 90% target. Out-of-pocket expenditure on health is above 75% of total health expenditure, which is well above the regional benchmark of 30 to 40%. This poor performance is attributable to persistent government underinvestment in healthcare, limited capacity to implement health insurance programs, and administrative inefficiencies. We need to increase healthcare financing beyond current levels, address the factors pushing healthcare personnel out of Nigeria, reduce corruption, and alleviate health infrastructure deficits. Having briefly reviewed the state of Nigerian health system, let us now examine critical care. Critical care refers to the specialized care of patients whose life-threatening conditions require comprehensive, constant care and monitoring, usually in an intensive care unit or a high dependency unit. Critical illness is a state with vital organ dysfunction, a high risk of imminent death if care is not provided, and a potential for reversibility. The importance of managing critical illness is illustrated by the estimated global incidence of 30 to 45 million people each year. However, this likely underestimates the true burden, as it excludes many critically ill patients who are treated in general wards and emergency wards rather than intensive care units. The African Critical Outcome Study estimates that 1 out of every 8 patients admitted in African hospitals has a critical illness. And of those, 1 in 5 dies within 7 days. This underscores both the burden and the fatal outcome of critical illness. Several studies report that there is high unmet need for critical care services in Africa. In Nigeria, Oshinaike and colleagues found there were 385 intensive care beds nationwide, giving a ratio of 0.19 beds per 100,000 population. This is lower than the African average of 1 bed per 100,000 and far below the 34 and 24 beds per 100,000 in the United States of America and Germany, respectively. A recent study from a tertiary care center in Southwest Nigeria gave the indications for intensive care unit admissions as neurological disorders, respiratory disorders, cardiovascular diseases, and hematological conditions. Ventilatory support was needed mostly by patients with neurological disorders, followed by those with respiratory and cardiovascular disorders. The ICU mortality following mechanical ventilation in that study was 75%, which is significantly higher than the 45% reported from another center. Reasons for our poor outcomes included poor triage systems, delayed patient presentation, lack of funds for admission, frequent power outages, ventilator-associated complications, high cost of ICU care, and insufficient staff to patient ratios. The African Critical Outcomes study found that among critically ill patients with respiratory failure, only 48% were receiving oxygen. Of those with circulatory failure, only 54% were receiving intravenous fluids or vasopressors. Mortality was 20.7% among the critically ill, compared to 2.7% among those that were not critically ill. Most deaths among critically ill patients occurred in general wards, 52.9%, as compared to 27% in intensive care units and 20% in high dependency units. This emphasizes the importance of intensive care units and high dependency units to critical care. Since not all critically ill patients will need intensive care unit or high dependency care, it is likely that the ratio of patients who need intensive care unit facilities is around 1 in 100,000 hospitalized patients. I therefore propose that Nigerian hospitals with at least 300 bed spaces should have at least 3 critical care beds. This could also be an accreditation requirement for hospitals by the appropriate national and state regulatory agencies. Our guest of honor has worked extensively on critical care in Nigeria. In a review, he and his colleagues listed challenges facing critical care as inadequate facilities, low number of skilled workforce, critical care physicians, nurses, respiratory therapists, speech therapists, low healthcare funding, irregular electricity supply, restricted availability of maintenance staff, equipment and parts, widespread poverty, absence of a national protocol for standardized care. They suggested ways to improve critical care services, including prioritizing critical care in national and subnational health budgets, implementing comprehensive health insurance that includes critical care, improving training and retention of skilled staff, then conducting implementation studies on new digital technologies, and research into cost-effective treatments using locally sourced therapies. Since most critically ill patients are not treated in intensive care units and high dependency units, there is need for critical care training, facilities and consumables to be provided across a range of healthcare environments, including pre-hospital settings, emergency units, and general wards in Nigeria. The foundational components of timely and effective care have been collectively termed essential, emergency, and critical care by the World Health Organization. This includes oxygen therapy as part of a package of 40 basic treatments and actions, including triage, vital signs monitoring, airway support, and intravenous fluid therapy. Most of these resources are not very expensive, and the skills can be taught to healthcare providers outside the intensive care unit. In Tanzania, the essential emergency and critical care has been estimated to cost approximately $14 per healthy life year saved, reflecting a high probability of cost effectiveness similar to anti-malaria medication or emergency obstetric care. Your society could assist in identifying practitioners to be trained in the essential emergency and critical care approach in Nigeria. Access to the lifeline, medical oxygen in Nigeria. I started this lecture by narrating the story of medical oxygen. The administration of supplemental oxygen is very common in critical care to prevent and treat hypoxemia in conditions such as pneumonia, sepsis, and to deliver safe anesthetic care. It is also vital in managing major trauma and heart failure. To reinforce the need for oxygen, the first 2 elements of the ABC of resuscitation focus on oxygenation, that is airway and breathing. The third component, which is circulation, is also essential for delivering oxygen to the tissues. Medical oxygen is therefore an essential medicine for any health facility that cares for unwell newborns, children, or adults, and provides obstetric, surgical, and postoperative care. The history of oxygen dates back to the 18th century, when Joseph Priestley isolated oxygen in 1774. By the late 19th century, Sir William Hosler and Jonathan Meckins had formulated the role of oxygen therapy in treating hypoxemia from pneumonia and other diseases. The importance of oxygen was reinforced in 2017 when the World Health Organization added it to the model list of essential medicines for treating hypoxemia. During the global COVID-19 pandemic, medical oxygen use was shown to be a determinant of outcomes, as the most common manifestation of the virus was hypoxemia. In many countries, including Nigeria, the COVID-19 pandemic exposed the critical gap, lack of available and accessible medical oxygen. From a health systems perspective, access to medicines involves availability, affordability, quality, and rational use. For oxygen, it has to be available at a very high purity, above 82%. Appropriate delivery services must be available, such as nasal cannula, masks with reservoir bags. There should be facilities for blood oxygen measurement, pulse oximetry as a minimum. A range of medical technologies, such as oxygen concentrators, cylinders, piping systems, are also necessary. You need skilled personnel, technicians, nurses, doctors, administrators. You need infrastructure, power supply, maintenance systems. This diagram shows you some of the things that you need to maintain oxygen supply in your facility. To achieve optimal access to medical oxygen, healthcare workers need the skills to administer it according to guidelines. A work environment that ensures they give oxygen to the right patient at the right time, every time. A pre-COVID-19 study from 12 Nigerian secondary health facilities found that oxygen access for children and newborns was compromised by faulty equipment, lack of pulse oximetry, and inadequate care practices. Only one hospital used pulse oximetry for pediatric care. Out of 57 oxygen concentrators, only 2 were fit for use. Overall, 14.4% of the children received oxygen at some time during their admission, but only 19% of those who received oxygen were actually hypoxemic, that is, they needed oxygen. This means that many patients who needed oxygen did not get it, and many who got it did not need it. During the COVID-19 pandemic, a survey of 58 health facilities in Lagos State found that only 14 had a functional pulse oximeter. Most facilities, 59% of them, had a functional source of oxygen, but usually in one ward area, typically the operating theater or maternity ward. Oxygen services were free at primary healthcare centers, but expensive in hospitals. They are free in the primary healthcare center when they are available. Pulse oximetry use was low, 32% in secondary care facilities, negligible in private facilities and primary health centers. When you triangulate this together, the data from this study suggested that no health facilities was equipped to meet minimum oxygen delivery demands. A cost effectiveness study in Nigeria reported that an estimated 5-year cost effectiveness of approximately $86 per patient treated, $2,694 to $4,300 per life saved, and $82 to $125 per disability adjusted life year averted from oxygen use, which is comparable to other life-saving interventions. After the pandemic, the availability of pulse oximetry and oxygen in 7 countries, including Nigeria, was evaluated. In Nigerian facilities, 53.7% of them were primary care centers, 41% were secondary care, and 2 were tertiary care centers. Pulse oximetry coverage for adults attending secondary care facilities was 11% and 74% for tertiary care facilities. For children, it was 31% in secondary care facilities and 61% in tertiary care facilities. Availability and the use of pulse oximetry and oxygen was low in primary healthcare facilities. In hospitals, oxygen was more consistently available than pulse oximeters. Overall, there are strategic opportunities to improve access to medical oxygen and pulse oximeters in Nigerian health facilities. To ensure sustained access, the Federal Ministry of Health and Social Welfare formulated the national strategy for the scale-up of medical oxygen in health facilities. The strategy aims to provide access to oxygen to all Nigerians from primary healthcare centers upwards. To achieve optimal access to medical oxygen, it must be available and accessible. Healthcare workers must have the skills to administer it according to guidelines, and a work environment that ensures that they give oxygen to the right patient at the right time, every time. I will now go to building a resilient critical care system in Nigeria. Nigeria has a large growing population with triple burden of diseases and a weak critical care system within a poorly functioning health system. This makes it most appropriate for us to discuss building a robust health system and a resilient critical care system. You will recall that we largely coped with the COVID-19 pandemic in Nigeria by shutting down most hospital services, with adverse consequences for morbidity and mortality. The pandemic revealed quantitative and qualitative deficiencies in staffing, equipment, and material resources. It also revealed high variation in the standard of care. The pandemic also tested the capacity of intensive care units worldwide. Despite increases in intensive care unit beds and the total shutdown of all but emergency services, very ill patients were at times unable to access needed healthcare. Outcomes were not universally favorable, nor was it constant across hospitals. Our past experience with Ebola and the COVID-19 pandemic have strengthened surveillance activities with the establishment of the National Center for Disease Control and Public Health Laboratories. However, the requirements for a resilient critical care system in Nigeria are yet to be met. For our health system to be resilient, we need to take note that our health system is also dependent on other interconnected systems such as water, power, transportation, and in present-day Nigeria, security. Critical care services will not function adequately without sufficient water pressure or when the hospital is dependent on generators for power supply. Resilience has been described in terms of robustness, that is the ability to maintain critical operations during a crisis and to cope with the ebbs and flows of critical care services. Resourcefulness, the ability to skillfully prepare for, respond to, and manage a crisis. Rapidity of recovery, the ability to return to normal operations quickly, and then redundancy, sufficient backup resources to support surges in demand. Like I said, my story was because there was no redundancy. A critical care system must be characterized by adaptability and flexibility to cope with major calamities such as pandemics, as well with the common flows and ebbs of different case mixes and patient numbers, from routine severe illnesses to mass casualty incidents like road or air crashes, terrorist attacks, or a pandemic. The system must function at all times, whether in emergency rooms or in critical and high dependency units, while learning from experiences and consistently producing good outcomes. In defining health system resilience, 4 S factors and an additional S have been proposed. These are staff, that's the personnel, the stuff, which are the consumables and equipment needed, the space, which is the infrastructure, and the system, the healthcare system and the critical care system. A 5th, which is the science, has been added to emphasize learning and research. What do we anticipate from a resilient critical care system? We expect it to anticipate, to respond, and to learn. Resiliency means shortened waiting times, adapting to increased case volumes, managing patients with high severity conditions, and then optimal use of resources. So, the core measures of resiliency would include intensive care unit and in-hospital mortality. Remember, I told you about how many patients died in intensive care and how many died in the general wards. Intensive care unit length of stay, rate of intensive care unit acquired complications, risk-adjusted mortality rates, how many patients were delayed or denied access to intensive care unit care, and adherence to evidence-based protocols. Because critical care is time-dependent, long hospital wait and delayed transfer times increase the risk of fatalities. Critical care services are interdependent on the capability of the hospital as a whole to function. Since hospitals cannot function without sufficient water pressure or when operating on generators for power supply, resilient critical care systems require continued, effective, and efficient interdependent services at the hospital. The need for accurate forecasting and modeling. Okay. To better cope with global health challenges or disaster events, there's need for us to accurately forecast and model our critical care scenarios. This will involve interdisciplinary collaboration between critical care physicians, public health physicians, civil engineers, and other relevant stakeholders. The society could lead in this regard. My recommendations. Having considered the state of Nigeria's health and critical care system, I will close with 6 concrete actions, not suggestions, not aspirations, but actions that this society, in collaboration with government and partners, can deliver. 1, define the national critical care minimum standard. This society should, within 12 months, publish a national critical care minimum standard document. I saw it in your program that you are launching critical care guidelines next week, so I think that's a step. The guidelines should specify bed-to-patient ratios, staffing norms, essential equipment list, and referral pathways. Every tertiary and specialist hospital should be accredited against it. Without a standard, we cannot measure progress. This will complement the national strategy for the scale-up of medical oxygen therapy in health facilities being facilitated by the Federal Ministry of Health and Social Services. Number 2, pilot the hub and spoke model. Within 18 months, your society should pilot a state-level critical care network where 1 tertiary care hub is linked to 4 or 5 secondary spokes using telemedicine with a short source of oxygen supply and a dedicated hospital transfer system using any of the cities. We need to show that this works in Nigeria, not just in theory. The primary care facilities should be linked to a secondary care facility, or in some cases directly feed into a tertiary care hub. Number 3, champion essential emergency and critical care. The WHO's package costs approximately $14 per healthy life saved. This society could train 500 frontline staff, nurses, doctors, and community health workers in emergency, essential, and critical care over the next 2 years, starting with people in general wards and rural facilities where most critically ill patients are currently treated. Number 4, intensify the push for critical care coverage under the National Health Insurance Authority. Critical care must be classified as essential care under the National Health Insurance Authority. This society has already made a case for critical care to be considered as essential care. Beyond this, your society should use data with advocacy and a clear financial model to show the need to eliminate catastrophic out-of-pocket payments for intensive care unit care. No Nigerian should have to choose between bankruptcy and survival. This is health equity. Number 5, establish a national critical care registry. We do not know for certainty how many critical and intensive care workers, how many intensive care unit beds, ventilators, or oxygen concentrators we have in Nigeria today. This society should establish and maintain a live open access national registry of critical care resources, updated quarterly. You cannot manage what you do not measure. Number 6, invest in local research, innovation, and industrialization. We need Nigerian models, not imported ones. Research priorities should include modeling and forecasting scenarios for critical care, use of artificial intelligence for triage in low resource settings, and cost-effective oxygen delivery systems, culturally appropriate care protocols, and the mental care of critical care staff. This society should partner with Nigerian universities and the Federal Ministry of Health to fund 5 implementation research grants in the next 3 years. You must aggressively advocate for local manufacturing of oxygen concentrators, ventilators, and consumables, reducing our vulnerability to foreign supply chain disruptions. In conclusion, Nigeria, a country of about 233 million people, has a significant proportion of young people, 70% below 30 years, and a steadily increasing number of the elderly. This demographic transition is associated with health challenges, communicable diseases, non-communicable diseases, injuries, violence, all seeking service from a sick health system. Critical care services in Nigeria share in these challenges with very low critical bed to population ratio. Mortality among critically ill patients in general wards is twice that of those managed in ICUs. We need to increase healthcare financing, address factors pushing healthcare practitioners out of Nigeria, reduce corruption, and alleviate health infrastructure deficits. I suggest that every hospital with at least 300 beds should have 3 critical care beds. However, since more patients receive critical care in general wards rather than intensive care units, we need to embrace the WHO's essential emergency and critical care damage. To have a resilient critical care system, our healthcare system must also be resilient. A resilient critical care system must be capable of coping with the ebbs and flows of daily function and able to scale up during surges in demand while retaining staff in optimal health. This demands a hub and spoke approach to national critical care that ensures that peripheral facilities link up with regional tertiary facilities for transfer of patients, information, and resources. The challenges facing critical and intensive care matter to all of us, whether we are clinicians or patients or potential patients, and the time to act is now. Acknowledgements, I acknowledge the chairman, I give profound thanks to the Intensive and Critical Care Society for allowing me to present this inaugural lecture in honor of one of Nigeria's finest clinicians, teacher, and administrator. I hope I have justified your confidence. To my Oga, distinguished Professor Bashino Gumbi, I thank you immensely for choosing and convincing me to present this lecture. I'm indebted to senior colleagues who read through drafts and improved this lecture by questioning my reasoning. I thank my present employer, the Vice Chancellor of the University of Medical Sciences, Ondo, and the staff of my office for providing the enabling environment and secretarial assistance. I thank, as one of my secondary school classmates here, Richard, I thank you for coming. I thank the members of the Association of Nigerian Army Doctors, and I thank other members, former and present members of the Nigerian Army Medical Corps. I thank the representative of the Corps Commander, and I thank you, the audience, for being part of this lecture. God bless the Intensive and Critical Care Society.
Thank you very much, the lecturer for today, Professor Ezekiel Adebayo. At this juncture, may I have the honor and privilege to invite the guest of honor, the former Chief of Defense Staff, General Lucky Irabor, to present a token to the lecturer. Well, thank you very much.
Speech.
Now it's time to go. The one is. You know you have to climb. Mountains. Living through. Eyes of your mind, peace and mind.
Please, special guest of honor, distinguished guests, ladies and gentlemen, our guest lecturer, I'd like to thank you so very much for that eloquently delivered lecture. I'm a soldier. I'm not a medical practitioner, but the way you delivered it, and from someone who has been involved in policy, both formulation and implementation, I thoroughly enjoyed and understood the lecture. I'd like to thank you so very much for what you've done. And in deference to what you've done, I've been tasked by the society to please present this to you. And I do hope that it will find a space, either in your home or in your office, that when you deliver this lecture, which was well understood and which be acted upon, especially those recommendations, that you feel good that you did a good job. God bless you.
I'll be waiting. I'll be I'll be waiting.
Well, distinguished guests, ladies and gentlemen, I've been compelled to say a word or two. And now that I'm privileged to be on this platform, I just thought that instead of going to sit down and come back later, that I do so now. So I hope I'm permitted. I want to especially appreciate the special guest of honor who has been honored today by the Intensive and Critical Care Society of Nigeria. I've always believed that honor is good. Honor dignifies. And it's even more so when that honor is bestowed while one is still in his right senses, in the right frame of mind, and still very strong. And so today, let me, on my personal behalf, since the special guest of honor is actually my colleague, I say my colleague, not in the medical profession, but as a soldier, so let me, on my personal behalf and of course on his behalf, thank the Intensive and Critical Care Society of Nigeria for this honor that is done to my friend and to my very senior colleague. On the lecture itself, which of course is building resilience in critical care in Nigeria, it's so profound. And I was taking down notes while sitting down there listening. And more so with the anecdote that he started with, which in my view also speaks to every sphere or every sector of our national life in Nigeria. And that shows very clearly that whilst we have abundant resources, human resources, that attitude is a little bit challenging, which I believe that every one of us need to take to be involved in to reversing that trend. And so I would like to use this opportunity to request, or if like, implore every one of us to be involved in social mobilization for us to have some form of social re-engineering within our society that will perhaps lead to attitudinal change amongst not just healthcare workers, but every aspect of our national life. Why many of the challenges that we now find today that manifest in various forms, security inclusive, is because we're tend to be a little bit careless or take certain things for granted. If the anecdote which I started with, that the lecturer referred to after the operation that was performed earlier on and the due care was taken to replace, I believe that that wonderful lady would have lived longer than she did. It's just a pointer to a good number of things that affect us. So on that note, let me also join to request the Intensive and Critical Care Society of Nigeria to also join. And I'm glad that the lecturer in his concluding remarks pointed to the fact that we've had some form of brain drain within the health sector. It's quite challenging. Whatever it's necessary for us to do as a people, as a group, as a society, I think we must begin to take concrete actions. I'm glad that the Senior Special Assistant to Mr. President in Health is here, so that collectively we begin to reverse that trend. On that note, let me once again congratulate my Egbon, the professor, as well as retired Major General, for the good things that you're doing. This honor that is being done to you, sir, it is not for you to rest on your oars. Rather, it's a call to greater action. And knowing you well, you will do more. God bless you.
Thank you very much, Chairman of the occasion. I want to use just a few minutes to call on the Special President's announced to help us present a plaque to our guest of honor, the General and the Professor. After which you say your goodwill message. With special recognition to the President of the Nigerian Society of Anesthetists, who is here in our presence, and our Vice President, Dr. Rene Kideresu.
My very senior colleague, far colleague, and a mentor, motivator. Since we met, you've been motivating me and encouraging us. So we appreciate you today on this very great day of recognition for the great work you have done, because it's an exceptional personality that he has from the military, which is well protected. He was able to build a career. And immediately after exiting from the military, he continued to do so and reaching this level in your journey. Sir, I congratulate you. And I believe without a woman behind you, a very strong one and an architect, very beautiful woman, this wouldn't have been possible. My sister, I congratulate you as well for the great work you have done. You are indeed worthy of emulation by many Nigerian women. So on behalf of the Intensive Critical Care Society of Nigerians and all Nigerians in the health sector, I want to present this award of appreciation to you. To you, sir, Major General Professor Obashina Ogumbi, MNI. On this occasion of the first Major General Obashina Ogumbi Lecture Series at the 11th Scientific Conference happening now in Abuja. Please join us, my sister. Thank you so much. Thank you so much. So I still start with you, Major General Professor Ezekiel Adeshina, and your amiable wife. I also acknowledge the General himself, General Irabo. I know your value, appreciate you, and I will continue to appreciate you. As I said earlier, I'm from Borno State. I've seen the impact of what you have done in Borno State and the Northeast and Nigeria in general. My distinguished colleagues in the medical profession, my senior colleagues, the Director General of the NCDC, who is here, who is also my mentor, and also the chairman, co-chair of the task force on Ebola. My own brother, you must have seen I hugged him when he came in as a Muslim sister. I hug my brothers, not just a handshake. And I'm proud of you. Dr. Oshota Choletiri, who is now a permanent secretary in the office of the head of service of the Federation. The eloquent speaker, you spoke very well. And I'm proud of you because even a layman will understand exactly what you have said. And this is truly a take-home message for all of us. So the International Society of Critical Care in Nigeria, I appreciate you. And this is happening at a critical time in our national history. As we all know, His Excellency, President Bola Ahmed Tinubu, remains very committed. When we drafted the policy direction of the president, before he came into office, myself and Dr. Jide Idris is here, who chaired the committee, and I was his deputy. I think one of the key areas we said, the vision was to attain universal healthcare coverage. But of course, no Nigerian should be left behind, including people in critical care. And we did receive a lot of inputs because we did a lot of engagement across the country. And I'm glad also that our senior colleague, whom we have started in the last dispensation, Dr. Gidembe, on the critical care. He actually was driving the emergency ambulance system, which is mainly about critical care and saving lives at the critical point of need for Nigerians. So I'm glad this we are taken forward, and it's currently being operationalized by the coordinating Minister of Health and his team. Dr. Sheridan played a key role in that. So we have added all, the journey is still on. I will not say we have achieved, it's still a long way, but this is a great eye-opener by the speaker to tell us as it is today in Nigeria, the situation it is. And what actually baffles me, you did mention that it's about 19% of those that truly need the care, that don't need the care are getting the care, while majority, which means almost 80%, that needs the critical care are not getting the care. And the expression in this hall was a laughter. So I want to bring it down to show how much we take what is important and critical in the health of Nigerians as a laughing matter. We all laughed, including myself, because this is how we express ourselves, Nigerians. Anything beyond comment, we laugh at it. But the critical aspect is to take action. We should be crying, because most Nigerians, nobody is spared from the need for critical care. And we never know when this will come. We have seen it all. So it's for us to change attitude, and the worst attitude you see is in the health sector, in our facilities, from the primary, secondary, and tertiary. A lot of you have traveled abroad one way or the other, especially we in the health sector. When there's an emergency, it's addressed as an emergency. You see people in the critical care panicking, running up and down. But when you walk into our facilities in Nigeria, you don't see that happen. So what is the issue? Is it still the laughter we expressed? That will not save the situation. So we have to take this this issue very, very seriously and translate it into concrete actions, because it contributes significantly to loss of lives. Because if you take just the aspect of it, children and the newborn, Nigeria still contributes one of the highest burden of death of newborn. And if you look at the statistic presented, we have remained stagnated. And the major cause of death for newborns in Nigeria is asphyxia, lack of oxygen. So what are we doing? So I think this is a wake-up call for all of us, this very important conference, and I pray that we'll put our heads together to address the issue. We've had a lot of lessons learned. The COVID has exposed the fragility of our systems, and it has also brought us closer, and it has also given us opportunity to do things better. And that is why today, because of what happened during the COVID, we have started establishing oxygen plants in majority of our hospitals in Nigeria, the tertiary institutions and the secondary institutions. But this is one aspect of our renewed hope health agenda in Nigeria. There is no hospital you will go today in every state of the Federation that does not have an oxygen plant. And the whole idea is to produce and distribute and create what he said, the hope and spoke model all across the country. So we look forward to all your collective efforts in the realization of that agenda. Thank you so much. And once more, congratulations, my very senior colleague, my mentor, my motivator, encourager, and counsel. Thank you so much, sir. Thank you, Nadim.
Thank you very much. The last part of this, first part of the ceremony, we don't, as a society, we don't take recommendations lightly. But we have to remember at the Port Harcourt meeting, when we had our AGM, Professor Dabrin Okaji, who was talked to us at the opening ceremony, made recommendations. So we don't take recommendations very lightly. So there are recommendations that were sent to our society, which we did something that we want to unveil now. So just spare us a few minutes. We'll call on our immediate past president, Professor B.B. Oshinaike, to show us the actions we've taken as part of the recommendations made at the last meeting. Professor B.B., thank you.
Thank you, Mr. President. Good morning, everyone. It's a great
privilege to stand before you this morning. All protocols duly observed. I want to thank all those who are here. We want to use this opportunity of this special day of honoring our teacher to unveil publications of our society. These two publications actually came on because of some lapses we observed, and majorly because a lot of people have been asking for this, practitioners. Practitioners, and in fact, today, Dr. Tai also mentioned it, that there will be need for policy document that will guide critical care, that will guide the price of critical care in Nigeria. And based on this, our society, the Intensive and Critical Care Society of Nigeria, has published two books, two guidelines that's going to guide our members in the practice of critical care and also in delivering a particular part of our care. Now, the first book is standards of critical care practice in Nigeria for our colleagues. And this book outlines the minimum requirement for infrastructure, equipment, human resources, clinical governance, patient safety, quality assurance, and other things. It was developed through multidisciplinary consultative process involving national and international experts. The document reflects internationally recognized best practices adapted to the Nigerian healthcare context. This book serves as a national reference for policymakers. We actually met the Minister of State yesterday and mentioned this to him, and he told us some steps to take for the Ministry of Health to actually adopt this as a national standard. So it will be used for healthcare institutions, regulatory agencies, professional bodies, educators, and healthcare professionals involved in critical care. This is the first book. Sorry. I wish it can be projected. You don't have a copy, so okay. So that's the first book, okay. And the second one is a guideline for management of brain death and death by neurological criteria in Nigeria. One major problem we have in Nigeria with care of some of our patients, especially those that end up with brain death, is the fact that going on with the care in terms of what do you do with the patient and the family is actually most of the time a concern to us. And other parts of the world have their own guidelines how to manage such patients. And a lot of our members have been asking, what are you doing about this in Nigeria? So what did we do? We gathered together professionals, neurologists, neurosurgeons, critical care nurses, we had lawyers, and we had some other professionals, and we sat together and we developed a guideline on the management of brain death and death by neurological criteria in Nigeria. So that is the second publication of our society. And we want to use this to honor our teacher and ask for his friends who are here to unveil these books on behalf of society. You can just unveil the account number of our society, and we won't mind if people can just send something to our account, and those who wish to announce can do so. So I don't know how it should go, but maybe General will help us with that, to call people to just do this on behalf of our society. Yes, sir.
Thank you so very much, Professor Shinaki, for this. Because of time, and once a soldier, always a soldier, I'm going to call individuals, and I'm sure they will not say no to me. In fact, one of this publication, I wrote the foreword to it because it's the seed started when I was president of the society. So if you want to read what I wrote there, I think you will say yes when I call on you. And of course, my brother, who is the chairman of this occasion this morning, I'm sure he will be the first person that I'm going to call on because I know he's worthy to do the best for healthcare. By the way, he has when he was chief of defense staff, he has a good heart towards the medical corps, and he's a soldier. So, General, please.
Well, thank you very much, sir. I remain very proud of you. I mean,
thank you.
And I'm going to support this with a little token within limits of what a retired general. But beyond that, I just thought that I should also say that for you as a person, I mean, you led your corps, but even your attitude, even whilst as a corps commander, you were still, going to the theater to do a run. And for some time, when you see, well, I'm only talking to those who are converted, so I'm just re-echoing what you already know. When you see him running, around the theater, you think that is perhaps somebody who just learned. But this is a wonderful work, and incidentally, I use UBA, so I'm going to do the transfer almost immediately. God bless you.
Thank you very much. No, we'll do together. Don't worry. So, stop this. So a few years ago, when we had the Ebola incident, Lagos was the primary place that the patient came in, right? The chairman of the committee set up for Ebola, anti-Ebola at that time, he's here. And I happen to be a member of the committee at that time, 2014. Please welcome me with me today, this morning, Dr. Jide, former Commissioner for Health Investors. Sir. He's presently the Director General of the NCDC in Abuja here. We'll call you appropriately again, sir. But I just want to recognize your presence, sir. Thank you so very much, sir. And of course, I know there's somebody here who taught me the art and science of administration of a corps in the Nigerian Army. He was my predecessor in office as Corps Commander Medical. Major General SOM, are you there, sir? And with him, I know the chap. Thank you, sir. I'll call you up afterwards. With us here also is our chairman of retired doctors, Army doctors, retired Nigerian Army Doctors Association. He's right here with us as well, Major General Tahir Umar. You're welcome, sir. For those of us who are here in Abuja, there's one hospital which everybody talks about, and that is Cedar Crest Hospital. Have you heard about it? Yeah. The CEO is right here with us, and he's one of my mentees, both in service and outside service. And I won't tell you what I did for that Cedar Crest Hospital, but Dr. Felix Ogedebe, he just stepped out. He will come back. Yeah. He has to take permission from me. And for those who know how we cherish our MNI badge, it's an institute where you don't apply to attend. You are invited by the government of Federation of Nigeria, Federal Government of Nigeria, to attend that institute, which is the highest think tank institute for Nigeria. And leading our pack here today is no other person other than Rear Admiral Francis Isaac. He's here. He's the retired Rear Admiral. So, and of course, presidency is also here with us. The president is here himself in the person of the senior special advisor on health, my dear sister, Dr. This is Anas Ibrahim. So thank you very much, man. May we all come to unveil this. General Mesa.
Right. So, to the glory of God, we unveil these publications of the ICN. Amen. Well, I think,
You can go to stage.
Yes. The chairman of the occasion, the chairman of this occasion, in the person of my very good friend, the officer, a distinguished military officer, and an astute administrator. It's indeed my pleasure this morning to say a big thank you to you for honoring me today. Particularly, I know you have a very tight schedule, but you promised and you are here. Thank you so very much. I'm grateful. I also want to say a big thank you to the Senior Special Advisor to the Mr. President on Health, Dr. Anas Ibrahim, whom we have come a long way. And the moment I told her that she's one of our special guests today, she blocked the date for me. Thank you so very much. God bless you. As I said earlier, my boss, who mentored me in the management of infectious diseases and administration of healthcare in Lagos State, the former Commissioner for Health in Lagos State, who is now the Director General of NCDC, Dr. Jide Idris, who has also honored us today. Thank you very much, sir. I want to say a big thank you to my good friend, Dr. Camille Shoretire, who is also the Permanent Secretary, Federal Permanent Secretary, Federal Ministry of Labor and Productivity. He's is also an obstetric and gynecologist. I want to today say a big thank you to my friend, my brother, who agreed with very little persuasion to be our first maiden keynote speaker at this lecture, the person of Professor Ezekiel Taiwo Adebayo. Thank you so very much for the very insightful presentation. And when General Rebo was talking about your presentation, as a policy maker and implementator that he is, may I say here that Professor Adebayo is a retired Brigadier General in the Nigerian Army. So thank you very much. He's a very distinguished researcher And myself and himself, we have come a long way as collaborators in the healthcare space and as well as in the medical corps. Thank you for all we did together in the quarters in those days and what we're all still doing today. We have a couple of articles published together in international journals, and it's a pleasure having you as our first keynote speaker today for this lecture. Thank you very much. Also, the chairman of the Retired Nigerian Army Doctors Association, Major General Tai Humar, who is here with us. He's also a very busy man. Thank you very much, sir. We are representing all of us on the platform, on the forum. God bless you, sir. And as I mentioned earlier on, Major General Elso Ame, who was my predecessor in office as the Corps Commander Medical, he taught me the art and science of administering a corps in the Nigerian Army. He was one of the, he's one of the longest serving corps commanders in the Nigerian Medical Corps, which is an elite corps in the Nigerian Army. Thank you so very much, sir. And my story started at the Methodist Boys High School in Lagos as a young boy. And over the years, I have learned something from the school, and that is the art of resilience in whatever sphere of life that you have found yourself. Today, the Methodist Boys High School Boys Association is represented here by no less a person than my classmates for the 5 years we spent together, 1971 to 75 in Lagos. And actually, there's a photograph during the video session that myself and himself, in our final year, one of our photographs was displayed there. Please welcome with me today and say a big thank you to him with a round of applause, Professor Soji Adesuba. Professor Adesuba is the immediate past Director General of NIPSA here in Abuja. He's a very wonderful person. He's the present Vice President of the Abuja Chamber of Commerce, making waves all over the whole place. Soji, thank you so very much for being here. God bless you, sir. And I want to say a big thank you also to my family. They have been there with me over the years. And particularly, I want to say a big thank you. They are even showing my family. That's my uncle, Dr. and Dr. Mrs. Teju Bolujoko. I learned from their feet growing up, and they are right there on the screen. Thank you very much, sir and ma. God bless you, ma.
Congratulations. We thank God.
And coming home, there's somebody who tolerated me when he was growing up. And he asked me one question when he was 10 years old, when we were living in the UK. He said, Daddy, why are you always reading book? And what have you? Every now and then you are writing something or the other. Don't you have time for us, your children? And that hit me so much. However, today he has seen the result of those books his father was reading. Please join me in saying a big thank you to my son, Mr. Olusoya Ogunbi. Thank you, Professor. He's a manager at the National Pensions Commission here in Abuja. And while talking about him, please join me to say a big thank you to his boss, who is also here to honor me, and the president of Professor Ibrahim Duwai from National Pensions Commission. Thank you very much, sir. We are very grateful. And I don't know how to say this. There's somebody who, when I met her, the very first day I met her, I knew that this is the person that God says I'm going to end up my life with. You know, for those who know me very well, as a young man, you know, over the hope they share, and they are also. Please, let me say a big thank you to my dear wife, architect Mrs. Bimbo Olubili, fellow of Nigerian Institute of Architects. here with us. She's also an author, The Military Wife. She's the author of The Military Wife that won the best book published in Nigeria in Channels TV Club in 2022. Thank you so very much, Nico, for being there with me, tolerating me over the years, in and out of service and thereabouts and so on. We thank you very much. Yes. And also today, I would not want to say thank you to everybody without mentioning somebody who has been supporting me spiritually. And when this thing came up, he said he must be here physically. And he came all the way from Lagos, surprised me, and I saw him this morning. Please say thank you to Pastor Nkem Akobundu. It's one of my pastors. Thank you very much, Pastor Nkem, for coming. That's a big surprise. And I want to say, I don't know how to say this. I was very emotional when I got a letter from the president of the Intensive and Critical Care Society of Nigeria, Dr. Job Otokwala, saying that they want to establish and institute this annual lecture series in my name, in my honor. Actually, I shed tears on that day. Because I'm alive today. I'm being honored this way. Dr. Job, I see, Dr. Job Otokwala is somewhere there, and the ESCO of this society. I want to say a big thank you to you. And like General Irabo ordered me, I will not rest on my horse, and I'll keep doing what I love doing best, bringing up intensivists and leaving a good legacy in training and service in Nigeria and suburbs by God's good grace. I want to thank everybody that's present online, especially my people from Namibia who are also online. Thank you so very much. I appreciate you all. So on this note, for everybody present in the hall today, thank you, and thank you.
Congratulations.
Congratulations.
Congratulations, Prof.
Thank you very much, everybody. As our special invited guests take their leave, we'll have a brief entertainment from the cultural troupe as we prepare to move into the opening ceremony. Thank you very much, our invited guests. Thank you very much. So the cultural troupe, prepare and make your way.
Reduce. I didn't keep just buy new private jet that you see me my grind reduce. I don't see who get before when I'm getting a why my brand was boost. My soldier the shiny boot. I don't even know anybody catch it. Boost from my jet escape is there, so I touch it. I just who there is money collect to be. I know that I'm feeling as I walk up west, not on my cake. Shake. I thought just very price, but we say no cost. We share good judge. Down the world, we know we are going to pick up. But there, don't get fresh. Yes, we the better. For me, I be walking on each other. And you move that's what I'm that's what I can't do that. That's what I can't do that. What's a change of the Eastern Cosmic United States? And I'm going to say about that very back
Thank you very much. Thank you. Thank you. A round of applause for the cultural team. Thank you very much.
Thank you very much. Distinguished ladies and gentlemen, permit me to stand on the already established protocol. My name is Dr. Ibrahim Bello. Ladies and gentlemen, can we please put our hands together so we make welcome our royal fathers? Your Royal Highness Alhaji Dr. Muhammadu Sambo Haruna, the Emir of Wasi. Please let's put our hands together for 100. And also His Royal Highness Abubakar Buba Azari, the Emir of Tula. Please let's put our hands together for them. Let's also make welcome in our presence Honorable Minister of State for Health, Dr. Isiaq Adekunle Salako. Very welcome, Honorable Minister. Also in our midst, Director of Hospital Services, Dr. Abisola Adegoke, MNI. You're highly welcome, ma'am. The chairman of the occasion, Dr. Olatishe. Please let's put our hands together for Doctor. Our keynote speakers for today, Professor Dapri Ogaji. Please let's put our hands together for. The NSC President, Professor Daffy Karim. Please let's put our hands together for Professor Mohammed Dati, NSA President. Thank you very much. And also Professor Elizabeth Onwafo. Please let's put our hands together for. And also Professor Sanusi. Thank you very much. All right, at this point, I want to invite our LOC chairman to please come and do this introduction. Thank you very much.
Good afternoon, all. Thank you for coming and welcome to I-CCSN 2026. Your Excellency, the Honorable Minister of State for Health and Social Welfare, Dr. Adekunle Salako, Your Royal Highness Alhaji Dr. Mohammed Sambo Haruna, the Emir of Wase, Your Royal Highness Alhaji Abubakar Buba Atare, the Emir of Tula of Gombe State, my senior colleagues, chief medical directors, distinguished guests, esteemed colleagues, ladies and gentlemen. Good afternoon. It gives me great pleasure to welcome you to the 11th Intensive Critical Care Society of Nigeria and AGM meeting, taking place at Transcorp Hilton, Abuja. Our theme this year, Sustainable Financing for Intensive Care Units in Public Health Facilities, Challenges, Opportunities, and Solutions, could not be more timely nor more urgent in Nigeria healthcare today. Across Nigeria, critically ill patients, whether from accidents, childbirth, complications, infections, surgical emergencies, desperately need access to well-functioning intensive care units. Yet, the truth is sobering. Many public hospitals either lack ICUs entirely or operate units that are poorly funded, understaffed, lacking essential equipment. Ventilator seats broken due to neglect. Skilled personnel are short supply. Essential supplies run out. And the expense of modern critical care far exceeds the public facilities receive. Now, this gathering is more than an academic discussion. It is a summons to act. We have brought together leading voices in intensive care, health administrators, policymakers to develop workable, lasting solutions to the ICU financing gap. Over the coming days, we will identify the underlying reasons for chronic ICU understaffing, examine creative funding approaches such as public-private partnership, insurance integration, diaspora investment, and blended finance. Learn from military hospitals, private providers, and global examples. And formulate concrete policy proposals for the Federal Ministry of Health and other decision makers. For this, we have carefully selected distinguished speakers and resource persons to challenge and inspire us all. We are proud to debut the Professor Obashina Ayodele Ogumbi Major General Retired Lecture, which just concluded series at this conference. As the local organizing committee, our heartfelt thanks goes to our sponsors and collaborators, the National Executive Committee of the Intensive Care of Nigeria, and all contributors who made these events possible. Special recognition goes to the chairman, Dr. Olaleko Olatishe, for his indispensable leadership. We are also deeply honored by the presence of the president of NMA, the minister, our royal fathers in attendance. As the LOC chairman, I congratulate my team who have worked diligently to ensure a seamless and rewarding experience. As we engage in these discussions, let us keep in mind that the frameworks and decisions emerging from this conference can save innumerable lives. Let us collaborate across professions and industries, taking advantage of the exhibitions and networking opportunities to create a Nigeria where quality intensive care is available to every citizen, regardless of geography or means. Thank you for joining this landmark occasion. I wish you a fruitful and energizing conference. Once again, Welcome to Abuja 2026 Critical Care Conference. Thank you all.
Thank you very much, sir. Can we please applaud Mr. Harrison Owogo one more time? He has been up and doing since the beginning of this event. Thank you very much, sir. Quickly, we are moving straight to the address by I-CCSN President, Dr. Job Otakwala. Please let's put our hands together for our president. Our energetic president. Please put your hands together for him.
Citation. Slides or citation. Is it his slides or citation? Okay, I'll speak.
The Honorable Minister of State Health and Social Services, the Emirs, Director of Health Services, the Federal Minister of Health, Presidents of the Nigerian Society of Anesthetists, Professor Dati Hassan, the Mother of the House, Professor A. Sanusi, the Medical Director of the Medical Center, Asaba, who is one of our colleagues, very distinguished ladies and gentlemen. I want to humbly welcome everyone to the 11th Scientific Conference and Annual General Meeting of Intensive and Gas Society of Nigeria. When we met at Enugu last year, where we discussed issues that do with cardiac anesthesia and cardiac clinical care, we decided to choose Abuja because of the relevance of the team that we have with us. And the team is basically a reflection of our experiences on a daily basis in critical units in public hospitals. That's the reason why we've chosen sustainable financing in public, intensive care units in Nigeria. What kind of model that works for everyone? We all know that critical care does not know boundaries. The rich, the poor could be ill and could be also be critically ill. We all know that critical illness is part of the continuum of the spectrum of illness. One can have chronic malaria and end up in intensive care units. And that is why designing a financial model that works for everyone is extremely important to us. Honorable Minister, sir, while we met you in your office, we are very grateful and appreciative of the encouraging visit that we had and the reception that we got. We highlighted some of the programs that we have as a society and the impact of these programs in advancing the practice of critical care in Nigeria. Like we said, everybody knows the role we played during the COVID-19 era. This we do on a continuous basis, while we have several other challenges that we are bound to face in the course of our practice. I want to humbly recognize the role played by one of the illustrious sons of this country, Dr. Latishe, the MD of Zenith Kidney Center. While we are trying to, I'm sorry, it's just working, you have to recognize it. I just mentioned your name, sir. And in spirit, you just walked in. Very candid, Honorable Minister, sir. I've never seen a Nigerian so dedicated, so patriotic like Dr. Latishe. We're trying to find out who could probably chair the opening ceremony, why we invited several dignitaries to come. We're looking for a suitable chairman, and incidentally, we got the most valuable chairman anybody could get. So Latishe took the initiative to bring us to a place like this. I'm sure we never anticipated to be at Transcorp meeting hotel. We never thought about it. Mr. Chairman, sir, we are very grateful to you as a society. We appreciate this pairing leadership that you offered us. Even when you are a nephrologist, you're not an anesthetist, you're not an intensivist, but you understood the relevance of critical care, and you decided to sacrifice your time, your resources to make this real. For those who are online, they appreciate the efforts you've made and the recommendations that they've made. We want to use the opportunity to also celebrate one of our very best, Professor Obashino Gumbi, and the contributions that he made. What it tells us is that in our society, we recognize the efforts, the sacrifices that people make to champion the cause of critical care in Nigeria. As a society, in addition to several plans that we have to champion this cause, we have earmarked certain prizes to celebrate and encourage the practice of critical care in Nigeria. We have prizes for the best public hospital intensive care units. This is to inspire MDs to look at critical care as an integral part of the practice of healthcare in Nigeria. We have a prize that every year we will announce, and we're informing the media to take it very seriously. We have endowed prizes in honor of our first president, Dr. A. Sanusi, which will be domiciled at the West African College of Surgeons. We have prizes for anyone who does what Dr. Latishe has done for us, who encourages the practice of critical care in Nigeria. We have a prize which we are naming after our immediate past presidents, Professor B.B. Oshinake. All these efforts are simple and tangible ways of encouraging people to offer their time, their resources to stimulate the practice of critical care. Like the last speaker, the speaker, for Professor Ogubiye's lecture said about the coupling of emergency and critical care. It does not hold any boundary. So for every effort, every sacrifice we make to ensure that critical care stays and the practice is sustained, we will encourage that. I want to use this opportunity to welcome everyone. We have very interesting lectures on data, management in critical care, how it improves critical care practices, on the Surviving Sepsis Campaign 2026, and we have eminent experts in the field of critical care from Nigeria. When you listen to all our speakers, they are the best in the world. Local speakers, international speakers, these are authorities who have designed whatever they're going to present to us. So we're not taking from secondary sources. I want to welcome everyone to this 11th scientific conference and an annual general meeting. Please don't get tired, don't get bored. We have a lot of activities that will inspire you to begin to love critical care. For our friends in the media, you share our objectives, our plans for the generality of our people. For whatever plan we have, whatever recommendation that we have, for the benefit of everyone. Thank you very much for taking your time to come. Please stay with us. We have today, we have tomorrow to serve everything that will benefit our practices. Thank you very much. God bless.
Well, thank you very much, sir. Distinguished ladies and gentlemen, please permit me to reintroduce our very own NSA president, Professor Al-Hassadati Muhammad. Please, let's put our hands together for one more time. Pardon me for the mispronunciation. The name was written by a doctor. I am a doctor, but I'm not a medical doctor, because their handwriting is like a telepath. If you are not in the system, you can't get it. Please put your hands together for all of them, please. Thank you very much. And also to Dr. Olalekan Olatishe, the chairman of this present occasion. Please let's put our hands together for one more time. You're highly welcome, sir. And to our royal fathers, Lafia Zaki. I should have done that first as a true northern man. Please let's put our hands together for His Royal Highness Alhaji Dr. Muhammad Sambo Haruna, the Emir of Wase. Please let's put our hands together for him. And also His Royal Highness Alhaji Abubakar Uba Atari, the Emir of Tula, Gombe State. You are highly welcome, sir. Thank you very much. Quickly, we'll move straight to address by, okay, it's not ready, right? Okay. Yes, we'll move straight to opening remark by chairman of the occasion, in person of Dr. Olalekan Olatishi, CMD Zenith Medical and Kidney Center. Please let's put our hands together for him.
Thank you very much. Good afternoon, everyone. I want to stand on the existing protocol. However, I still want to recognize the presence of our Honorable Minister of Health. We are happy to have you here, sir. Thank you very much for making out time out of your busy schedule to come for this conference. It's very important that at this crucial period, we should lay lay emphasis on critical care in this country so that we can improve our outcomes for our patients. I also want to recognize the presence of our Royal Highness, the Emir of Wase. Thank you, sir, for coming. The Emir of Tula, thank you so much for coming. We are just we're grateful to have you people here today to attend this great conference. This is the 11th Scientific Conference and Annual General Meeting for the Intensive and Critical Care Society of Nigeria. It's the 11th one, and it's my credible honor to stand before you as the chairman of this edition of our conference. Well, I know many of you have traveled from very far, far locations to be here, and we're extremely grateful to you for making that journey, And I want to also say that whether this is your first I-CCSN conference or the 11th one, you're welcome. Now, this is the 11th Scientific Conference and Annual General Meeting of the Intensive and Critical Care Society of Nigeria, Abuja, 2026. I want us to take a moment to reflect on what that means. The society started about 13 years ago, when a small group of anesthetists and critical care physicians came together and to promote critical care medicine and foster specialized education, address resource gaps. I would say that we still have that gaps, and I'm glad that we have the policymakers here who can really help us to close the gap and also connect with international bodies from those modest beginnings. Now that I-CCSN has grown into a true family, we have intensivists, anesthetists, physicians, nurses, and allied professionals working in the teaching hospitals, federal medical centers, and private hospitals like ours across the country. The I-CCSN has not only grown, they've also delivered. The society produces and manages systemic surveys to objectively map intensive care services across Nigeria. Also, they give up, of course, the policymakers had data where, and then before there were only antidotes Our bi-monthly webinars, these webinars take place regularly. I've closely connected world-class educators and also trainees. We support independent multi-center registries. I think that's very important. Let's have the data so that we can work closely with the policymakers. And also such as those tracking acute kidney injury, that's my own area of interest. And then of course, acute coronary events. And these are just the highlights of what the I-CCSN has achieved. Now, which brings me to why we are gathered today. The theme of this year is sustainable financing for intensive care units in the public health facilities. And then of course, the challenges, opportunities, and solutions. It's very, you agree with me that it's quite expensive to set up an ICU in Nigeria. I know that's how it is all over the world, but because we don't have these companies, I'm talking from experience, we don't have the likes of the big companies that manufacture ICU equipment in the country. So it means that we'll have to order each time, as against our counterparts out there where they just keep upgrading this equipment. As the new ones come, they take those ones out and phase them out. They have access to a lot of credits. They can sometimes do placements. We don't have such opportunities in our environment. It may cost close to $1 million to set up maybe 5 to 10 bedded, 10-bedded ICU in the country. That's a lot of money for government, for the private sector. So you find some of our equipments are behind, monitors, ventilators, and etc. They are quite expensive to set up. And these are some of the areas that policymakers can help in closing out gaps in the system. Also, I will also talk about, apart from the financing, I will speak plainly, financing is not an abstract policy question. It is the difference between an ICU unit that saves lives and the one that merely exists on paper. You have some of our ICUs not really in that position where you can say this is a standard ICU. And I'm sure that we have all had a direct encounter with patients and their relatives who have had to sell property just to afford one more day on the ventilator. It costs so much to have patients to get admitted to an ICU because it's quite an intensive area. And then of course, we have intensive care units without consumables. I think these are the things that we should look at in this conference, consumables and other critical supplies due to lack of financing. I would say government is playing its role, whether you like it or not. They've really tried. They are able to tell, okay, well, reduce import duties for health, medical equipment. Some of us are benefiting from it. And then the other thing I want to state here, not a politician, but I'll say it the way it is, the Honorable Minister is here. We've also found it easier to source for forex, to buy these equipment out there. It was difficult in the past because as I speak to you, Zenith is setting up a 250-bed hospital with a 10-bedded ICU. I knew what we faced a few years ago trying to source for forex, and now there's a difference. It's a lot easier, it's a lot more transparent. You don't have to know anybody from anywhere because I don't know anybody. So it's easier now. And I would say that because you're here. Thank you so much for making life a lot easier for us. Now, also, I would say that sub-teams on data in critical care, sepsis, and mechanical ventilation in low resource settings, very important. And of course, my sincere hope is that we will all leave this conference with solutions, and not just resolutions. We shouldn't leave here today and say, oh, well, these are our resolutions, but we should find true solutions to some of these problems that are around us. Now, this year, we also inaugurate the Major General retired Obashina Ogunbiyi, like I've been told, annual lecture, honoring a man whose contribution to our field, critical care, speaks for itself. Please do not miss it. And then let me also thank the local organizing committee. We've worked very closely together throughout a couple of weeks now on daily basis. Sometimes we meet even on Saturdays to make this happen. And then, so I must thank the local organizing committee for a good job. And also, we can also talk about thank the management of National Hospital Abuja. I don't know whether the CMD is here. Thank you so much for what all the support that you've been able to get. And of course, our speakers, partners, and sponsors, and the executives of our Society of Critical Care for their steady leadership. So ask the hard questions. Share what you know, make friends over lunch. I'm sure lunch is served very soon. And enjoy Abuja. It is going to be a memorable few days. Thank you and God bless.
Thank you very much. Please, we can do better. Let's give a sound round of applause. Thank you very much. Quickly, we are moving straight to goodwill messages. And permit me to invite Professor Dati to stand in for Nigeria Society of Anesthetic for their goodwill messages. Please put your hands together for Professor Dati.
Thank you very much. I want to stand or align myself with the protocols already established. Good afternoon, everyone. I want to say that the Intensive and Critical Care Society of Nigeria have grown rapidly, and that's because of the commitment of the ESCOs, past and present. Particularly my mentor here, Dr. A.E. Shanusi, who have trained most of us, to train others. So I'm sure they are happy to see what is happening now. The theme for the conference is very apt, timely, because maybe during the discussions we have a solution, what we think, what we can do. We cannot run away from Nigeria. Like the chairman of the occasion said, the government is doing well. But when you look at it, most of it is, we don't know what they are doing. We just go back and carry placards and so on. But when you look at it, actually you go back and say, when you point one finger to somebody, you're pointing like 3 or 4 to yourself. So you go and re-examine yourself. So that's what we should do. What I'm trying to say is that we should be collaborators, and then the policy makers, what we want. We don't have time to come out when we come knocking at your door, Federal Ministry of Health, Honorable Minister, create time to listen to us. I think whenever we come to you, you will see that we have things, actionable points, and then you can do the politics behind to get things through. So we want all of us to support each other, to collaborate, not to undermine each other. I know the society has been, and its members have been team players. As I speak to you now, we are developing the guidelines. This came because we needed to review our guidelines, the way we practice, the way we provide anesthesia and give critical care. So we've gone far, and this is, you have very senior colleagues looking at that, and we hope to circulate it and then later develop it into an act. So most members of the Nigerian Society of Anesthetists are members of the Intensive and Critical Care Society of Nigeria. So on behalf of the Board of Trustees, the distinguished members of the Nigerian Society of Anesthetists, I want to congratulate our sister society, the Intensive and Critical Care Society, of which I am a member, and for putting all this together and providing the platform to discuss ways and means of sustaining critical care, because whether we like it or not, there will be critical care will be there always. So we must find a way to sustain it in a more equitable manner. Congratulations once again. Thank you.
Thank you very much, Professor Dati. Quickly, I want to invite Society of Obstetric and Aesthetics of Nigeria, Professor Nwaso. Please, let's put our hands together for. Please, can you hear me from the back? Please put your hands together. Thank you very much. Please, can we clap for one more time, please?
If I had it my way, you want sunshine in the rain when it's pouring. You should give yourself to me, give it all. I just want to see you.
Good morning, ladies and gentlemen. I want to stand on the already established and existing protocol. I'm standing on behalf of the Society of Obstetric and Aesthetics of Nigeria. I'm the immediate past president. So on behalf of the Executive Board of Trustees and highly esteemed members of Society of Obstetric and Aesthetics of Nigeria, we congratulate the President and the entire members of the Intensive and Critical Care Society of Nigeria at the 11th I-CCSN conference holding in Abuja at this time. We also want to felicitate with the Society for having had launched the inaugural Professor Obashino Ayodele Ogunbiyi lecture series. And we have the honor to be part of this event today at this time. And we like to say that it was a great honor to see the honor of a pioneer of critical care medicine in Nigeria. As we continue to felicitate with the society, let us celebrate the partnership and collaboration that we have had with the society towards reducing maternal mortality in Nigeria and also in the well-being of the newborn babies with the pragmatic critical care interventions that the society has always been able to come up with. So I'm reading this on behalf of the society's president, Professor Simeon Olugbade Olateju, and he's sending his best wishes and kind regards. Thank you very much.
Thank you very much, ma'am. Well, the next goodwill messages. Society of Nigeria and Society of Specialists in Airway Management, Dr. Osazwa. Thank you very much.
Good day, everyone. I'm going to stand on existing protocols. I'm here to give a goodwill message from the Society of Specialists in Airway Management, Nigeria, to the Intensive and Critical Care Society of Nigeria. SSAM and I-CCSN are sister societies, especially because airway management is a fundamental part of critical care. And indeed, all intensivists should be good managers of the airway. The theme of this year's conference, Sustainable Financing for Intensive Care Units in Public Health Facilities, is an issue that every Nigerian intensivist is trying to solve. It is a problem that I personally feel strongly about. The Nigerian patients deserve much better than the status quo. As we deliberate and discuss and learn from each other at this conference, it is my sincere hope that we come up with a communique that can be shared with the Ministry of Health and all relevant stakeholders. It is Nigerians who will build Nigeria. If we want changes in critical care, we have to work hard, lobby, and fight for it. I look forward to learning and enjoying the conference. Thank you for inviting SSAM to be part of this. With regards from all of us at SSAM, I'm Dr. Mary Rose Osazwa, President, Society of Specialists in Airway Management, Nigeria. Thank you.
Thank you very much, Ma. Distinguished guests, ladies and gentlemen, before I invite for our keynote address this afternoon, I noticed some people are already sleeping behind, and we are all medical practitioners. Can we please stand up for like 60 seconds? I'm very sorry. Honorable Minister, you can sit, sir, but if you want to stand, please. I always have this strong belief, passionate about Nigeria, that's what we grow up listening to. Nigeria Go Better is actually happening. And our teachers, more especially from our schools, they used to tell us that all work without play make Jack not just a dull boy, but so ladies and gentlemen, talk to your neighbor, just a handshake. Tell them congratulations. Yes, that you are here this afternoon. It's a great deal. Congratulations. Dr. Kate, if you can hear me, congratulations. All right. Can we please put our hands together for the I-CCSN in collaboration with World Federation of Intensive and Critical Care? Thank you very much for all your work. So all our medical practitioners, God will continue to strengthen you and you continue to succeed. Somebody say amen. Please, we can sit down. Thank you very much. Now, quickly, I want to invite for the next keynote address, Team Sustainable Financing for Intensive Care in Public Hospitals in Nigeria. Please permit me to make welcome Professor Daprim Ogaji, PhD, FWACP. Please put your hands together for him, please. And before that, we'll listen to a citation to be done by our amiable Professor Dr. Rosemary Okoye. Please put your hands together for her.
Good afternoon, everyone. Please permit me to stand on the existing protocol as I read the citation of our keynote speaker, Professor Daprim Samuel Ogaji. Professor Daprim Samuel Tamuno Ojemi Ogaji is a distinguished professor of health systems and public health and director of the Africa Center of Excellence in Public Health and Toxicological Research, University of Port Harcourt, Nigeria. He previously served as head of departments of community medicine at the University of Port Harcourt Teaching Hospital and head of departments of preventive and social medicine at the University of Port Harcourt. An internationally respected scholar, educator, and health systems expert, Professor Gaji's research focuses on healthcare quality improvement, health systems strengthening, healthcare financing, access to health, access to care, health equity, patient experience, human resources for health, and the management of long-term conditions. His methodological expertise spans quantitative research, evidence synthesis, psychometrics, program evaluation, field trials, and implementation research. With more than 2 decades of experience in medical and public health education, he has played a pivotal role in developing health workforce capacity across Africa. He has led the establishment of 16 nationally and internationally accredited postgraduate programs and spearheaded the creation of the University of Port Harcourt School of Public Health and the World Bank-funded Africa Center of Excellence in Public Health and Toxicological Research, both recognized as leading centers for advanced public health training and research in Africa. Professor Gaji serves on several strategic academic and governance bodies, including the Senate of the University of Port Harcourt, the board of the School of Graduate Studies, and the board of the Center of Medical Research and Training. He has supervised more than 100 master's dissertations and over 30 doctoral theses, while authoring over 120 peer-reviewed scientific publications in national and international journals. He is the editor-in-chief of the Nigerian Health Journal and serves on the editorial boards and review panels of several prestigious international journals, including Patient Experience Journal, BMJ Open, BMC Health Services Research, Primary Healthcare Research and Development, and numerous other scholarly publications. He is also an accredited healthcare quality surveyor and reviewer for international public health accreditation bodies. Professor Gaji has successfully secured and managed several highly competitive research grants and international collaborations, including the World Bank African Centers of Excellence Impact Project, Wellcome Trust-funded initiatives, the French Development Agency Research Networks, and the European Union-supported Intra-Africa Academic Mobility Program. His leadership has attracted millions of dollars in research and capacity building funding to Nigeria and the African region. Beyond academia, Professor Ogaji has held several notable leadership and public service positions, including Vice President of the National Association of Resident Doctors of Nigeria, Chief Physician to the Governor of Bayelsa State, National Technical Officer for the Millennium Development Goals, Conditional Grants Scheme, and consultant to numerous national and international health organizations. A passionate advocate for universal health coverage, quality healthcare, and health systems transformation. Professor Ogaji continues to influence policy, research, education, and practice across Africa and beyond through his commitment to excellence, innovation, and evidence-informed decision-making. Ladies and gentlemen, please join me to welcome Professor Gaji.
Thank you so very much. Yes. Can I control my slide, if you don't mind? Yes. Let me do like others and stand on already established protocols. But let me recognize our revered royal fathers, as well as the Honorable Minister of State for Health, who welcomes us. I want to thank the association for this invite. I remember last year when we had an encounter, Dr. Job has always reminded me about another encounter 1 year from that time. And we see the reality today. I'm quite impressed to know that right in this room are very passionate and patriotic Nigerians. And we having to do this with an association whose leaders have been very, very proactive, in order to get things sorted out within the space of critical care and ICU in Nigeria. So I'm quite privileged, to join them in this regard. Today, I've listened to several other speakers, and so it makes my work very easy. And I would like to go straight to the point because I know that we are all converts of what we'll be discussing here today. However, we know that the conversation we are in today, looking at issues of sustainable financing, and on the one hand, and equity on the other hand, within the context of ICU and critical care is very important. And this is because we all know the Nigerian situation, that any one of us seated here can be a victim, either through an emergency down to ICU, and most of the time may even be unknown victim. And so whatever we do to make this work, we are doing it to make it work, not just for others, but for every one of us. So intensive care, we know, saves life. I've been a patient to Dr. Job, and I knew what he did and what the system did for me, which I'm forever grateful. We also understand very clearly that financing determines access to this critical intervention that saves life. And so this lecture looks at how we can be able to evolve a sustainable financing model that will ensure that everyone who requires critical care and ICU gets one without having to think about how and where to get the next funding, to get the care he or she requires. So it's very key to us. We all understand all the concepts around healthcare financing, which is actually looking at how we get the money, how do we pull it, and how do we allocate this money in order to guarantee access to healthcare. This lecture also looks at it within the context of public hospitals. I want to say this, that these are hospitals that are owned by either the local government, primary health centers, the state, the general hospitals or secondary health facilities, and the federal, which runs the tertiary healthcare facilities. But I believe that whatever we do here today concerns private healthcare practice as well. And this is very important. And so looking at the end of it all, which means we will have to develop resilient systems, that can take care of the challenges of today, as well as the threat of tomorrow. We need to think broadly and see how we can evolve that. And I believe that the human resource we have within this space have the capacity to do that, not for this generation, but for future generation of Nigerians. So this conversation is very important, like I did emphasize. And so we would also need to know that it's not tea party. The MD of Zenith Medical once just said that setting up a 10-bed ICU could cost as much as $1 million. If you heard him very clearly, $1 million is not 1 million naira. It's $1 million, which goes beyond $1 billion in current day terms. So that tells us that ICU is very expensive. It's not cheap. It's not cheap. What makes ICU expensive? We talk about the infrastructure. You have to get a building, a purpose-built structure, for ICU. We work in a hospital where I come from, where today they'll tell you something has failed, another has failed. I then remembered my dad's old car, that sometimes stops on the road. You understand? And the question is, do we keep fixing that bad structure? Or do we walk out boldly and say, no, we need a complete change? I'm glad to note that the association has developed their protocols, their guidelines, which is a first starter. And I'm quite appreciative for this effort. Apart from infrastructure is the issue of equipment. Sometimes I tell people the problem of equipment is not just the initial purchase. Honorable Minister, sir, we've had several federal government intervention, targeted at certain aspect of healthcare. that will give a lot of equipment to this facility. But 3 years down the line, we see that everything is gone. So getting equipment is not the only thing, but creating a support system that will ensure that this equipment are really maintained, and improved upon. I'm happy that the Director of Health Services or Hospital Services is here, because the teaching hospitals play a very critical role in ensuring, that they get systems working and they build resilient systems within the context of healthcare in Nigeria. And then, which appears a bit easier, is the consumables. What do they need? I hear that one of the essential consumables is oxygen. Oxygen appears simple, but can be difficult. I'm glad to note that the federal government has launched a policy on medical oxygen for all health facilities. The question is, how have we made or implemented this policy? How has it worked? As of today, the cost of oxygen in our hospital could go as much as 5,000 naira per hour. 5,000 naira per hour. And if you have a critical care patient that should be on oxygen, for up to 20 hours in a day, it means that they'll be paying 100,000 naira for a day, to have oxygen. And imagine that that person is on a minimum wage of 70,000. It means that the person has automatically been given what we call now economic euthanasia. Because the moment your money stops, care stops. So you don't even need any other distance. Your money determines how long you are going to live. Distinguished guests, this is a very unfair situation. And this is where it becomes so difficult to know, why are we Nigerians? And I believe from this conference, we evolve a system that will leave no one behind. Irrespective of the ability to pay, everyone should be able to get health care, including critical care, whenever they need it, however they need it, to the extent in which they need it, without having to think about the economic consequence that will have on them. That brings us to the core issue. In Nigeria, is health a public good? We understand the problem of health as a commodity. Many of us here work in hospitals, in private clinics. These are workshops. And in this workshop, we sell commodities called health. And we all know that health is not like other commodities, that runs within the context of a perfect market. And the reason for this is because nobody can predict when you fall ill, what that illness is all about, until we get the experience. And so it's important for us to understand that as policymakers, as decision makers, we must work towards ensuring that health is considered and is practiced as a public good in Nigeria. In that sense, no one will be excluded, when it comes to critical care and other health problems. Now, the big question about finance. And this is a very important question. If I look at myself now, maybe telling myself, look, I'm not going to fall ill, at least for the next 1 year. That is only a desire. Whenever we fall ill, it's unknown to us. The probability of falling ill goes beyond our mathematical calculation. Anyone can sleep today, and the next moment they say he has a stroke. From the stroke, he goes to the emergency unit, from the emergency unit to the ICU, and that's how the process goes until an outcome, which may be a full recovery or other outcomes like permanent disability or even death. Any of this can happen. And that is why we see that when it comes to ill health, the economic losses are unexpected, and they could be very large. Some people have some money in their accounts today, and then they can say, oh, well, I can afford healthcare whenever I need it. I'm sure if I ask the MD of Zenith Medical, how much does it cost to sustain 3 dialysis in a week? You find out that if you have to live for 5 years more with an end-stage kidney disease, you possibly will go broke. We see people sell their properties, sell their businesses just to prolong their lives. And that is the reason why we believe that issues about sustainable financing should be everyone's business. So in Nigeria, access to life-saving critical care remains largely determined by ability to pay rather than clinical needs. And I believe that this conference is set, to change that scenario. We know if we must come out from this conference with a strategy, that strategy should ensure that there is equity, there is efficiency, there is transparency, there is sustainability, and above all, there is financial protection, which means that no one will go into catastrophic health expenditure or become impoverished as a result of seeking health care. This is our goal. But however, if we wait for government alone, we have to wait for a fairly long time. Sometimes people believe that, oh, government have all the resources. Government does not have all the resources. I'm very sure that the budget for the Ministry of Health may not equate to the budget of one hospital overseas. Several years ago when I was in Helsinki, the budget of University of Helsinki as far back as 2006 was €1 billion. €1 billion, you heard me. And that, I don't think the Ministry of Health with all kind of funding, when it comes to healthcare, we're looking at all what happens, whether from the ministry, from government budget or from other sources. I don't think we have that. And because of that, we are faced with the stark reality. How do we improve efficiency? How do we, and that's efficiency can be the technical aspect or the allocative efficiency. How do we ensure that the funds go to what we consider to be the greatest needs? So low and medium income countries like Nigeria face many difficult challenges like this. The challenges of meeting the healthcare needs of their population, and also the challenge of mobilizing sufficient financing in an equitable and affordable manner. And lastly, the challenges of securing value of these scarce resources. Securing value of these scarce resources. I've lived and I've worked in Nigeria for a long time. I don't see government at all levels declare their report card. From the federal ministry to institutions like the teaching hospital, an annual report card that will show people this is what we got and this is how it was spent, so that we can be able to know, has the money been spent on the right things? Have we got the right result? Has every dollar spent in this country given us a mileage towards achieving universal health coverage and other goals we have decided to? So this is a big issue we need to address as healthcare managers. Needless to say that the current state from the report from the studies done by the Association of Critical Care Practitioners shows a dismal report of the state of critical care in this country. If you look at it very carefully, you will see that the critical care bed per 1,000 population is 0.9. If you look at it carefully, you will find out other dismal issues. And if you compare it to developing countries, or even to developing countries like Ghana and all that, you will see that Nigeria is still far behind. And all these are big issues which I believe the association is looking inward very seriously to see how to address them. So the question will now be, at the moment, when it comes to public hospitals, how do we get our money? Where do the money come from? I know many CMDs visit Abuja every day. If every now and then they're in Abuja. And this is because they're either called to come and defend a budget or to come and collect whatever. And because of that, we see that government budget at the state and national level are a major source of revenues, for our public hospitals. We see that as insurance is growing and more people are getting covered, insurance is also becoming a great contributor, to the money that we spend. But by and large, the greatest part, as much as 75% of revenues that we use for health comes out of people's pocket. This is not good for a supermarket like the hospital, where people come and they pay cash and carry. Anytime you need it, you put hand in your pocket, you pay the money, and you get the service you get to the extent you are able to pay. And I think that is where we want to reverse. The good thing is that we also have donors. Donors are here and they're happy to be with us, and they have a role to play. And the question will now be, what about this money we talk about, the internally generated revenue from what people pay? It's also a significant part that needs to be looked into, as well as corporate, bodies. But the current system I've just shown is not sustainable. We cannot take it for too long. And it's important we know that. I heard in a story, if it's true, that sometimes budget and budget release are two different things in Nigeria. It may be in the budget, but the money will not be released. And one of the things I know sometimes that is affected are things like health. Defense may say, oh, well, we are well off and so on, but health is always at that receiving end. At this point, if you want to think about innovative financing, where do we look to? And what do we consider to be sustainable in that context? So we understand this very clearly from this slide, that late budget release or non-release of budget, a weak procurement system, are issues that we need to consider if we keep going for paycheck from the Honorable Minister every month. We will look outside of that. But if we don't look out of that, and this is very important, if we think that we don't want to look away and see how to evolve a sustainable financing system, the economic consequence of inadequate financing is very there, both for the patient, for the hospital, and for the government. For the government, like I did say, if we don't look into that, we'll have poorer population health. And we know productivity is linked to health status. So if you have a professor that is on the ICU bed and poorly managed, comes with a permanent disability, the question will now be, how useful will it be? Or what are the losses to the nation from the loss of functionality of that professor, as the case may be? This is something that is considered an economic issue and not just a health challenge. So we all need to look at it very importantly. But again, when we now say sustainable, not a one-off, not a government intervention like we see, a one-off thing either from the Senate, constituency vote, or from government budget, or from interventionist agency, we look at it as sustainable. What that means, I have defined in 5 phrases. It means providing enough money, number 1. Number 2, that money should be continuous, year in, year out. Number 3, it should be reliable from a predictable source that you can bank on. Number 4, it should rely solely on, it should not be solely on systems we know are limited. Because most times when we say, what is the solution to this? Say, government, basic healthcare provision fund. You understand? That should not be. And then while we maintain this, there must be consistency in the quality of care that is provided, meaning that there's no compromise. At the global picture, different financing model. We have different finance from the tax-based model, which is operational in countries like the UK, to the social insurance and payroll-based model you see in Germany and major part of Europe, to the national health insurance model you see in Canada, to the out-of-pocket that is common in Nigeria, and then the mixed method, which is the plural method, you find the US and in other countries, including Nigeria, because we do that a lot, the mixed method. How does each of these methods affect some of the core attributes we are discussing here today? Now you will find that very clearly. On the issue of equity, efficiency, financial protection, you will see each of them how they, so that by the time we start thinking, what mixture are we going to bring into ensuring we have sustainable financing in ICU service? We will see all the pros and cons.
and be able to tailor just like a control knob. We say, okay, we're going to change the knob this way, that way, that way, that way, to get what we call the Nigerian solution to sustainable financing, for ICU services. I've taken a lesson from some major leading countries that have done very well, including from Africa, and lessons we should learn. Let's take, for example, Nigeria improves its tax drag net. I heard people say, the problem of Nigeria is not our debt burden, but it's our revenue. So assuming we succeed with the new headsman in power to get more money from tax, and assuming the government decides to say, from today we start funding healthcare through taxation, we need to also understand that countries like US with the NHS are having a hard time, a very hard time. As a matter of fact, some countries spend as much as 35% of their GDP on health. But because their political ideology is tied to that, there's no way they could go away from that. Any political group that says we want to tinker with the NHS, you're already a failure. Is that what we want in Nigeria? And if we must do it, how do we reinvest ICU funding from the budget? How do we ensure that what gets out of the budget, there is a provision that is assured to take care of critical care? Same thing goes with the tax funding system in Thailand, or the community-based health insurance, or the social insurance and all that. We can learn a lot of examples, from all this. But what is known in Nigeria, which we don't need to repeat, by doing further experiments, is that a market-driven, privately financed health system will not give us universal health coverage. In other words, private insurance is not the solution for us. As long as you're looking at financing that is sustainable and is equitable, then private health insurance is not an option. Government needs to force the healthy, wealthy to cross-subsidize the sickly poor. As of today, the National Health Insurance Act spells it out that insurance is mandatory, meaning that by law, everyone must be insured. The question is, what is the level of implementation of that? User fee, which is out of pocket, is the worst form of insurance. It's the worst form of area to do that. Nigeria started it when we had the Bamako Initiative, and we thought that was good in 1987. But as of today, other countries have left us, other countries in Africa. And I believe that we must also show leadership by moving away from this. What we work to us is public financing, and that will have a mixture of financing model from the tax financing and the social insurance, and that to us is key, to ensuring that we have universal health coverage. As we look into the solution here this morning, I want to say that a nation's commitment to saving life is measured not only by the hospital it builds, but by its resolve to keep every bed, every machine, and every critical care team funded long after the ribbon has been cut in the process of commissioning. And in doing this, we must see, how do we move from here? Sometimes we may look into the basic healthcare provision funds. Now, the basic healthcare provision funds are today guarantees 5% to emergency medical treatment. 5%. That 5% covers pre-hospital care as well as initial stage of emergency care, which is poorly defined, but usually said to be 48 hours. In 48 hours, somebody would have moved from emergency to ICU. Now, theoretically means that all that is covered. The question, if you look at the criteria for financing model, if you stop after 48 hours, what are you telling the person? It's a difficult thing to do. Honorable Minister, we learned in medical school that if I go past the road, Abuja Road, and I see somebody injured, I may decide to look away as a doctor. But the moment I turn and decide to do a supererogatory service of taking care of that patient, I must ensure that I take care of that patient until I am able to hand over that patient to another competent authority. Now we have to ask ourselves that question. What was the intent of government to say emergency care should stop at 48 hours? Is it because Nigerians are not credit worthy? Or because we know that because people are impoverished, they will not be able to pay? We need to rethink that very carefully. And I believe we can. And that is an aspect of the basic care provision one we could extend to ICU care in this country. And then we see all that also play out in all the challenges we are going to be discussing. I'm going to move right this through very fast, so that we have the slide, we can look at it. So when it comes to money, theoretical options from the cube phenomenon is that we have started with something which is good. How do we improve the width, the breadth, the length? In other words, how do we cover more people? How do we cover more scope? You understand? And how do more people come into what we are doing? I think these are policy and programmatic issues that needs to be resolved, in this country, especially when it concerns healthcare financing. And so if we look into the current options we have, which cuts across the government, insurance, the public fire policy, and all that, how do we make it work for ICU? And as we end this thing, I've shared here what PPP can do for us. And this is something we need to look into. But there must be deliberate policy to ensure that PPP works. We see many PPP models in our hospital, that are actually not properly done because of pecuniary interest. The ministry needs to evolve systems and policy that will guide PPP, especially for intensive care in our system, because we know what happens. You fix an oxygen plant today, and tomorrow is no more. How do we guarantee that? Private sector has a big role to play to ensure that there's efficiency within the system. Quite a lot of policy recommendation as well, especially how we can strengthen the basic healthcare provision fund to see how to scale, along the cube phenomenon I have said, and also how we can invest in critical care workforce development. I'm happy that the association is doing something about it. How do we invest, and how do we reduce, issues around, migration of this thing? And then when it comes to leadership of all this innovative plan, I believe that everyone has a role to play. It's not only on the government alone, it's not on the association alone. Everyone has got a role to play, from the hospital managers, to the professional society, to the private sector, to development partners, and to researchers. And so in doing that, we must look at the pathway to sustainable ICU financing in this country. And I brought a logic for that. The logic is that if Nigeria as a country mobilizes and pools public and insurance funds for ICU care, and if these funds are used to purchase a clearly defined ICU benefit package from public hospital like the association has been able to design, and if the poor ICU patients are protected from upfront payment, another if hospital receive predictable financing, for ICU to cover the cost of all the needs, then ICU services in public health facility will become more affordable, more reliable, and more equitable. And this will lead to reduced catastrophic spending, improved survival, and stronger progress towards the attainment of universal health coverage in Nigeria. I have listed a couple of interventions. I'm afraid if you can see that slide, but it's on 5 pillars. The pillars, number 1 is on strengthening governance and accountability. To us, this is a big issue. And then we look into the issue of enhanced revenue for ICU services. Now, each of these interventions have been staged: immediate, which is short term, medium term. Immediate is 2 years. And I'm sure it's within the administration of Dr. Job and his ESCO team. So who are you responsible if all the short-term interventions are not done? Now, the medium term is up to 5 years, and then the long term is 10 years. We expect that some of these things, you've already done that. For example, defining the minimum ICU packages as a national standard. I just heard that has been done. You tick it, good. And so if you're able to do all the first year thing and you know how many you've done within the next 2 years, you can score and assess yourself. Because as an association, you must be able to galvanize public interest, the interest of stakeholders, to ensure that critical care, sustainable financing, and equity for critical care are maintained. I'm not going to give a lecture on all of this point because I'm going to leave you with each of them. But if you look at issues of developing a national critical care strategy, it seems that that has been done. To define minimum ICU care, service package and national standard, again, you have done that. And I'm also happy that the federal ministry is ready to adopt that if you properly channel it to them. And then also to integrate ICU into the USC agenda. That is what we must all be talking about. The USC, the Sustainable Development, requires that no one is left behind. And ICU should not be left behind when it comes to the USC agenda. And we have all the interventions that are carefully packaged. These are not things that are so difficult to attain. Issues of building regional ICU hubs, or issues of linking up all the secondary health facilities to tertiary, they are not difficult with proper leadership. And I trust that just like last year, you were able to make all the recommendations that were said. I believe that in your next year conference, we will say that many of these recommendations have been met. On that note, Honorable Minister and our revered father, President of the Association, I want to rest my case. Thank you so much for the opportunity.
Please, can we give him a standing ovation, please, everybody? We can do better, please. Just put your hands together for him, please. Thank you very much, sir. I want to quickly invite. Yes, sir. Chairman, sir.
Just a few minutes, just 3 minutes. This is a fallout from the guest speaker, from the speech he gave, or the presentation he gave. It's been a wonderful one. It's a very good one. It's an eye opener. That was a very powerful presentation. Very nice one and well set out. Now, this is a fallout from your presentation. I was just taking it. I wanted to draw the attention of the Honorable Minister. Since he's here, I will mention these few things, and I think it will help us in financing. Honorable Minister, it's very obvious in our country that a lot of the wealthy people are not interested in investing in the health sector. They would rather take their monies to oil and gas and banking. So the question is, because there's no way in the world where government funds everything. It's not possible. You don't even have, in fact, when you talk about this developed world, you look at how they fund health care. They put those monies in the health insurance scheme. That's where they put their money. You don't have government running hospitals. In the US, for example, they are policy makers and then they put those monies, so it's private sector driven. How do we get our rich Nigerians to get involved? I have some suggestions, it may help us. If it is possible to have some tax waivers for wealthy Nigerians who invest in the health sector. If you bring your money into the health sector, give them some tax waivers. I mean, from those investments. Of course, if they invest in oil and gas and all that, government will tax them. But if they know that whatever fund they are bringing into the health sector, they will have some tax waivers on it. Maybe it will encourage them to invest, because the whole idea of financing is going to be done by it's going to be driven by the private sector. And that's one of the things that we may consider and then look up and think about it. We cannot have 230 million Nigerians, depending on very few ICU centers across the country. They are not readily available. And the reason why is capital intensive and it's driven by money all over the world. I could remember going to a hospital to visit an ICU in the US, Chicago, just few weeks ago. And before seeing the patient, I met one of my colleagues there and I asked him, how much is ICU admission here per night? Sir, he said $15,000. One night to stay in that ICU. So it tells you that it's expensive anywhere. The next question I asked him, do people still die here? Because if I pay that kind of money, my relative must not die. That was what I told him, jokingly. And he said, of course, people will still die. So ICU, critical care is expensive all over the world. It needs funding. And government will have to look, because government doesn't have all the resources. They have to look out for how to. And then the speech that was given, he mentioned the wealthy, the healthy wealthy, to cross-subsidize the poor. That's one of the ways. Let them bring their monies into the health sector. And then that's one of the things that I thought about. Then energy support for hospitals, very important. Most of those ICU equipment, they are damaged by uninterrupted, poor interrupted power supply by AEDC or Lagos, whatever. So there may be need for us to take out all our ICUs in the country off the grid. And I don't know where the ministry will come in. It's possible. Just the ICU, the units, because those equipments are quite sensitive. And then that's why there will be intervention in the health sector. You provide the funds, you supply those equipment. Within 1 year, they are destroyed. So it's possible to have all ICUs taking some energy support, some solar energy for our ICUs across the country, whether it is private or government. It will go a long way. Then, of course, still talking about financing, you cannot use a 27% commercial bank interest rate to fund health sector. You'll be in trouble. I'm talking from experience. It's not possible because you now have to bill patients, very high rate, and then I don't think that's the whole essence. So there was a time the CBN intervention loan came. Some of us were able to access it. A lot of the small hospitals were not able to because the CBN will still run them through commercial banks. And they'll tell you, go and bring a house, go and bring a land from somewhere as collateral. It's not possible. So these are some of the areas that I think, of course, DOI and the CBN intervention will help to sustain the financing. And then, of course, if we look at it again, of course, the health insurance scheme will have to be strengthened. That's where the funding for government will go. That way, you protect the poor who may not be able to have payout of pocket to still access good health services. Yes. Again, maybe tax waivers and, like I said, energy support for our government hospitals. You find out that sometimes the electricity is not even there. Some of our teaching hospitals can benefit from those solar systems if they are possible. Thank you very much, sir. At this point, I've been asked to call our Honorable Minister to take this award of appreciation to Professor Daprim Samuel Ogaji. I also want to thank you for an excellent lecture. Thank you so much.
Thank you very much. Prof, on behalf of the Intensive and Critical Care Society of Nigeria, I think that what you have delivered is what I call a critical lecture and a critical care conference. And of course, we have taken very good note of all these recommendations that you highlighted. But it's important that we also appreciate you
And on behalf of the society, I present this to you as a token of the appreciation.
All right, thank you very much. Please, Honorable Chairman, don't go. Permit me to invite the President, I-CCSN, to please come and present to our Honorable Chairman. Thank you.
Most admirable Nigerian, most patriotic, supportive, inspiring leader that I have not seen, but I've seen you today. Like we told you yesterday, I should remember those by childhood song. You know, what can we give you? You're a big man. You have money much more than our society. And the song says, if you were a shepherd, like amen, I'll give you land, give you sheep, I'll give you too many things. Our society appreciates this unique gesture you've offered us. Your time, your money. Even you be, I'm sure you're losing something over there. Thank you very much. This is an appreciation for all the efforts you've made to make this conference a reality. Thank you very much. Congratulations, sir.
And to hate you, I still waiting. We are not waiting for life.
This Major General Professor Kumbi. Okay, we want to give one of our award being to one of our own, the MD of Sorry, our royal father wants to leave, so I will give you just a few minutes to say one or two words of encouragement to us before we call on the minister to declare a conference.
Afia Zaki.
Your Excellency, the Honorable Minister of State for Health, on behalf of myself and my brother, the Maitama, we want to apologize for breaking protocol. We all know, as royal fathers, that there are laws that have been established, and based on the protocol list, we ought to have met us here. We truly apologize. In that same light, we are also apologizing for leaving early. As you are fully aware, we are all not from Abuja, and we come from far places. For instance, he's 9.5 hours away. I'm 7 hours away from here. So with the kind permission of the Honorable Minister and the chairman of the occasion, immediately after my keynote address, we will be leaving. I hope you have your permission, sir. Distinguished chairman of this occasion, Your Excellency, the Minister of State, the President and members of the Intensive and Critical Care Society of Nigeria, representatives of the World Federation of Intensive Care, Critical Care, eminent medical professionals, invited guests, distinguished ladies and gentlemen. I am pleased to join you today as the Royal Father of the Day for this important international conference. I commend the Intensive and Critical Care Society of Nigeria for convening this around the vital theme of sustainable financing for intensive care units in our public health facilities. This is not merely a medical issue. It is a matter of humanity, equity, and national development. Critical care touches every home, every community, and every part of our country. When life is at its most fragile point, the availability of well-equipped intensive care services can make the difference between life and death. I therefore urge government, the private sector, health institutions, development partners, traditional institutions, and all people of goodwill to support practical and sustainable solutions that will strengthen critical care delivery in Nigeria. I also pay tribute to our doctors, our nurses, intensive, how do you pronounce this word?
Intensivist.
That one.
Intensivist.
My doctor is not that of medical. It's for Turanchi, that is talking. Hospital administrators, and all the frontline health workers whose dedication continues to preserve lives under very demanding conditions. May the inaugural professor and Major General Ayodele serious lecture inspire knowledge, service, and a lasting reform in our health systems. On behalf of the Wasai Emirate, the Tula Emirate, I offer our royal blessings for the successful deliberations. May the Almighty Allah guide you. May the Almighty Allah guide your discussions, reward your services to humanity, and grant Nigeria a stronger, more compassionate, and more resilient health system. Thank you. God bless you all and the Federal Republic of Nigeria. We are fully aware that when I seek for permission, the Honorable Minister did like this. In our context, that means yes. So thank you and God bless you all.
Thank you very much. Please, can we all rise for the Royal Father of the Day as they take their leave? Lafiya Zaki.
That's one of the give him that people to
Thank you very much, DJ Sagzi, for a wonderful job. Please, you can sit down. Thank you very much. While our invited guests are taking group picture, I introduced earlier that my name is Dr. Ibrahim. Thank God, His Royal Highness just debunked everything that we are doctor for talking. I took a step out to ease myself and somebody approached me that he's having a running stomach. And I couldn't think of any medicine. I said, okay, go and ask of a Kulomapy tablet. Please, there's a message I want all of us to take home as we are striving for a better ICU. We can as well tell our people to stop taking Agbo. All right, quickly, I want to invite our guest of honor, special guest of honor, Honorable Minister of State for Health and Social Welfare, Federal Republic of Nigeria, Dr. Isiaq Adekunle Salako, for his address. Please put your hands together for Honorable Minister.
Please, let's sit down. The chairman of this occasion, who is also the Chief Medical Director of Zenith Medical Clinic Center in Abuja. I must say that you are one of the professionals that we continue to see and value, and also based on the kind of thing you are doing, become assured that the 1 trillion economy that President Bola Ahmed Tinubu wants to create, the health sector will have a big chunk of it. Let me especially thank you for those testimonies that you gave. And then let me also say that Nigeria is on a trajectory. And for those of us that God Almighty has given the opportunity, the exposure, and who has been able to acquire some level of knowledge and discerning, to be discerning, we must chest out so that that trajectory is not disrupted. If you throw a stone, it's like throwing a stone towards a board. And of course, it's going to take some time for the stone to hit the board. If you disrupt that trajectory, of course, the board will escape. So I want to assure us, permit me, I'm sorry, I'm not politicking, even though I'm a politician. But honestly, I'm not politicking. When the president and his team met me, they met me only yesterday to canvass me to be part of this. I told them that first, what they are talking about, critical care, is really critical. You know, and for me, as Minister of State for Health, what else will I be doing other than to attend to something really critical? So, and that is why I had to prioritize my attendance here today. So, distinguished ladies and gentlemen, as we go out, a lot has been said. I'll just quickly run through my speech. But let me also recognize the Director of Hospital Services of the Federal Ministry of Health and Social Welfare, the President of this society, and of course, our very eminent keynote speaker, who gave a very thorough analysis of the landscape and also made very, very good recommendations that I assure you that we're going to take a critical look at. I recognize all eminent personalities, all members, stakeholders in this very important subsector of the health sector. Gentlemen of the press, distinguished ladies and gentlemen, let me, of course, also recognize the chairman and members of the local organizing committee, who I'm sure have done a very good work in ensuring that this is put together. It is therefore with a great pleasure that I join you today at this opening ceremony of the 11th Annual Scientific Conference and Annual General Meeting of the Intensive and Critical Care Society of Nigeria. On behalf of the Federal Government of Nigeria and the Federal Ministry of Health and Social Welfare, I extend warm greetings and congratulations to the leadership and the entire membership of I-CCSN on the hosting of this important scientific and professional gathering. Let me also commend the society for its sustained commitment to advancing intensive and critical care practice, professional education, research, policy development, patient safety, and quality improvement in our country over the years. The society's continued efforts to bring together healthcare professionals, policymakers, researchers, institutional leaders, and other stakeholders provide an important platform for addressing some of the most pressing challenges confronting the care of critically ill patients in Nigeria. The relevance of this year's theme, sustainable financing for intensive care in public hospitals in Nigeria, is both timely and compelling. It draws our collective attention to one of the most important trusts that can strengthen our healthcare system: how to ensure that every Nigerian who becomes critically ill has timely access to appropriate, high-quality, life-saving care without exposing such individuals and their families to catastrophic financial hardship. Critical illness does not discriminate. It may arise suddenly from trauma, severe infection, maternal and neonatal complications, surgical emergencies, cardiovascular diseases, neurological conditions, respiratory failure, complications from non-communicable diseases, epidemics, or other public health emergencies. When critical illness occurs, the availability of accessible and quality of intensive care service can determine the difference between life and death, recovery, and permanent disability. The federal government of Nigeria recognizes that strengthening emergency and critical care service is fundamental to building a resilient, equitable, and responsive healthcare system. It is also essential to our broader national objective of improving population health, universal health coverage, strengthening national health security, and ensuring that Nigerians have access to quality healthcare services when they need them most. Ladies and gentlemen, sustainable financing remains one of the greatest challenges confronting the development of intensive and critical care services, particularly in our public health institutions. Intensive care is inherently resource intensive. It requires purpose-built infrastructure, adequate bed capacity, highly trained multidisciplinary healthcare professionals, reliable medical oxygen systems, mechanical ventilators, patient monitoring systems, essential medicines and consumables, diagnostic services, biomedical engineering support, uninterrupted utilities, that's talking about power, and effective systems of clinical governance and quality assurance. Let me say that the challenge of power, which the chairman highlighted, is one issue that is running through the whole of the health system. And you'll see that a number of our hospitals spend in the neighborhood of their 50% operating costs on a monthly basis just to power. The federal government has decided to address this. And one of the things that we have done is to create the Power for Health initiative, which is basically, thank you very much, which is basically first to harness more robustly government intervention in the power sector and drive it towards the health sector. That's one. The other thing is how to now mobilize social investment from the private sector, from development partners, from impact investors into the health sector to support the powering system of our facilities. And only about a month ago, we had an investment matchmaking in Lagos, where quite a number of federal tertiary hospitals were present with investors who are willing to. And I hope that with the way we're going, clearly we will be able to do some reasonable improvement in the power supply in our hospitals. Thank you. For many Nigerians, the cost of critical illness can be devastating. Excessive dependence on out-of-pocket expenditure delays access to care. It interrupts treatment and exposes households to financial hardships. No Nigerian family should be forced to choose between financial ruin and access to life-saving healthcare. We must therefore develop mechanisms that can finance in a sustainable manner our public hospitals, improve financial protection for users, and ensure that access to critical care is determined primarily by clinical need rather than the ability to pay. So I'm quoting the keynote speaker here. In line with the theme of this conference, isolated effort at intervention is unrealistic, and this calls for collaboration and synergy. The National Emergency Medical and Ambulance System represents an important component of efforts to improve access to emergency healthcare. NEMSAS has expanded from a pilot program in the FCT to 36 states with ongoing efforts towards nationwide operationalization. A digital emergency dispatch system that will link callers, ambulance, and emergency treatment centers is currently being developed to support real-time response, patient tracking, referrals, and claims management. Similarly, ongoing intervention are strengthening maternal and newborn care, expanding healthcare financing, and improving service delivery demonstrate the federal government's commitment to reducing preventable death and improving health outcomes. All this require coordinated approach that connects emergency care, ambulance and retrieval services, intensive care units, high dependency units, operating theaters, medical oxygen systems, diagnostic services, health insurance, workforce development, and rehabilitation service. Therefore, continuous collaboration among the federal government, the state government, health institutions, professional bodies, academics and research institutions, the private sector, development partners, and the civil society organization is an imperative. In this regard, I commend the Intensive and Critical Care Society of Nigeria for the readiness and contribution to the development of critical care services in our country. Professional societies have an important responsibility to support government through technical expertise, policy development, professional education, research, advocacy, and the establishment of standards that promote quality and patient safety. Ladies and gentlemen, building a sustainable critical care system requires deliberate investment in our healthcare workforce. Nigeria needs more physicians trained in intensive and critical care nurses, physiotherapists, pharmacists, biomedical engineers, technicians, and other members of the multidisciplinary team. We must expand specialist education, fellowship opportunities, continue professional development, and strategic partnership with national and international institutions. Medical oxygen must equally remain a national priority. The experience of COVID-19 pandemic taught us that reliable medical oxygen systems are indispensable, and the federal government has risen to this challenge by prioritizing and providing oxygen pressure swing absorption plants in many facilities across the country. We must also strengthen referral and retrieval systems so that critical ill patients can be identified early, appropriately stabilized, and safely transferred to facilities capable of providing the level of care they require. The development of regional and critical care networks will contribute significantly to reducing geographical inequalities in access to life-saving services digital health, telecritical care, and stronger health information system as added advantages. Ladies and gentlemen, health financing is not complete without involving the private healthcare sector. Public and private healthcare institutions serve the same Nigerian population, and improved collaboration can only make things better. I therefore encourage the deliberations at this conference to go beyond identifying problems, which I think we have started doing. The discussion should generate practical, innovative, and sustainable recommendations for strengthening the financing and delivery of intensive care services in Nigeria. We must collectively address the critical questions before us. How can Nigeria sustainably finance intensive care in public and private hospitals? How can we protect families from catastrophic healthcare expenditures arising from critical illness? How can we increase the number and equitable distribution of trained critical care professionals? How can we ensure that the expensive medical equipment remain functional throughout its expected lifespan? And how can we strengthen medical oxygen systems, referral networks, and critical care infrastructure? How can government, professionals, societies, health institutions, development partners, and the private sector work together more effectively? The answer to these questions will require evidence, innovation, strategic investment, collaboration, and sustained political commitment. I urge all participants to engage actively in the scientific sessions, workshops, and policy discussions, and I encourage the society to develop recommendations that are practical, measurable, and responsive to the realities of our healthcare system. The Federal Ministry of Health and Social Welfare looks forward to the outcomes and recommendations of this conference and to continued engagement with the intensive and critical society of Nigeria in areas of mutual interest. As I wish you a productive deliberation, fruitful scientific engagement, and a successful annual general meeting, it is now my honor and privilege to declare the 11th Annual Scientific Conference and Annual General Meeting of the Intensive and Critical Care Society of Nigeria officially open to the glory of God and the preservation of the lives of Nigerians who may fall critically. And so, with peace and plenty, Nigeria shall be blessed. Thank you.
Please, we can do better. Thank you very much, Honorable Minister. Quickly, I want to invite Dr. Irene to take us through our two publications.
Good afternoon, distinguished ladies and gentlemen, Honorable Minister of State, DHS, Hospital Services, Chairman of the occasion, distinguished ladies and gentlemen. I just want to be quick about this. So today is a great day for critical care in Nigeria, for professionals, for government, for businesses, and for our patients, because today we produce and present our policy document. We have one on the national standards for intensive care services in Nigeria. We know nature abhors a vacuum, and the Critical Care Society has decided to bring this up to act as a policy document for critical care in Nigeria. This document has a lot in it, talking about setting up ICUs, either in the public space or in the private space, manpower development, services, standards, quality, performance indices. And I think those things are what we, the clinicians, patients, and government all need, and regulations as regards IC. So this was the work of a committee and the Critical Care Society. This is available and everyone should have a copy. I think it is very important for every ICU to have this. We also believe the government, the Ministry of Health, will also have this copy because this was written by professionals in this space. The next document we have is the guideline for management of brain death
and Death by Neurological Criteria in Nigeria, a document by the I-CCSN. We have challenges when you have a patient who is brain dead and you need to, certify or de-escalate care. And it's a lot of ethical issues. We went through a lot of processes. We've been on this for close to 2 years to tell you how important it is. So these documents are available. Our account number is there on the screen. And since today it's our conference, we're unveiling, of course, we expect persons and hospital representatives and government and private sector to please support the association in moving these documents forward. Thank you very much.
Thank you very much, Ma. Please, quickly, I want to invite our very own Major General Ogunbiyi to please step on stage to do the honor of presenting this award to Dr. Omo. Please, let's put our hands together for them. While the president brings up for his vote of thanks. The chairman of today, my brother, Dr. Laleko Latishe. I want to say a big thank you to you again. Thank you. God bless you, sir. The Honorable Minister of State, Ministry of Health. Thank you so very much, sir. Your words were critical. We have noted them. We will do the needful, sir. And I don't want to be impeached by the Alumni Association of Nigeria. I have to recognize my own, they are member of National Institute, who is also the director of Hospital Services and Federal Ministry of Health, Dr. Mrs. Absada Adigoke. You are welcome, MNI. You are welcome. The Agama lizard, when he fell down from the top of the wall, he looked left, he looked right. Nobody applauded him. The man said, look, I will applaud myself. This morning, the Intensive and Critical Care Society of Nigeria, we are honoring one of us. And in doing this, we want to say a big thank you to the Honorable Minister of State, Minister of Health, sir, and by extension, the Director of Hospital Services, for finding it fit to appoint one of our distinguished intensivists in the healthcare space in this nation as the medical director of the Federal Medical Center, Asaba, and the person, my brother, Dr. Kenam Omo, who we have come a long way together. He happens to be my mentee over the past 15, 20 years. So on behalf of the Intensive and Critical Care Society of Nigeria, I want to say congratulations to you. And as the Medical Director of Federal Medical Center, Asaba, we wish you all the best. And we know you as a performer. The minister is here. You won't disappoint us. And you'll be. Congratulations, Dr.
When I finish both of thanks.
All right, thank you very much. Please, I want to use this honor to invite Honorable Minister and member of the High Table and Chairman.
The vote of thanks for the photograph. This type of vote of thanks. I want to use the opportunity to thank the Honorable Minister of States for Health and Social Services. So thank you very much for the audience you granted us yesterday.
it's not easy to see a Nigerian politician except during elections. But for the minister to grant us audience yesterday, we're impressed. Seriously, we're encouraged as well. Thank you very much. We are very grateful for not just granting us audience yesterday, you also attended. I think it's the first time we've seen minister attending except NMA functions. But for some societies, it's very encouraging. That is great. Thank you very much, sir. For the director of hospital services, you were there yesterday, and today you came very early. We are very grateful. Thank you very much. We appreciate all this effort you've made to encourage us. That will help us do more. To our guest speaker, keynote speaker, Dr. Daprim, you are with us in Port Harcourt. You're here. You're a very busy person, very busy scholar. But you've taken the initiative to come because you love what we do. We are very grateful for what you've, delivered today. It's very inspiring. It's lessons for all of us. Like we started doing, you've given us a checklist. So I started taking the checklist. And you gave us a Port Harcourt and he said, we've done 1, 2, 3, 5. Yesterday, you started asking me, what have you guys done since the last time we met? So you're putting us on our toes. We're very grateful. We'll take it from here. And by the time we meet next year, obviously, we'll do much more than what we have done. To our chairman, the man of the house, nephrologist, renal transplant expert. I was telling him that he should endow a prize in critical care nephrology. I spoke with the president of the Nephrology Society. He didn't know the area I was coming from. I told him that you can't practice nephrology without critical care. All your AKIs, where did they go? So there is basically an interface between nephrology and critical care nephrology. And I begged him he should endow a prize for researches in critical care nephrology. Because if you do transplant patients who end up in the ICU, I saw everybody that comes to the ICU that dies. That's why we're experts in critical care, so that we can reduce the percentage. Thank you very much. Your time, your resources, bringing us here. We can't go below the standards. Thank you very much. And keep it up. I believe in the principle that if you give, you will get. I believe that principle and it works. That you keep. Professor Sanusi was telling you yesterday, Zenith is like a height. There must be a higher level than Zenith. So Zenith Medical, I think I'm not advertising the hospital anyway. But you've done very well. Thank you very much. To our celebrants and his dear wife, I remember we went to Canada. After the ceremonies, the general didn't leave the boys. He took us to one seaside restaurant and finished out with a lot of, delicacies with all the fun. I think around general is fun. Around general is fun. I'm sorry, in the morning, you see all the big generals here. You'll be scared of touching them. But our own general is touchable. You can perfect him anytime. That's why we have to celebrate him now. I will keep doing that. By next year, we'll be bigger than what we are doing today. Thank you very much. To our president, the president of the Nigerian Society of Anesthetists. He's a very busy person. He's championing the essential and critical care. He knows things. He's doing too many things, but for him to be here, he flew from Kano to be in Abuja. That's a great sacrifice. Thank you very much, sir. And the mommy of the house, Sanusi, is always with us. But we always need them around to inspire the younger ones. So that, imagine people in taught levels down to, and more levels. But if you come around, I always tell residents, whatever she says will always come in the exam. Just hang around that. Because she doesn't talk carelessly. She says something, you must always have it. Something that you can actually value. So thank you very much, ma, for being there. Like we said, we're honoring you with a prize that the West African College of Surgeons will pay for it. We have a lot to show. We're not afraid. Money is not a problem now. So we're going to get it done. It's just $4,000. It's chicken fee. If you don't pay for it, Only one patient in the ICU will jack up the price. So we have a price in honor. And to immediate past president, Professor BPO Shinaki, if you work with Professor Shinaki, he can sit down. Every detail. By 1 a.m., you wonder what do they do in Ibadan and read book. But we in Port Harcourt, we love fun, I mean, but Ibadan is all book. It's always a guide. I mean, it's sure that you've taught him very well. You taught Shinaki very well. And Shinaki is exactly cascading down to our levels. And then to our sister societies, obstetrics, airway, our partners in the industry, to the media, to our members, the fund is just starting. So after this, I want to thank everyone for coming. We're not closing up now. Just go for a short walk through the exhibition, which will be led by the Honorable Minister, and then we'll go for our lunch, and we'll come back for our abstracts, and then more presentations by those from the industry. And then the main lecture on Surviving Sepsis Campaign 2026 is the latest by one of the authors. Professor Craig that is talking to us is one of the authors. He's one of the best in the world on sepsis. So when he talks, whether you're internal medicine or anesthesia, critical care, you need to listen to the originators of those concepts. So thank you very much. Thank you, and may God bless all of you and lead you gently home, Minister and his team, and all those who stay back with us. Thank you. Tomorrow's another day, please. So we have a group photograph led by the Honorable Minister on this platform. So we're sorry we're exhausting you today. So all ESCO, can you please come on board? Sister Presidents, can you please join us? NSA Presidents must come. That one is the first.
When you called out to them, they will wait. You have to announce.
Are we all rise for national anthem, please? God bless Nigeria. Distinguished ladies and gentlemen, exhibition stand.
We're giving a tour of the. Hello, how are you? Well done, sir. Giving a tour of the exhibition. Sorry. Let me even remove you from the door. In which centers? Is it during the ESAM, Society of Government, or during NSA in 2020? Beto Hotel, how is what? From Lagos. Remember, I was in Lagos. How is what? Our exhibition booths. Very soon you will feature. They just finished opening ceremony. Great Cooper. So very soon they will come back to our lecture. Right now they are doing tour exhibition booths.
Can you hear me?
Mark? Mark. From Craig is online.
Me and my dad before me then. Me and my dad before the sunset shines in the moon. Just before you leave. You are the flower. Me and my dad before my dad. Me and my dad before the sunset shines in the moon. Just before you leave.
Come in, please. Please come in, come in.
Introducing.
Where's the CV? Did I give you CV?
It's not the one online in the book.
In the book, yes.
We project it. So we can read through the books.
Please, those outside, can you come inside, please? Where is it? How do you read it?
You see it on the screen.
Right.
It will be seen on the screen. So just. So you see it on the screen.
Which screen is that?
Projected.
It's not projecting it. Good afternoon, ladies and gentlemen. So we have an important lecture. We have an important lecture which is delivered by one of the best in the world. So Professor Craig, just give us a few minutes to read your citation. So we have Professor Craig, who is talking to us from the US. He had woken up this early. He was prepared. He has been prepared. So a brief citation of Professor Craig. Can you please reflect it? Like we said, he's one of the world's leading authorities in sepsis. So anybody who is not here is going to miss it. Anybody who's not here is going to miss it. Because we have an authority that is going to talk to us. And he's director of Emory Critical Care Center, vice chair and research in the Department of Surgery and professor of surgery at the Emory University School of Medicine, Atlanta, Georgia, USA. He also directs the Surgical Critical Care Fellowship and has played a pivotal role in shaping modern critical care practice in the United States and in the world. His scientific work has transformed the understanding of sepsis pathophysiology, particularly the interaction between the gastrointestinal tract, immune dysfunction, and multiple organ failure. So Craig is widely recognized as one of the foremost investigators in sepsis and septic shock, with over 450 peer-reviewed publications and accumulated over 63,000 citations, making him one of the most influential researchers in critical care medicine globally. He was president of the Society of Critical Care Medicine and has contributed extensively to international critical care guidelines. He was a key contributor to the sepsis 3 definitions and the Surviving Sepsis campaign, which remained fundamentally foundational references for clinicians managing critically ill patients worldwide during the COVID-19 pandemic era. He has served on national guidelines committees for critical preparedness and management. His numerous honors include election to prestigious scientific organizations and recognition for excellence in research, education, and clinical leadership. Through his mentorship of young investigators and clinicians, Professor Coppersmith continues to shape the future of critical medicine internationally. It's our privilege to invite Professor Craig to talk to us on this all-important topic. Thank you very much. Prof, thank you.
Thank you very much for having me here. It is a tremendous, tremendous honor to be here. I thank you for the invitation and good afternoon to everybody. It's good morning for me. So I'll be speaking to you today about the Surviving Sepsis campaign and the update that just came out a couple of months ago. So my disclosures are listed here. I am the co-chair of the Surviving Sepsis campaign, and prior to that, I co-chaired its research committee. The other disclosure, and this is obviously incredibly important, is that guidelines need to be adopted to local environments. I've never practiced in Nigeria, and therefore I understand that some of what I'm about to say will not be directly relevant to your local practice. And I do apologize for that up front. When we put together guidelines for the world, by definition, it means we're going to get it wrong for some places in the world. So what I'm going to be talking about here is the most recent Surviving Sepsis campaign guidelines. So they came out in March in both critical care medicine and intensive care medicine. And as you see here on the right, I'm the final name or the senior author on the guidelines. So how did we put the guidelines together? It took a panel of 69 panel members. They came from a combination of 23 countries. And although I do not like the term low and middle income country, because I think it's much better to talk about resources, because there's clearly people who work in low and middle income countries who work in high resource ICUs, and there's people in high income countries like the United States who work in low resource settings. The easiest way of looking at this is to talk about low and middle income countries. So 38% of the panel has low and middle income country experience, which is by far the largest it ever has been. There were 6 clinical domains. Of the people who made up the panel, 88% were physicians, 9% were nurses. Multiple specialties were seen, including internal medicine, anesthesia, emergency medicine, and surgery. Most people were specialists in critical care, but not all. And importantly, we had patients and family advisors integrated throughout. And I'm actually going to show you a recommendation where the families actually changed the recommendation. So how do we actually come up with the recommendations? So what we do is we start with what's called a PICO question. So we identify the population that we're interested in, and then we look at the intervention of interest, the comparisons, and outcomes. For every single question, there is then a systematic review team, which is made up of clinicians, content experts, methodologists, statisticians, and a search specialist. Then a systematic review is done, including literature search, data extraction, pooled analysis for predefined outcomes, subgroup analysis, and risk of bias. And then finally, certainty of evidence using what's called grade evidence. And so it's not just a question of what does the data show. We actually then put it in what's called evidence to decision framework, where we not only look at the evidence, we look at the strength of the evidence, we look at the directionality of the evidence to see whether all studies agree. We look to see whether there's equity, whether it is cost-effective analysis, whether this will be acceptable throughout the world. And ultimately, we put all of that together to make a recommendation. Now, there are limitless numbers of questions that we could answer. And what we said up front is, what can we do? Because each question is actually fairly expensive to do this entire process. And so we say up front in the 6 different domains, how many questions can we answer that we think are important, that there's data on to bring to the world? And ultimately, there's 2 types of recommendations. There's what's called strong recommendations, or conditional, they used to be called weak recommendations. And so as you see here on the left, the implications are different for patients and families, or clinicians like I'm talking to, or policymakers, or researchers. So if I take clinicians, for example, a strong recommendation means that the intervention should be given to all or most patients. There's actually little need for shared decision-making for tailoring to context. Versus a conditional recommendation, which is much weaker, the intervention should be done for most patients, but clinicians should consider shared decision-making, clinical context, and resources. That's actually a little bit different from how you would see for patients and families, where you would actually make it simpler. A strong recommendation is everybody or just about everybody would want the intervention, while a conditional recommendation would be most would want the intervention, but a substantial portion would not. And so in the guideline, we used 4 different frames for sepsis: definite, probable, possible, and unlikely. So for definite, sepsis is actually confirmed based on history, clinical exam, and diagnostic testing. An alternative diagnosis is very unlikely. Probable is exactly what it sounds like. There's a high suspicion, it's the most likely diagnosis, and an alternative is possible, but less likely. Possible is in between, when there's a moderate suspicion, but there's also a lot of other possibilities, also likely. An unlikely is exactly what it sounds like. There's a low suspicion for sepsis. So the 2026 guidelines have 129 statements covering 6 different domains: infection, hemodynamic management, respiratory support, adjunctive therapies, additional support with goals of care, transitions of care, and long-term outcomes. As you see, of the 129 statements, 2/3 of them ultimately were conditional recommendations. That's most of them. Only 17, only about 12% or so, were strong recommendations, which actually tells us the data aren't that strong for everything. And remember, a strong recommendation can be positive, you should do this, or negative, you should not do this. There's also 19 good practice statements. We changed the wording in this from last time. Last time we called these best practice statements. And a good practice statement would be something to the akin of, do not jump out of an airplane without a parachute. So nobody is ever going to do a randomized controlled trial about what half the people jump out of an airplane, they have a parachute, and half the people do not have a parachute. That would be unethical to do. Nonetheless, it is possible to make a recommendation based upon what an appropriate practice is. And then finally, there were 11 recommendations in which there was insufficient evidence to issue a recommendation. So I have 45 minutes to talk, and I'm obviously not going to go over 129 statements in 45 minutes. What I will do instead is focus on new statements, focus on updated statements, mostly related to treatment of infection, and also talk about statements where the strength of recommendation has changed, either getting stronger or getting weaker based upon new data that's come out in the last 5 years. So what's new since the 2021 guidelines? There are 46 statements addressing new questions. There were 38 statements that address questions that were previously examined in the 2021 guidelines. But of those 38, only 3 of them differ from the previous guidance. And only 8 of them differ in the sense where the certainty of evidence or strength of recommendation changed, even to becoming greater or lesser. So of the 38 ones that we forwarded, only 11 have changes, 27 are not changed. And then there are 44 statements that we carried over directly without change because there was new evidence and there was no sense giving any explanation for the recommendation because the evidence was the same as it was years ago. So I'm going to start going over the statements and why. First new statement. For adults with septic shock, we recommend, again, that's strong, an initial mean arterial blood pressure target of 65 over higher mean arterial pressure targets. And there's also a new remark. In practice, it's not feasible to maintain the MAP at exactly 65. So a reasonable range within 5 should be used. That means a MAP of 60 to 70 is okay. Because if you say to a nurse at the bedside, the MAP needs to be 65, and it's 63, does that mean they need to increase the pressors? Or if it's 67, does that mean they need to decrease the pressors? And so we added some real-world guidance to this. But this is also new. For adults with septic shock who are over 65 years of age, we suggest again as a lower bar, it's a conditional recommendation, an initial mean arterial blood pressure goal of 60 to 65 over higher ranges. So that's a little bit lower. So why is that? Here's the most recent data, and this comes from an individual patient data meta-analysis from the New England Journal of Medicine. blood pressure targets for adults with vasodilatory shock. And ultimately, what you see for the conclusions, and I'm certainly not going to have time to go over all the data, targeting a lower mean arterial pressure for vasopressor therapy in critically ill patients with vasodilatory shock possibly reduced 90-day all-cause mortality, although the evidence is still low. Another new one, and this is probably one of the biggest changes that I think that will change practice really worldwide. For adults with sepsis or septic shock without a large risk factor for anaerobic infection, we suggest, again, lower level of evidence, using an empiric antibiotic regimen without anaerobic coverage. And agents with anaerobic coverage that are needed to cover possible MDRs, such as piperacillin tazobactam, also known as Zosyn, carbapenzins, are reasonable to use if alternative agents without anaerobic coverage are inadequate. The flip side of that is for patients with sepsis or septic shock with specific risk factors for anaerobic infection, we suggest using an empiric antibiotic coverage that includes anaerobic. What's important to see here is what are the risk factors for anaerobic infection? And they include intra-abdominal infection, or deep-seated GYN infection, or necrotizing soft tissue infection, head and neck infection, CNS abscess, or empyema. But notice what's not there. What's not there is pneumonia or respiratory therapy. What's not there is urinary infections. And so the most common cause of sepsis by far is intrapulmonary, is pneumonia. And this is suggesting that a new recommendation, we should not be giving anaerobic treatment for somebody who we're concerned about either community-acquired or ventilator-associated pneumonia. That's new and that's different. And why? So this is a little bit older. This is from a few years ago, empirical metronidazole or Flagyl for patients with severe bacterial infection, a systematic review with meta-analysis and trial sequential analysis. And this is looking at a total of 9 trials with nearly 2,000 patients, all of which actually have a high risk of bias. And they found no evidence of change in mortality. But as you see, the relative risk was actually higher in patients who get anaerobic therapy. But this is probably the key study. And this is a retrospective cohort study from one of the 2 first authors of the Surviving Sepsis Guidelines, Hallie Prescott, looking at a time in the United States when there was a shortage of piperacillin tazobactam, what I might also call Zosyn, for a year. And what they did is they went back in time and they took adult patients with suspected sepsis who were treated with vancomycin and either piperacillin tazobactam, also known as Zosyn, or vancomycin and cefepime. And it was a large study, again, retrospective, but looking at nearly 8,000 patients, of which 4,500 were treated with a gram-negative coverage that has anaerobic coverage, including piperacillin tazobactam or Zosyn, 4,500, and 3,000 who were treated with cefepime. And because of the shortage, basically during that period of time, almost nobody got it. And what you see here is that there was an absolute mortality increase in patients who received anaerobic coverage. And so for those who like to see pictures rather than words, you can see here this paper from JAMA. So at the top, you see the absolute difference in mortality. Now that might look pretty similar because it's a small difference, especially among 7,000 patients. But if you see in the box, if you change the thing going from 0% to 100% on mortality to just 50% to 100%, now all of a sudden you see a significant difference. And what you see at the bottom is when they actually looked at differences in the primary analysis as well as in the sensitivity analysis and multiple different things, including year of admission, anatomic site of infection, et cetera. You see for every single one of those, it favors cefepime. And that led to the new recommendation that if you are not concerned for anaerobic infection, you should not be treating for anaerobic infection. And I will acknowledge that this actually changed my personal practice because historically we actually have used vancomycin and Zosyn for coverage for pneumonia, for a hospital-acquired pneumonia. And we've actually changed now to stop using Zosyn, piperacillin, tazobactam to use a cephalosporin. Next one. And I understand that this will not be relevant in Nigeria, most likely. This is equally not relevant in the United States, but it is an important statement worldwide. In mechanically ventilated adults with sepsis or septic shock with a low prevalence of antimicrobial resistance, we suggest using selective decontamination of the digestive tract. Again, a conditional recommendation based on moderate certainty of evidence. So why is this recommendation made? This has actually been studied more than literally anything else in all of critical care. If you look at this meta-analysis that came out in New England Journal of Medicine Evidence, you see selective SDD in adult mechanically ventilated patients, an updated systematic review of Bayesian meta-analysis. You see about 25 studies going from 1987 to 2025. And if you add up the number of patients here, it is in the multiple thousands, because when you look at the largest studies, the top you see small studies, you see the number of patients are like 20 per group. But when you get to the bottom and you see the number of patients are 3,500 per group. So this is looking at thousands of patients over nearly 3 decades. And what you see is there is a significant trend towards improvement in survival with using SDD. So why is this not recommended for everybody? Almost every one of these studies was done in the Netherlands, where there is a very low incidence of multi-drug resistant organisms. That's not the case in the United States. So I do not know anybody in my country who does this. Conversely, every single one of my friends in the Netherlands does this as standard of care. So this is challenging to do, and you have to be confident that your chance of resistant organisms is low. But within that context, this is actually the most studied thing within critical care. Here's another new statement. For adults with septic shock, after the acute resuscitation phase, we suggest, again, lower levels of data, using active fluid removal. And acute resuscitation means escalating doses of pressors, high dose pressors, need for ongoing volume resuscitation. And active fluid removal, which is what we're suggesting, refers to diuretics. And if diuretics are insufficient, ultrafiltration or extracorporeal fluid removal, dialysis or continuous dialysis. And the factors to be considered when deciding when to do that include a cardiorespiratory function, pressure dose, clinical course, edema, weight, and fluid balance. And what you see here on the right for the abridged rationale in the red box is this is the first time we've said this in a rationale. Our suggestion for active fluid removal was influenced by input from patient representatives on the Surviving Sepsis Campaign guidelines who placed a high value on avoiding edema. So this is not because we have a strong randomized control trial of active fluid versus not active fluid, but this is actually taking for the first time patients and families on the guideline panel, and they said, what's important to you? And they said, what's important to us is that my loved one or that I am not incredibly swollen. It's very, very difficult. It's very uncomfortable. It's difficult to see. And so we took that into account and we actually included this new statement. Next one. For patients with sepsis or septic shock, we suggest using pathogen-specific rapid diagnostic tests on a case-by-case basis. And this is case-by-case based upon clinical features, local pathogen and resistant patterns, seasonality, and availability of tests and antibiotic stewardship. I understand that these are not available everywhere. So for some hospitals, this might not have any relevance. For some, it might. Why don't we recommend this for everybody? So here's the rationale. Pathogen-specific rapid diagnostic tests are used to guide empiric antimicrobial therapy. So you can very rapidly say somebody has this infection or this infection. There's lots of different ways to do it. I'm not going to get over the methodology, but ultimately the guide is not to wait 2 days until one gets back a culture using technology that's 150 years old. Instead, this is actually very rapidly, within an hour, trying to find out what bacteria or pathogen somebody has in order to better target the antimicrobial therapy. The concept is that it will improve clinical outcomes and to reduce both unnecessary prescription of broad spectrum antimicrobials and the development of antimicrobial resistance. So why do we not say to do this in everybody? Well, here's the most recent Cochrane database analysis looking at this. Rapid versus standard antimicrobial susceptibility testing to guide treatment, specifically of bloodstream infections. And what you see is mortality wasn't beneficial at all. Rapid antimicrobial susceptibility testing makes little or no difference to mortality. And in every subgroup, it was the exact same thing. So even though in theory it makes sense, the data doesn't actually support it. In fact, as you see here, there was little to no difference in short-term mortality with the use of these as compared to not using them, a relative risk of 1.03. So we said it shouldn't be used in everybody because it will increase costs without a benefit. But in very specific patients, these could be used. After surviving sepsis came out, which I understand is only a couple of months ago, this trial came out, the FAST randomized controlled trial. Now, this is not specifically looking at sepsis. This is looking for bacteremia. But this is a large study. As you see here, a large study when they looked at patients with bacteremia. And what they found was the risk of death actually, just like in before, although it crosses midline, there's certainly no evidence here whatsoever that there is actually a benefit on the right towards rapid antimicrobial tests. And if anything, the standard was more desirable. So those are selected new statements. These are selected statements that are different, not new, but different from 5 years ago. The first is, for adults with sepsis or septic shock, we suggest against empirical antifungal therapy, with the remark that empirical antifungal therapy should be considered on a case-by-case basis in selected patients with sepsis or septic shock and risk factors for fungal infection, such as immunosuppression, prolonged use of antibiotics, prolonged hospitalization, and intra-abdominal source. Here's another statement that differs. For adults with sepsis, septic shock, we suggest using either invasive, that will be an arterial line, or non-invasive blood pressure monitoring. And we said invasive blood pressure monitoring is advised to patients who require intermediate to high dose pressors, escalating doses of pressors, or multiple pressors, or frequent ABG sampling. But why did we change this? Why do we change this to say that you can either use invasive or non-invasive? And this is the study that came out last year in the New England Journal of Medicine about deferring arterial catheterization in critically ill patients with shock. This isn't all sepsis, but this is critically ill patients with shock. And what you see here is patients who got an arterial line in the invasive strategy at the top, of course, 100% of them did. But patients who met certain criteria, only 25% of them required an arterial catheter. And what happened when we look at mortality? I'm not going to have time to go over all the details, but when one looks at mortality, there's a non-statistical improvement, although actually the hazard ratio for death is 1. So there's no difference in mortality between the non-invasive strategy and the invasive strategy in a large number of patients, as you see at the bottom. And so the bottom line is mandating an arterial line in everybody just because they have low-level shock is no longer the recommendation. You can do it. You're also totally justified in not doing it. Another statement that differs. For adults with sepsis or septic shock, we suggest using crystalloids over crystalloids with albumin for fluid resuscitation, while still saying albumin may be appropriate for patients who receive large volumes of crystalloid or who have cirrhosis, and also saying that albumin should be avoided in patients with traumatic brain injury because of evidence that it increases mortality. So this was a change because in the past there was actually a suggestion for supplemental albumin, and now there's a recommendation for crystalloids alone. So why the change? So this is something which has also been studied quite a bit. Now, if you look at the numbers of patients involved here, it's smaller than the sample size with the SDD that I spoke about earlier. The largest study here is still large, though, and this is still looking at about 5,000 patients per group. And one looks at 5,000 patients per group, and then one looks at mortality, you see literally no difference between patients treated with crystalloid and patients treated with crystalloid or albumin, with the knowledge that albumin is significantly more expensive than crystalloid. We would never make a recommendation for something which is 60 times more expensive, but does not have a patient benefit in outcome. Here are some statements with a change in strength of recommendation or certainty of evidence. For patients with sepsis or septic shock, we now recommend, again, one of the very strong ones, using prolonged infusion of beta-lactams for maintenance after an initial loading dose over bolus recommendation. It's a strong recommendation, again, as high as we get with a moderate certainty of evidence. What's the biggest evidence behind this? This is a meta-analysis. And again, the reason I talk about meta-analysis more than individual studies is the meta-analysis is pooling all studies on this. So intermittent versus prolonged beta-lactam in patients with septic shock. And what you see is this is also a study of about 5,000 patients. And when we look at whether we're using traditional statistics, or that's the frequentist type, or whether we're using Bayesian statistics, which takes into account pre-hoc knowledge, and either one of those, you're seeing a significant benefit towards mortality, which is probably the single most important outcome on patients who receive continuous infusion of beta-lactams. Here's another one with a change in thing. For adults with sepsis or septic shock, we recommend, that's stronger now, de-escalation of antimicrobial therapy over no de-escalation when a confirmed microbiologic diagnosis of susceptibility is available. So basically this is saying once you know what the microbe is, it's appropriate to narrow or de-escalate. And that was upgraded based upon new data from a conditional to a strong recommendation. This is something there's a lot of studies on. For adults with sepsis or septic shock undergoing initial resuscitation, we suggest using balanced crystalloids over normal saline. And I understand in order to do this, you need to have balanced crystalloids, and that can be lactated ringers, and that can be plasmolite. And that was upgraded from low to moderate certainty evidence. Still a conditional recommendation, but the certainty is higher. Why is that? Because there have been 2 large-scale prospective randomized trials published since then. Those are the 2 at the bottom, the Zampieri, which is the basics trial, and the FINFER, which is the plus trial, putting this together. And so this is looking at a combination of low bias studies, those are the ones at the top, and higher risk of studies, those are the ones at the bottom. But ultimately, if you look at the very bottom in green, which is the risk of mortality, simply by giving a different fluid, you see that the relative risk is lower. It does cross 1. The relative risk is 0.3, with the entire confidence interval going from 0.76 to 1.15. So understanding that it does cross 1, there's a lot of evidence that suggests in critical illness that balanced crystalloids are better. But people specifically sometimes ask, how about in sepsis? And so this is a post hoc exploratory analysis from the basics trial. The basics trial, which was published in JAMA, was looking at about 70 ICUs in Brazil, showing no difference in mortality between balanced crystalloids and normal saline. But what the authors then did is they broke it into subgroups retrospectively. So again, a limitation. There's 2 possibilities. Remember, patients get crystalloids before randomization. So before randomization, they can get balanced crystalloids or normal saline. And then after randomization, they can also get balanced crystalloids or normal saline. And so you have 4 groups, one that gets balanced crystalloids before and after randomization, one that has saline before and after, and ones that are mixed. You have one before randomization and the other after. And then what they did is they said, we're not going to look only at critically ill patients. We're going to look explicitly and exclusively only on septic patients. And when one looks at septic patients only, when one looks at the patients who get balanced crystalloids before randomization and then after randomization, they actually had an improvement in mortality. You can see for all the other groups why it was a negative study, but specifically septic patients who got balanced crystalloids throughout had a better outcome. Next one with a change in strength of recommendation. For adults with septic or septic shock, we suggest using dynamic measures to guide initial fluid resuscitation over physical exam and static measures alone. And dynamic measures could be a passive leg raise or fluid bolus using stroke volume or stroke volume variation if you have the technology, or pulse pressure variation. And this is actually based upon new data that moved it from very low certainty evidence to low certainty. So still not great, but better than it was. Pressors, and I do understand that the pressors available are different between countries, and we had a lot of discussion about that. But ultimately, this is if you have every possible pressor. We said for adults with septic shock, we suggest using norepinephrine or Levophed as the first-line agent. That's not new, but compared to vasopressin, it's actually downgraded to low certainty evidence. Compared to angiotensin II, which wasn't even mentioned before, it's very low certainty evidence. So in fact, this is actually lower evidence, and we actually say the use of norepinephrine as the first-line agent over dopamine, epinephrine, or celepressin remains a strong recommendation if you have norepinephrine. And then finally, it also says for adults with sepsis and an adequate MAP, despite norepinephrine and vasopressin, we suggest adding epinephrine. And saying when vasopressin is not available, epinephrine can be added to norepinephrine alone. But again, this was downgraded. So there are some things that we said there's more evidence to support. This is something we're saying there's less evidence to support. Here's another thing which was downgraded. For adults with septic shock and persistent hyperperfusion and cardiac dysfunction, despite fluid resuscitation and adequate and arterial blood pressure, we suggest adding dobutamine to norepinephrine or using epinephrine alone, and could not make a recommendation for dobutamine versus milrinone. This was also downgraded. And the final thing, which was downgraded from moderate to low certainty evidence, was we suggest using IV steroids for patients in septic shock. Here's a few things that are not new, and I understand I have 10 minutes left, but are still important. Timing of antimicrobial therapy. So anytime we talk about sepsis, if there's one and only one slide to remember, it is this. This is not a changed recommendation, but it is so important that we have it in the figures, and I'm going to explain it. If the patient has shock and sepsis is definite, or sepsis is probable, or sepsis is even possible, antimicrobial therapy should be instituted immediately. No delay is acceptable. Ideally within 1 hour. If you could do it within 10 minutes or 5 minutes, do it immediately. We're not suggesting to wait for an hour. Obviously, there's logistics that sometimes make it difficult or impossible to get antibiotics. But as quickly as you can get antibiotics in for somebody in shock that is definite, probable, or even possible septic shock, do it. If shock is absent and sepsis is definite or probable, it's the exact same thing. Administer antimicrobial therapy immediately, ideally within 1 hour. But if shock is absent and sepsis is only possible, and there's other plausible explanations, it is appropriate to do a rapid assessment of infection versus non-infectious causes of acute illness, and to administer antimicrobial therapy within 3 hours if concern for infection persists, because of antimicrobial stewardship. Because if we use antibiotics on everybody immediately, we're just going to end up being resistant to the antibiotics we use. And here's the explanation for how we came up with that. Again, the data did not change. The recommendation did not change. But this is looking at 42 studies on nearly 200,000 patients, showing the observed mortality was strongest for patients with septic shock. And even if we get to the bottom, 2 RCTs did not show a difference between early treatment and reduced mortality for patients with sepsis without shock, but the median differences in time to antibiotics in earlier versus late were well under 3 hours. Here's one that didn't change. There was actually no new data. This wasn't even discussed, but there's something new that I would like to discuss. For adults with possible or probable sepsis using sepsis or septic shock, we suggest using clinical evaluation alone over procalcitonin plus clinical evaluation to decide when to start antimicrobials. Nothing new. No new meta-analysis, no new evidence. But this was published in March of this year in Lancet Respiratory Medicine. This is a study from England and Wales, a multi-center randomized controlled open label phase 3 trial, where the authors did two different things. They looked at procalcitonin levels to be low, medium, or high risk, and NEWS2 score to give somebody a low, medium, or high risk. And ultimately put the patients into categories. If you have a low calcitonin and a low NEWS2 score, your risk is very low. If you have a high of high, your risk is high. And you can see in the thing over there, ultimately what got you to a low, medium, or high risk. And so what did they do? They looked at 7,000 patients, or nearly 8,000 patients. And as you see at the bottom, making procalcitonin guided algorithm available to clinicians in emergency departments did not change antibiotic initiation, but a decrease in 28-day mortality was seen. So let's look at this in more detail. If we go in the top left, there's no difference in antibiotic use. If we look at the top right, the difference in mortality was slight. But then if we look at the bottom right, when we look at this, where is the difference in mortality coming? Patients who were sicker, who had higher NEWS2 scores, who procalcitonin was also used, had a difference in mortality. Because there was no difference in antibiotics, this is still exploratory. This is not a new recommendation, but this is something worth thinking about if you have somebody who's very high risk. This is new for source control. So obviously patients with sepsis or septic shock should be evaluated for anatomic diagnosis that will require source control, but something which is new, and that's just a good practice statement. There's no way to study that. A recommendation, we suggest early source control over late source control, ideally within 6 hours of the diagnosis of sepsis. And putting a time frame to it is new with this version. And why? Because the meta-analysis of the studies was low certainty evidence, but point estimates suggest that early source control may reduce short-term, that is 90-day mortality versus long-term. And given the observational studies that typically reverted early source control is within 6 hours, we propose this time frame. Earlier source control is better when feasible. The quicker you can get somebody to either the operating room or to drainage, the better. So what happens when there is not enough evidence? This is the first time we included in our practice statements. So in our practice statements, or because people would say to us, you're a bunch of experts. You have 70 experts together. I don't know what to do. Please tell me what to do. And we can't say you should do this because there's no evidence. And so stating that this is our opinion with no evidence doesn't mean that you should do it. But people did say, because you're experts, we want to know what you did. And so we added these in our practice statements, which says what we do. We took votes. We said, this is what we do in places where there's low certainty or no evidence via structured surveys of the panel, acknowledging that we had variation and acknowledging this is descriptive, saying that it's not a recommendation, it's not an endorsement, it's not using grade. We didn't vote on it. We just said when people say, what do you do? If it's helpful for you, this is what we do. So just to conclude, there's many limitations to what I've just said. Obviously, there's a lack of expertise from many parts of the world. This was the most diverse panel we've ever had, and that does not mean that we had expertise from every country in the world and every region in the world. And you would lightly criticize that there were very few. The representatives from Africa are very low. The representatives are dominantly from the United States and from Europe. And so even though we had nearly 30 countries represented, there's over 150 countries in the world, and it wasn't entirely representative. There's certain regional causes of sepsis that were not addressed at all. As I'm fond of saying, I have never seen dengue fever, and almost everybody on the panel has never seen dengue fever. despite the fact that there's portions of the world where dengue fever is endemic and is one of the most common causes of sepsis. And then we didn't have a lot of data on management in low resource settings. We did try for each recommendation to talk about recommendations for low resource settings, but there just wasn't that much available. There are separate ongoing activities right now through SCCM, through the Surviving Sepsis campaign, in partnership with the Global Sepsis Alliance, to look at sepsis in low resource settings. But I will acknowledge that there just isn't that much data. And so we're trying to figure out the right thing to do when we acknowledge that if you don't have all the resources of things that I'm talking about, sometimes you have to change management. So in conclusions, the Surviving Sepsis Guidelines contain updated evidence-based recommendations for the treatment of septic patients. Guidelines are obviously evidence-based, but they're also evidence-based on a population basis. So every time I've shown you a meta-analysis or a randomized controlled trial, it's based upon a certain number of studies. But that's taking the aggregate. When you're being a clinician, you're literally looking at one patient, just the patient in front of you. If you follow the guidelines 100% of the time and you take your clinical judgment out of it, you will end up harming a small number of patients. Alternatively, if you say, I know better than the guidelines all the time, you're going to end up harming a lot of the patients. So the majority of the time, 85, 90, 95% of the time, you should be following the recommendations. And a small percentage of the time, you should say, the patient in front of me is different, and I'm not going to do it for this reason. But if you follow guidelines for the majority of time, you will in fact save lives. From my wonderful introduction, it was pointed out that I'm in charge of nearly 400 ICUs. This is 6 hospitals. There's actually a 7th hospital that we're now in charge of as well. And so from a very, very long distance away from the morning, I want to say thank you so very, very much for the invitation to speak here. It's been a tremendous honor to speak to you, and I'm happy to take questions.
Thank you very much, Prof. Thank you. We are very appreciative of this, the honor you've offered us to present this lecture. My comment initially is that is it possible to test these recommendations in low resource settings?
So is it possible? I'm sorry. Were you done? I'm sorry. I have a little trouble hearing you.
You made recommendations. Based on the recommendations, is it possible to test the validity of these recommendations in low resource settings to see how workable it is?
Yeah. So the answer is it is possible and it is difficult at the same time. So one can do clinical trials anywhere in the world. And it is very important for every recommendation to acknowledge the fact that just about every one of these recommendations is based upon data from high resource settings. So there are a number of researchers, including a number of researchers in Africa, who are studying these. So every single recommendation, and again, each recommendation is different, is studyable in low resource settings. You need the infrastructure to do it. You need to have the ability to do the study. And so it is everybody's fondest hope that the next iteration of the guidelines are not just based upon the data from high resource settings. But in order to do that, studies are expensive to do and they're challenging to do. There was a change this time because in the previous ones, almost all the data was from high resource settings. And this time there was a lot of data from middle resource settings. I talked about, for instance, the fluid studies. Those were all done in Brazil. Brazil is not a high resource setting. It's not a low resource setting. It's in between. And so they did it in 75 ICUs in Brazil. So it is possible. And our hope is that when we give talks, that people will say, I hear what you're saying, but I don't work where you work. I want to know what it's like where I work. And my hope is that people can say, I work in Nigeria. I work in Africa. And I want to know what it looks like in my country, in my hospital, and that people do the studies and people publish the studies. And so next time when we put together the recommendations, we're not saying it's just in ICUs in countries that look like mine, but it's in places that are more representative of the world. Challenging, but doable.
Thank you very much. From the floor, any question for Professor? Yep. Let me take that. Hands up.
Thank you very much, sir, for the beautiful presentation. I noticed you didn't mention anything about steroids, especially for patients with increasing need for high doses of vasopressors. Sometimes you may have patients with sepsis. We've seen. Sorry, probably I missed that aspect, so I was waiting to hear.
The public has responded to his question. Dr. Short, want to say something?
I'm sorry, I didn't actually hear the question. I heard something about pressures, but I didn't hear the question.
My prof, thanks for the presentation.
The question about is on the use of steroids. So you've answered that is because of your lecture. So we are moving on to the next person.
Thank you very much. Again, I appreciate the honor of speaking.
All right. Prof, I want to find out your experience in obvious sepsis with vasoplegic state and to mix or not to mix norepinephrine and vasopressin. Thank you.
Was one of the questions that there's not good data on. That was one of the questions where we said, in our experience, because there's not good data, it turns out that the average panel member started vasopressin as a second line agent when they had reached a dose of 0.5 of norepinephrine, which is not what I personally do and not what we personally do in my hospital. In my hospital, we typically start vasopressin much earlier. We typically start it as a second line agent when we get to a dose of 0.15. So in fact, we start it much earlier than the rest of the world. And it turns out there's not good evidence on what the right time to do is, nor is there good evidence on whether one should do it at all. So the recommendation, which is weak, is to start vasopressin as a second line agent without telling people at what dose we do it. But the truth is, there's not good data. But the concept is, if we hit different mechanisms, we will diminish side effects. So again, in my personal practice, we start vasopressin earlier than most people on the surviving sepsis panel does.
Prof, can you remind us about the dose you use in your practice?
For vasopressin, we use a fixed dose, and we either use a fixed dose. We typically use 0.03 units. I know some people who will use 0.04 because the original study was 0.04. Most people use 0.03, and it's not titratable. So whereas we do titrate norepinephrine or epinephrine or angiotensin II or anything else, we do not titrate vasopressin for vasodilatory shock from sepsis. We use a fixed dose of 0.03.
Great. Thank you. Any other question? Prof, thank you very much. We have two presentations which we made to you by our former president, Dr. A. Samson. We have a plaque. We'll give you a copy of the plaque. Maybe when you come to Nigeria, we'll give it to you physically.
Thank you so much. Again, a tremendous honor for me.
So just give us 2 minutes. Let bring the plaque so that I will show it to you. Then later we're gonna give you the code.
Sounds awesome. Absolutely.
Okay, can we see it? Is that okay? Right. So, on behalf of the Critical Care Society of Nigeria, we really appreciate your lecture this afternoon, Professor Craig Coppersmith, and then this talk on sepsis, the surviving sepsis and the new recommendations has really gone a long way to update us on what is doable and achievable, and the ones that we need to reconsider. I believe that everyone has got one message or the other on managing patients with sepsis this afternoon. Thank you very much, Professor Craig. We really appreciate you. Thank you.
Thank you so much. It was my tremendous honor to be here. Thank you.
I think we cannot leave for lunch and come back to wrap up these days' activities. We are sorry. Let's go for lunch. Where is the lunch taking place? Prof, thank you very much. You can join us for lunch if it's still early in the morning.
Actual lunch.
Where is the lunch site? Ground floor. Take us downstairs.
Restaurant. Downstairs.
That is from federal. I think there's one Dr. Allen, first presenter.
I will share
Alan.
it, yeah.
Okay. Oh, sir. You're welcome, sir. Media, are we having projection?
Yes, but call out all abstract presenters. They should all come out. Anybody that has known.
Hello, good afternoon, everyone. All the abstract presenters, please step forward. One of them is a pre-recorded version. Dr. Alan and Dr. Diko from Anizamiye. We have Dr. Chiso from Rivers State University Teaching Hospital. And Dr. Mary Rose, on her way up from National Hospital. Then Dr. Owoniya from Zenith Medical and Kidney Center. Please step up. Thank you. Do we start with the rest of the? Yes,
No, wait. Let's.
Can we take Dico?
All right.
So you call out the name of the slide so that I will know which one to project, please. It's a bit heavy, but it's coming up now.
It's not really.
You know, we have it in Flash or initially, but they send a WhatsApp copy.
Still loading, you can stop.
Is there someone in the house? Yes, Nico, are you ready? So that we play your own.
Yeah, no problem.
Because his own is downloading. They resent, we have the Flash version. So they now resend.
Somebody. I do want to help you. Everybody's gone. I'm telling you, there's nobody. Even I'm keeping the time as well because nobody expected to be here so long. There's a good time now, but even the time. That should be all right.
No, don't do anything. You can't see anything.
Good afternoon, distinguished chairperson, respected consultants, fellow colleagues, ladies and gentlemen. My name is Dr. Yusuf Diko. I'm a Chief Clinical Officer in Nizamiya Hospital Intensive Care Unit. And the topic of our presentation today is multidisciplinary intensive care management of severe malaria with multi-organ failure. As we all know, critical illnesses do not respect the boundaries of specialty. Most good outcomes are usually best gotten with multidisciplinary care.
This system need to be started. Let me just convert to this.
Sorry, please. We're having some technical issues.
Yeah. I need to restart it. No work. Just allow me to restart, please. Can I restart my system? It's not responding.
You have the second one.
Production. Thank you. Thank you. Sorry for the delay. So go ahead. Tap once. Click once. Forward, back.
You have the second mic. DJ. Second mic.
Attention. Power is low. Where is your mic? The other microphone now. Please pass it. There are two mics.
Why? Hello. Before we start, I think it's good to establish a few ground rules. You have 8 minutes. At 5 minutes, she will allow you.
Thank you, sir. Okay, good afternoon, distinguished chairperson, the local organizing committee, respected colleagues. My name is Dr. Yusuf Diko. I'm the senior clinical officer at Nizamiya Hospital. And the topic of our conversation today and our presentation today is multidisciplinary intensive care management of severe malaria with multi-organ failure. As we all know, critical illness does not respect specialty boundaries, and neither should its management. The best outcomes in critical care are rarely achieved by one clinician or specialty alone. They are the result of coordinated expertise, effective communication, timely intervention, and a shared commitment to patient care. Severe malaria remains a leading cause of critical illness and mortality across sub-Saharan Africa, frequently requiring intensive care. We report the case of a 51-year-old woman referred to us on 26th of October with severe malaria complicated by sepsis, altered consciousness, acute kidney injury, metabolic acidosis, and jaundice. On presentation, she was unconscious, pale, icteric, dehydrated, hypoxic, with signs of systemic inflammatory response syndrome. Diagnostic workup included arterial blood gas analysis, laboratory investigations. We took microbial cultures, including blood, throat, urine, and skin cultures. Brain MRI was done, a thorax CT was done, an abdominal ultrasound was done. And interventions that she had in our ICU included mechanical ventilation for the respiratory failure and for respiratory support. She had hemodialysis, neuroequipment therapy for the AKI. She had blood transfusion because she had severe anemia, anti-malarial and broad spectrum antibiotics, artesunates, meropenem, and vancomycin, which were according to the results of our cultures, which we will see in subsequent slides, antifungal therapy, and then anticoagulation and nutrition. The results of her investigations, the brain MRI was normal. Hematological investigation revealed she had severe anemia, thrombocytopenia, markedly elevated inflammatory markers, including procalcitonin, CRP, and the WBC count was very high. She had elevated lactate dehydrogenase levels. She had hypoalbuminemia, hyperbilirubinemia, and metabolic acidosis. The UCR revealed she had dyselectroitemia and elevated urea and creatinine, indicating acute kidney injury. And the thorax CT showed diffuse ground glass opacities, which are a sign of inflammation and acute respiratory distress syndrome. The microbiology cultures, the throat culture grew Klebsiella, Proteus, and Enterobacter species, and the urine culture grew yeast cells. So while on admission, the clinical cause, she developed respiratory failure requiring invasive mechanical ventilation, acute kidney injury with anuria, and this triggered escalation into full multidisciplinary ICU bundle with the nephrologist, physiotherapist, hematologist, pulmonologist, and respiratory and chest physiotherapists were involved. As we can see, this was the results of her investigations. On presentation, she had a WBC count of 31,000 with neutrophilia. The platelet count she was thrombocytopenic with a platelet count of 79, and the result here showed as a CBC malaria result, which is we use a Sysmex 9. It detects the amount of red blood cells that are infected with malaria. So it shows a high malaria profile was 300 with over 12% of the RBCs infected with malaria. The graph there shows the graph of her CRP. After targeted antimicrobial therapy was commenced, we can see a decline in her CRP levels while she was on antimicrobial therapy. These were the results of her EUCR and inflammatory markers. Very markedly elevated CRP of 491, bilirubin of 17, and creatinine of 8.17 with a urea of 206. The procalcitonin level was also markedly elevated with a value of 42.76. This was the result. This is the images of the chest CT showing diffuse ground glass appearance with signs of acute respiratory distress syndrome. And the throat culture there shows the growth of the organisms, Klebsiella, Proteus, and these were the antibiotics that guided our targeted antimicrobial therapy. The urine culture showed yeast cells, which is one of the reasons why we started our antifungal therapy. So, so this is this from clinical illness. She presented with a very low GCS, sepsis, AKI, respiratory support. She was it triggered multidisciplinary ICU bundle, which required ventilation, hemodialysis by the nephrology, transfusion to support the anemia and the platelets. Targeted therapy with anti-malaria with artesunate, culture-directed antimicrobials and antifungal therapy was commenced. And then she was extubated on the day 9 of admission in the ICU. Oral feeding was resumed. She was discharged stable after a total of 11 days in the ICU. So early recognition of deterioration, timely organ support, coordinated multidisciplinary critical care can yield favorable outcomes in severe malaria complicated by multi-organ failure. Thank you.
So go to the second presenter. Please very well.
Yes. Press once. Any audio? No audio.
Good afternoon, everybody. I would like to thank I-CCSN for giving me the opportunity to present our case. I am Dr. Ala Naim, interventional cardiologist in Nizamiya Hospital.
Click once. Click. Put it, you're upside down. Turn it. Turn it upside down. And forward and back. Start from beginning. Back. Good.
Okay,
so forward one.
So today I'm going to present, unfortunately, not so uncommon in real practice case, completely preventable, but potentially fatal complication. This is a case of prosthetic valve thrombosis due to anticoagulation non-compliance. This patient disappeared from follow-up for more than 2 years. No INR check, no dose adjustment of anticoagulants, and he came back only when he developed acute pulmonary edema. So past medical history of mitral valve replacement, mechanical valve in August 2022. No INR done since the last visit 2 years ago. Medications, he is on warfarin just once every 1 or 2 weeks. Is not compliant to treatment, X4, digoxin, and carvedilol. In examination, the patient was in respiratory distress, not cyanosis, no edema, heart rate 100 beats per minute, blood pressure 122/70, heart sounds. There is very important issue, absent metallic sound, which should be here. Saturation 92 on room air. Chest was, respiratory rate was 30, vesicular bilateral breathing, bilateral basal crepitation. He has pulmonary edema. Other symptoms were unremarkable. All investigations carried out, all of them were within normal, except hemoglobin, creatinine was 187 and mild hypoxemia. ECG showed sinus tachycardia with sign of left ventricle hypertrophy. Immediately we did echo. Echo showed preserved left and right systolic function, ejection fraction around 50%, mechanical mitral valve with partial stuck or thrombosed valve. Pressure, transvalvular pressure was very high, 20 millimeter mercury, should be below 5. Pressure half time, 400 milliseconds, should be below 130. DVI, Doppler velocity integral, 1.8 should be more than 2.5. Moderate tricuspid regurg and pulmonary hypertension. So, which images we should do in this case? We suspect thrombosed mitral valve due to lack of anticoagulation treatment and follow-up. Images, whenever prosthetic valve patients presented with dyspnea, do not treat as heart failure before excluding valve obstruction. So we did for him echo.
Display?
Where is
Yes, it's showing. Display. Reverse?
I like this.
Okay. We're coming back from beginning.
It's upside down.
They give us the updated one. They said they send the updated one via email.
Okay. So the echo showed very
Let me just rotate and see. Is it good now?
so echo showed prosthetic mitral valve with restricted movement.
Display, right?
Prosthetic that indicates thrombosed mitral valve or stuck mitral valve. So fluoroscopy, in our practice, fluoroscopy is often the deciding investigation within minutes. It tells us immediately whether there is leaflet moving or not moving. So this is the fluoroscopy. Fluoroscopy, as we see, there should be two, like a ring and two discs. Here, there is just one disc is moving. It should be like butterfly wings. So one disc is moving, the other one is stuck, not moving. So this indicates thrombosed or stuck mitral valve. As we see, one disc is moving. Okay, next. So how to manage the diagnosis of acute thrombosed mitral valve? Would we thrombolize to give a thrombolytic therapy or to send directly to surgery? There is no one size fit all. Decision must integrate stability, thrombosis size, and surgical risk. Surgery risk is very high here, around 30 to 40%. So our plan, admit to HDU, consult cardiothoracic surgery, oxygen, we give furosemide infusion. IV heparin, we started maximum dose for 24 hours, but unfortunately without response, still low INR and ECT. So we took the decision to give TPA, tissue plasminogen activator, 25 milligram, low dose, slow protocol within 12 hours. So review after 12 hours giving TPA, successful with excellent results, vital are stable, monitor vital signs, and as we see, the guidelines that they are supporting giving this low dose, slow protocol TPA, and according to American Heart Association and American Heart College of Cardiology, it's a class 2A. It is reasonable. European guidelines, it's a class 1. It's recommended to give a slow infusion, low dose TPA in acute thrombosed mitral valve. The trial that's supporting this, we call it Troya trial in 2013. And this is the echo after the giving the TPA, we see the valve return to normal pattern of flow, transvalvular gradient has reduced significantly, and all parameters of successful thrombolytic therapy. And this is more interesting, the fluoroscopy. Fluoroscopy after giving the, as we see now, both discs are moving. That indicates successful thrombolytic therapy of, as we see two discs, they are moving as normal, indicates successful thrombolytic therapy for thrombose or stuck mitral valve. So outcome, patient was discharged after 6 days, stable, no complaint, plan to continue treatment. After 2 months, he came for follow-up. His INR, the most important, was 3.55 on 10 milligram warfarin. So home take message, last slide. This is not just a disease, this is a system failure, follow-up, education, and anticoagulation management.
counseling and explaining to the patient the importance of follow-up and adherence to treatment, very, very important. Whenever the patient with a prosthetic valve comes with dyspnea, don't treat as heart failure before excluding acute valve thrombosis. And thank you so much.
Let's see. Once. Press once and that's all. Back. Once is okay.
Good afternoon, everyone. Dr. Chisowa Balinka. I'm a consultant anesthesiologist and I'm the lead intensive care lead at the River State University Teaching Hospital. So let me say that the River State University Teaching Hospital intensive care units started actively 3 years ago, and this is a pool of the data we have gathered. We're looking at what we've done so far. So we all know that the intensive care units are vital in managing life, and in many developing countries, critical care is still developing, especially with all of the challenges that we have now. Mortality rates in intensive care units amongst African countries is very, very high. In our study, we saw that in Ethiopia, it was around 25%, Nigeria, 35%, Tanzania, around 35%, and then, of course, in Kenya, about 60%. So the patterns vary widely, and we're looking at it, we're saying, okay, so what patterns do we have here at the River State University Teaching Hospital with all of the equipment we now have? What do we have? Okay.
Press once.
Sorry. Okay, so though we just started and we can provide the third level of care, we still have a scenario where we have a lot of shortage of staff, and we also have problems with people obeying your ICU admission protocols. So therefore, we decided to look at this to help us strengthen what we are doing currently. And then we also assess the mortality and the patterns. It was a retrospective study, descriptive study that was done. We acquired data from all of our registered, and we looked through everything we had done in the last 31 months. Okay, so our findings, what did we find? Most of them were within the ages of 49 years. What's happening? But within the ages of 49 years, they were amongst the mostly young population, as have been seen in other studies. Okay, and then we found that neurological conditions accounted for the highest indication of ICU admission, while renal conditions were the least. And then 42% of the patients had invasive mechanical ventilation. And we found something really interesting, that most of the patients that had non-invasive mechanical ventilation had an 80% odds of mortality than those receiving invasive ventilation. And one would think that this may have been from, you taking it for granted that because they were on non-invasive, that they were going to be fine and they will progress and leave the unit. Okay. About 27% of the population was transfused with blood. Most of them were post-operative cases. And then 52% of the patients were nebulized, which is almost in keeping with the number we had that were mechanically ventilated, because as part of our protocol, we will nebulize them after extubating to help up the airway. Only 15% had tracheostomy. So we have a problem. Most of the patients, once you tell them, oh, the family members, you need to do a tracheostomy, they run away from it. They are very afraid. They don't want to do it. They ask you, oh, doctor, it's like you're killing them alive. And then we have 41% of the patients needing inotropic support. And then the mean duration of stay range from 1 hour to 32 days. Okay, so length of ICU stay remains significantly associated with mortality, with each additional day increasing the odds of death by approximately 9.6%. And this was as a result of most of the patients, once they come in, the first 1 week, you see them, the relations are very active, providing, but after 1 week, catastrophic healthcare cost becomes a problem. They can no longer do investigations. They cannot buy antibiotics. They can't even give you anything you need to work with. So you're literally struggling to
take care of these patients. And then in our study, we found out that age was not a significant predictor of outcome. Maybe because of the population we admitted, most of them were within late 40s and early 50s. Okay, so while we had 49.3% of the patients transferred from the ICU to other wards, we had a mortality rate of about 43.3% on the average. Okay, so basically we want to say that in River State University Teaching Hospital, we found that most of the patients came in as a result of neurological admissions. And then we had a mortality of 43.3%, highlighting the need for enhanced critical care resources to reduce mortality in resource-limited settings. Thank you.
Playing recording. Let me project your own first. You press. Yes, then the other one to go back. No, don't point because of the screen digital. Let it come out first. That one is WPS, not Microsoft Word. Microsoft, so it was a bit of. So press once, back, confirm. Once, back, once is okay.
Good evening, everyone.
Mike.
Good evening, everyone. My name is Mary Rose Osazwa, and today I'll be presenting a 5-year review of pediatric admissions into 3 intensive care units at National Hospital, Abuja. In Nigeria, critically ill pediatric patients are managed alongside adults because we don't have many pediatric ICUs. In fact, pediatric ICUs are very, very few. And the demand for pediatric critical care services are rising. The demand is rising. A clear understanding of the patterns and outcomes of pediatric admissions into ICUs will help our healthcare systems to prepare better, to plan better for this population. So our aim in conducting the study was to identify the indications for pediatric admission into the ICUs at a tertiary hospital in Nigeria, the clinical interventions in the ICUs, the length of stay, mortality rates, and factors associated with outcome. It is a 5-year retrospective cross-sectional study of all admissions of patients less than 18 years into the main ICU, trauma ICU, and cardiac ICU at the National Hospital in Abuja from January 2016 to December 2016. 203 patients were admitted during the study period. 161 had complete records and were further studied. So this shows the number of pediatric ICU admissions per year. It shows how the number increased from 2016, peaked at 29, and then there was a slight dip in 2020. And then this shows the percentage of pediatric admissions into ICU as a fraction of the total admissions into those ICUs. So you see even the fraction also is increasing from 1.4 to 11.4%, and then it dropped to 6.6% in 2020. Now, the highest indication for ICU admission was for airway management and ventilatory support in these children. For diagnosis, the commonest diagnoses were respiratory conditions like bronchopneumonia, airway obstruction, croup, aspiration, and then followed by sepsis. Okay, looking at this table, you see that the 1 to 5 years was the commonest age group that were admitted in the ICUs. And then most of the admissions were in our main ICU. And then at the type of ICU where these children were admitted affected outcomes. So those admitted in the main ICU had more mortality.
And then for the source of case, even though more surgical patients were admitted, that's 79 there, mortality was more in medical cases. For Glasgow Coma Scale, the lower the GCS, the more, the higher the mortality. And then for mechanical ventilation, those who were mechanically ventilated, they had a higher mortality too. Other oxygen therapy devices we used in the ICU were face masks, nasal prongs, non-rebreather masks, and tracheostomy. And then the children also received antibiotics, anticonvulsants, inotropes, blood transfusion, diuretics, steroids, and hemodialysis. Interestingly, the nurse-patient ratio in the cardiac ICU was 1 nurse to 1 patient or 2 nurses to 1 patient. However, in the main ICU and trauma ICU, is 1 nurse to 2 patients or 1 nurse to 3 patients. So the outcome, 57.8 patients were discharged from the ICU, and mortality rate was 41.6%. Like I mentioned earlier, the type of ICU significantly influenced outcome. In the mortality rates in the cardiac ICU was 5.6%, it was the lowest, compared to 46.8% and 42.1% in the other ICUs. The admissions of children into our ICUs have increased over the period studied, from 7 in 2016 to a peak of 62 in 2019 and then 30 in 2020. This shows there's an increasing demand for ICU care in children. The dip in 2020 is most likely due to COVID, because there was real restriction of movement, and then electives were all but cancelled for a long period during COVID. Now, the highest indication for ICU admission was airway management and ventilatory support in this study, while the commonest diagnoses were respiratory conditions and sepsis. This is not surprising. Respiratory problems are a leading cause of critical illness and cardiac arrest in children, and sepsis is a common cause of ICU admission in our environment and other environments. The cardiac ICU patients had very low mortality rate compared to the other ICUs. In our hospital, congenital cardiac surgeries are done with local and foreign faculty, and they come with a lot of things. The ICU nurse-patient ratio, like I mentioned earlier, is higher, and then the consumables, the staffing, the funding is well taken care of, unlike in our regular ICUs. The mortality rate in our study was unacceptably high. Compared to some other studies in Africa and in the US, it was way higher. Although one study in Nigeria recorded a higher mortality rate. And the mortality in our study was associated with mechanical ventilation, low GCS, and a medical diagnosis. So requirement for mechanical ventilation and low GCS are indications of disease severity. Hence, mortality in our research can be inferred to be more in children with higher disease severity. In conclusion, there is an increasing number of pediatric admissions into ICUs at National Hospital, Abuja, Nigeria, with 58% survival rate. Airway management and ventilatory support are leading indications for admission, while respiratory conditions and sepsis are common diagnoses. Patients admitted in the cardiac ICU fare better. Mechanical ventilation, low GCS, and medical cases are associated with higher mortality. Thank you.
Next presenter, Dr. Maitama.
Starting with adult sepsis or respiratory tract for anyone.
Anyone, sir.
Press once, the pointer. Is it good?
Good evening, sirs. I'm Dr. Onia. I'm a consultant anesthetics at Zenith Medical and Kidney Center here in Abuja. I'll be presenting two case reports.
Mike, volume? No, put it close to your mouth so that.
Okay, so I'll be presenting two case reports. The first one is titled From Respiratory Tract Infection to Multi-Organ Failure, a case of severe pediatric sepsis with acute kidney injury and fungal superinfection. So this patient is a 2-year-old boy who was referred from another private hospital on account of sepsis complicated by acute kidney injury. So the symptoms began 6 days before prior to presentation. He started with cough, catarrh, and later the cough became progressive and became worsening. Initially, the mother managed the patient with over-the-counter drugs. Then later, the condition became worse, necessitating being taking the child to another private hospital. So at the referral center, the patient was noticed at presentation to be anemic. So they had to transfuse, but the condition became worse after the transfusion. So that was why this patient was transferred to a facility for expert management. So at presentation, the patient was in severe respiratory distress, respiratory rate as high as 80 cycles per minute, with suboptimal oxygen saturation, saturating between around 55% of the saturation or 55% on intranasal oxygen. The baby was tachycardic, hypotensive, febrile, jaundice, and also had an episode of convulsion that was aborted at presentation. So these were the investigations at presentation. WBC showed a markedly elevated WBC. The WBC was 43,000 with neutrophilia. Then the lymphocyte count was also low, which was suggestive of lymphocyte paresis. Then the thrombocytopenia too. Platelet count was as low as 60,000. The CRP was severely elevated, 462 milligram per liter. Then add dyselectrolemia, severe hyponatremia, marked hyperkalemia, hypocalcemia, and the urea and creatinine were elevated. Liver function test was severely elevated too. Then the clotting profile was deranged. The analysis showed 3 pluses of protein and the trace of blood and the traces of protein. The abdominal ultrasound done showed the patient had bilateral pleural effusion, ascites, and though the kidneys appear to be normal in size, but has increased cortical echo density. The chest X-ray done also showed pulmonary edema. So an assessment of severe sepsis, probably chest focus was made with complicated with AK high. So immediately this patient was intubated and was moved to the ICU for mechanical ventilatory support. The patient was also commenced on vasopressor because of the hypotension. The BP at presentation was 62/42 without mercury. Then he was also placed on IV antisonate because malaria is one of the commonest things in our environment, considering that age group, and was commenced on antibiotics, meropenem, levofloxacin, and clindamycin. The hyperkalemia notice was corrected, and other electrolytes abnormalities were also corrected. Was given calcium gluconate, and other abnormalities were corrected. He was managed conservatively for the kidney failure and was placed on LASIS after the BP has optimized better on vasopressor. So this is the trend of events. The first 3 days, the patient had the patient blood level dropped. So the patient was transfused, and the patient was still maintained on mechanical ventilatory support and was still being supported on vasopressor. The patient has persistent fever between day 4 to day 7 on admission, and the previous antibiotics that were commenced had to be discontinued because of this persistent fever. Although during this period, the patient renal function was improving. Then on POD8, the patient was commenced on polymyxin B. The other antibiotics were discontinued because of the persistent fever. But after the change of the antibiotics, the patient's condition appears better. We're able to wean him off vasopressors, and the patient was extubated, and the post-extubation vital signs were stable. However, the blood culture normally takes like 7 days in our environment. The blood culture and urine culture came out to be negative. However, this patient still has persistent fever. So because the patient was extubated around this period, the ETT catheter tip was sent for MCS, which came out on between day 11 and 13, the growth of Candida began. And that was what gave us the idea that this patient has a superimposed fungal infection. And the patient was commenced on fluconazole. So immediately that was commenced, the patient fever started subsiding and WBC dropped significantly. And the patient was discharged from ICU 20 days after admission. And these were the values of the CRP and the WBC at discharge from the ICU. And the patient was discharged home on POD 23. So this is just the trend of the electrolytes. We can see how the creatinine improved over time and how the urea level 2 improved. Then this is also another one that shows the decrease, the progressive decrease in WBC based on the time at admission. And can also look at the WBC, the lymphocyte counts that improved significantly as the patient's clinical condition improves. So in conclusion, this case illustrates a fulminant pediatric sepsis with multi-organ dysfunction, AKI, respiratory failure, and shock. But early ICU admission, prompt antibiotic commencement, and timely ventilatory and vasopressor support were crucial and also improved the survival of this patient. So, and this another thing we should learn from this case presentation is the fact that superimposed fungal infection could sometimes be one of the reasons why patients stay longer in our ICU. Thanks. So I'll be presenting the second case. Sepsis. So this is another case I'll be presenting. It's also a case of an adult sepsis titled The Reversal of Septic Shock and Multi-Organ Failure Following Source Control of Perforated Appendicitis with Multi-Drug Resistant Klebsiella Infection. So this is a case of a 51-year-old man that was referred from the private hospital with sepsis complicated by AKI. The patient presented with abdominal swelling, vomiting, and passage of loose stool, fever with associated abdominal swelling. This patient was initially managed as a private setting as a case of sepsis with query intestinal obstruction. So they were managing this patient conservatively. So this patient, during the admission at the referral center, developed sudden difficulty in breathing, became hypotensive, was admitted into their ICU, and so was started on vasopressor. But his clinical condition deteriorated further, necessitating him having 2 sections of hemodialysis at the referral center. But despite all that, the condition deteriorated further, and he was subsequently referred to our hospital for expert management. The patient is a known hypertensive diabetic with previous history of stroke. So at patient stage, at presentation, the patient was conscious but agitated and febrile. The patient was 38 degrees Celsius. He was also in severe respiratory distress with widespread chorus palpitation bilaterally, with suboptimal oxygen saturation while on non-invasive ventilation. We have while on non-bleeding face masks. These were the vitals. It was tachycardic too. They've commenced him on vasopressor at the referral center. That's why we have this blood pressure at presentation. The tummy was grossly distended and he had an NG tube in situ that was draining fecal matter. Fecal effluent. So this was his investigation as admission. The WBC was mildly elevated, though he has symptomophilia. PCV was fine. The CRP initially was not elevated, was slightly elevated because our cutoff is 0 to 5 milligrams per dl. The HbA1c, then he also had elevated creatinine and urea. The liver enzymes were just mildly elevated. Clotting profile was nothing significant, just mildly elevated. Then the ABG done showed he had metabolic acidosis and hypoxia based on the oxygen therapy he was getting at that point. Chest X-ray showed hypertensive disease in failure, suggestive of chest infection. Then the abdominal ultrasound showed multiple intra-abdominal collections. Then the kidney functions were a bit enlarged, and the echogenicity were preserved. So an assessment of septic shock from suspected perforated viscous was made, complicated by AKI and ARDS. This patient was initially commenced on non-invasive ventilation with plan for possible intubation. Then he was commenced on non-adrenaline infusion. He was initially on dopamine infusion from the referral center, so we had to change him to non-adrenaline infusion, and this showed he was on high dose of non-adrenaline infusion to maintain the blood pressure. So antibiotics was commenced, meropenem, levofloxacin, and metronidazole. Then this patient was also commenced on insulin because the blood sugar was highly elevated. This patient was reviewed by the nephrology team and the surgical team. Initially, this patient was commenced on CRT because the relatives had this denial of the diagnosis because they were told this patient was initially managed for what this patient had was intestinal obstruction that they wanted to manage consultation from the referral center. So when we told them this patient had perforated viscous, that we are suspecting that he has perforated viscous, it took them 48 hours to consent to surgery. So while waiting, we started the CRT while they gave the consent. So eventually, this patient had emergency explorative laparoscopy done 48 hours after admission into the hospital, and he had 700 mils of pus drain into abdomen during the surgery. So intraoperatively, this patient had an episode of hypotension, which we had to go higher on the vasopressor. Then immediately post-op, he was commenced on vasopressin at 2 international units per hour, and IV Advocate 2 was also given just to supplement because of the higher need for vasopressors. This patient was electively ventilated for 48 hours and was sedated. So this is just the investigation flow showing the pattern of events from admission to day 10. So this patient, between the first 2 days, initially, as I said, we had delay in having the surgery done because of the denial, because of the relative failure to give consent. So the clinical condition initially worsened a little, then later we had some improvement. So this patient was fortunately extubated, between day 3 and day 4, the vasopressor was stepped down, and the patient was weaned off ventilator and extubated. And by POD 8, this patient was successfully weaned off vasopressors and was transferred to the ward. So this case demonstrates the life-threatening progression of perforated appendicitis to severe intra-abdominal sepsis, septic shock, AKI, and respiratory failure. So despite multiple organ dysfunction and multigram-resistant Klebsiella infection, prompt in-source control, targeted antimicrobial therapy, and intensive organ support resulted in recovery of this patient. Thank you very much.
Did that. We through for today.
No, we are not through yet. But I just got information that some people are beginning to forget their questions. So just at this point, I want us to take questions, then we can now conclude with the others. So far, we have had 6 presentations. The first one was from Dr. Diko. He talked about...
What is wrong? Audio?
Audio.
Mic is off.
Okay, he talked about multidisciplinary intensive care management of severe malaria with multi-organ failure. We had Dr. Alan, who talked about successful low-dose thrombolytic therapy for partially thrombolized mechanical mitral valve, a case report. We also have had Dr. Chiso Waba. She presented what was this? Patterns of admission into the ICU. Okay, how patterns of admission into the ICU changed. Report from a tertiary hospital in Nigeria. And then we had Dr. Mary Rose. She presented a 5-year review of pediatric admission into 3 intensive care units at the National Hospital, Abuja. And Dr. Temitope Owoniyi presented 2 topics. One was from respiratory tract infection to multi-organ failure, a case of severe pediatric sepsis. And then the second one was reversal of septic shock and multi-organ failure following source control of perforated appendicitis with MDRO Klebsiella infection. So maybe if we identified them with their faces, maybe I will just ask them to join me at the stage while we take questions from the audience. Can we get cheers for them? Oh, we know them. Okay. So, questions?
Yeah, thank you. I'm Bibi Oshinaike. I have a question from Dr. Chizo. Chizo Babali. incidents, the mortality reported following NIV is a bit of a concern to me. And I want to find out from you, do you have a policy for non-invasive ventilation in your institution? Because if you have a policy or protocol guiding those that will go on NIV, when they should leave NIV, I don't think that mortality should be, I'm not sure it should be that high. So just let us know. Because if there's no protocol, there's a tendency to put those who actually need invasive on NIV. And what the patient will not make it. So do you have that? If you don't have that, that might be necessary. Thank you.
You want to respond? Oh, let me wait. Okay, wait, just take notes. Just take notes. Mommy will exactly.
Thank you very much, all the presenters. I have a comment to the cases from Zenith. The patient with the sepsis, you did everything to make the patient survive, but you never gave any fluids. So please, if you are presenting, if you are writing that up, there's no way you'll be managing that patient with sepsis, cardiovascular, shock, and there was nothing mentioned of fluid therapy. Thank you.
Any other question? What of virtual? You can request if they are around.
Thank you all presenters. Fantastic efforts to showcase what you're doing at the various ICUs. To my friend Tope,
when they bring back the mark,
I just like slight correction. There's nothing like severe sepsis. An old concept. Sepsis is severe enough to be sepsis. The second part is mass taking care of that. When did you do blood culture? No, where did you do blood culture? Was it because the 1 hour sepsis bundle says that first hour, as most of the patients you had were referrals from outside the hospital. So as the first time they came, to be in A&E, blood culture is taken. And I found out that from your intervention, like you have a protocol where you use meronym levofloxacin because you're a renal center, I don't know why. Is it based on microbial profile you've identified that most of the organisms you get are sensitive to meronym levofloxacin? That's why you routinely place them on that. That is for you. To my sister, Nkashubi, our past president talked about indications for NIV and for conversion. You can place a patient on NIV now. In the next second, if you miss criteria for intervention with an invasive, you move on. That will probably reduce the percentage directly mortality. And then the question is, for you and Mary Rose, we have a 46% mortality in our ICUs. What do they die from? Because it's important for us to identify. There was a fine study from UNILAG, from University of Lagos, about causes of death in eclamptic patients. And it was very interesting. They identified tubular necrosis, they identified the intracranial bleeds, specific things that cause death among patients. So if it's possible for us, I know from your case anyway, I had reported the same thing about neurological cases becoming the highest indications for ICU, for medical indications for ICU admission. And then both of the cases you get are basically, they present with secondary brain injury. I'm sure you don't get any acute stroke case coming to a public ICU. It's almost impossible. So they come in when they are either gotten aspiration pneumonitis, secondary brain damage, and you end up to delay their time of exit. And that is one of the problems. So I think it's important. Take home message is that it's important in our various studies now. Maybe you can pull studies together and find out what really are the causes of death in resource inexperienced centers or resource poor, call it poor, resource poor, resource inexperienced. Maybe find a way of defining this resource limited, because Nigeria has money, so it can't be resource limited any longer. The guy resource inexperienced or that is it. So that'll be a fine word. For the guy that presents malaria, malaria, you said MOD from malaria. I talk about acute kidney injury. I didn't see you see pictures of ARDS as a long complication of the other components of MOD. You mentioned renal, and I don't know what you mentioned respiratory, but if it's respiratory, you have shown the image. It's interesting to show it. I had published one on ARDS from severe malaria, and it'd be interesting for us to showcase that kind of thing. Thank you very much.
For the online now.
This is just a general comment to most of the presenters, and that is the importance of showing graphics, especially if it is case reports. With graphics, it will encourage listeners to follow what you are telling us. And especially, I'm directing this to Dr. Wunia. I was looking forward to seeing your patient that had a distended abdomen, among other things, and there was no graphics at all. Please, it's very important at meetings like this for anyone presenting. If there are graphics, please show them. Thank you. Well done, everybody. That was excellent.
Thank you very much, sir. Concerning the use of meropenem and levofloxacin, because our center is a kidney center, most of the time, once they are seeing the patient is coming from another center, they usually want to start peak. So they usually start with meropenem and sometimes the levoflox. Sometimes they go as high as polymyxin B, polystine. That's just the protocol because the patient is coming, so they assume the patient is coming. Then with the patient with WBC of 43,000, we just have to eat it early. That's why they usually start with meropenem, levoflox, and sometimes they escalate beyond that.
So they use polymyxin B as a monotherapy, like one.
No, the combination. But I'm just saying sometimes they may have to escalate.
It's not that is polymyxin it's possible. But in the advice, my saying, no, okay, sorry, my
We had a presentation about 2 weeks ago or something on the polymyxin B, and it was shown that it's effective, all right, but its penetration is poor. So its penetration into the organism is poor. So you need another antibiotic, to add on to it to be effective. That was from, I don't remember the company. Yes.
Good evening, protocol of that. Dr. Ojum is the name. My question is to consultant who presented from Senior Hospital for the child at 53, 55 saturation, something like that. Okay. I just want you to explain to us a little bit about when you had that 53, how long did that prolong? So, they came from one tertiary institution to another institution. Can you approximate the time? Because at that 53, you can have organ dysfunctions. What is the CNS level? Do you check the coma skill? The things you need to know, because at 53, you understand what has happened to the brain at that time. And then suddenly the patient recovered completely. No. So thank you so much.
Before you answer that, let's take some questions online. Okay. So there's a hand raised of Dr. Daramola.
Yes,
can she hear me?
Yes. Can you
unmute? Yes, I've unmuted. Good afternoon, everyone. Can I be heard?
Yes. We can hear you.
We can hear you.
Thank you. Good afternoon. I would like to congratulate all the presenters. Before I do that, I want to congratulate Professor General Obashino Ogunbi. Daddy, congratulations on the inaugural. God bless you, sir. Hello?
Yes, we're with you. Question?
Okay, so thanks to all the presenters. My question goes to the last presenter, Dr. Temitope Owoniya. Like Daddy said, it would have been nice to see the picture, of course, the face blocks of the patient that came in so badly and then, going out good. My question is on you said the patient had session, that's renal replacement therapy. I guess that's hemodialysis, if I'm correct. It would have been nice for you to tell us how many sessions he had before surgery. You said it took about 48 hours before the patient was finally gotten into the theater. So I just wanted to know how many sessions he had, the trend of you showed us the table of the investigations, but the EUCR was not really among what you showed. So how many sessions of the dialysis, if that was what he had? That was my question. Thank you. Thank you very much, everyone.
One other question, but no name.
Thank you very much, Dr. Daramola. The patient had 72 sections of the hemodialysis, that's CRRT, continuous renal replacement therapy, throughout those periods. He had 48 hours initially before the surgery, had another 24 hours after the surgery. So in total, the patient had 72 hours of continuous renal replacement therapy. Then hopefully my next presentation, I'll put more pictures. Thank you very much. Then, sir, for your question, sir, in our facility, we have 24-hour coverage for anesthetists. So immediately the patient got to the A&E, the anesthetist on call intubated. GCS, and as I said at presentation, the patient had an episode of convulsion at that point. So immediately the patient was intubated, moved to ICU. So there was no delay. We didn't know how the delay between transfer, though the mother mentioned that the first convulsion was during transfer from the referral center. So I assume we didn't lose so much time between the convulsion the boy had during transfer and the second episode he had at presentation. But he was intubated immediately, moved to the ICU, and within the first 2-3 days, the consciousness improved. And this patient, I said, spent 23 days in the hospital, spent 20 days in the ICU. He was one that had superimposed fungal infection. So I felt the delay was not much because we have a 24 hours coverage and the patient was intubated immediately.
We also have another question online. That's for the first presenter. I would like clarification on how they made the diagnosis of severe malaria, but some of the investigations like the WBC levels, culture results, and CRP were somewhat suggestive of sepsis.
Yes, thank you for that question. In one of the slides, I did show that we did a malaria profile for the patient. It was positive, 3 pluses, and the patient had other clinical and laboratory features of severe malaria. The patient had hyperparasitemia, the patient had acidosis, there was severe anemia, the patient was comatose, he had ARDS, as I did show I did show pictures of the CT scan that showed diffuse ground glass opacities, which are not specific, but maybe indicative of ARDS. And then, yes, of course, the patient had sepsis, but the severe malaria diagnosis was also made with laboratory investigations. Thank you.
Okay, before we wrap up this session, just a comment on the presentation by Dr. Osazuwa. If I'm right, you compared 3 of your ICUs. I don't know if you have this experience we have in our own center, where when the physicians see that a patient is about to die, they tell the relations that the ICU is where the magic is going to happen. So I don't know if you considered that while you were doing your study or doing your comparison.
Kelechi. Kelechi, do you want to comment on that? She's one of our intensivists. My presentation was on pediatrics, and there's this the pediatricians, they always like to try as much as possible to treat their patients. When they see it's getting beyond them, then they invite us. But for the adults, I think Kelechi has something to say about it.
Yes, well, our experience is that by the time the patients are coming to us, they're already in multiple organ dysfunctions, and we're already supporting multiple organs. So it looks like it's when they're close to ES, that's what happens. And for the children, it's also the same. The pediatricians push as far as they can go. I don't know why, maybe because we don't have specific ICU for children. So they push as far as they can go. And then, so it's the same situation. Thank you.
Thank you very much, Kelechi. And just to add to what you said, you are right. They tell the relatives that we've invited the anesthetists. They are coming, as if the anesthetists are coming to lay hand and wake the patient up or revive the patient.
Good evening, everyone. Thank you so much, Prof, for the insightful comments you made on my presentation. It's a take-home note for me because I've never really thought of having the policy. I will go back and make sure we pull up a document that guides us like that. But the experience we had, or the challenge I had for a long time, was you have a situation where the residents at that time in the ICU could not intubate by themselves. So they will struggle, put the patient on CPAP. By the time you're coming, the patient is almost gone. There's little or nothing you can do. So that was the major challenge we were having at that time. But yeah, manpower shortages. But well, I would say that it has improved a little because now we have senior registrars and the registrars have also become skilled in intubation. So it's a lot better. Thank you so much.
Let's clap for them as they go back to their seats. Thank you very much. We have 2 more presentations. It seems Dr. Omoni is still there. Dr. Demladi Omoni. Okay, that's you. And then the other presenter is online.
So are you the one? Are you the Omoni? Call out your slide name. You submitted it here, right? Is it this pattern of disturbance? Thank you. 1 minute. Pointer not on the table. It's on the table.
Good evening, sirs and mass. Standing on existing protocol, I would like to take this presentation on patterns of electrolyte disturbances and the association with mortality and length of stay among adults intensive care unit patients. These are the authors of the study. This electrolytemia, abnormalities with electrolytes balance is quite prevalent among critically ill patients, and the etiology is multifactorial. Will be from the fact that the diagnosis the managing diagnosis, the fact that the patients might have multi-organ dysfunctions, even cross-interactions from medications could be a cause of this dyselectrolytemia. And then, but what we have found out also is that it could be linked with adverse clinical outcomes. So the objective of this study was to evaluate the pattern of baseline admission electrolytes and to determine their effects on the length of stay and patient mortality in ICU. So it was a retrospective study. Actually, the inclusion criteria included that of adults more than 18 years of age, patients who had data that could be extracted from the records adequately. And then this study was actually done when the data was actually put from both public ICU and private ICU in a ratio 2:1. And then the baseline electrolytes were actually assessed, reported, and then analysis were done on them. So what we found out basically was that we were able to put about 292 patients and with a male predominance of about 52.1%. The baseline, even though the gender difference was slightly there, but it was not so significant enough to have affected the results we had. So, and among them, we noticed also too that neurological disorders were the major reasons why people were admitted into the ICU, followed by trauma. And the trauma was actually more among the male gender. So going to the disturbances that we have with the electrolytes, we noted that the most significant of them was hypokalemia, about 40.4% among the patients' data that we pulled. And more importantly is the fact that this, when we analyze this further, we notice that when we compare the disturbances, the imbalances in the electrolytes with the outcome, patient outcome vis-a-vis the mortality and then the length of stay, we notice that for mortality, those that showed in significant association was that of sodium disturbances, potassium disturbances, chloride, and creatinine. On further evaluation, we realized especially that hypernatremia, hyperkalemia, hypercreatinemia, and hypochloremia were the main ones that actually tend to show trend towards mortality. And still further evaluating it now, having taking care of the confounders like age and Glasgow Coma score at admission and the use of ventilator, we were able to further pinpoint that hyperkalemia and hypercreatinemia were the main independent predictors of mortality among this group of patients. Also, too, we also noticed that patients who had invasive ventilation requirements also had more, it was actually also an independent predictor of mortality, as well as increasing age of the patient. Also, as regards the length of stay, which is also one of the outcomes we assessed, we realized that hypernatremia was the major independent factor that affected the length, that prolonged the length of stay among these patients. Also, the need for invasive ventilation. So, just as I said earlier, males were the most common, were more of the patients admitted, and then mostly from neurological disorders, especially trauma. And hypokalemia was the most common electrolyte disturbance we noticed from our study. And also we noticed that potassium, chloride, sodium, and creatinine disturbances were factors that affected mortality, and more importantly, hyperkalemia and hypercreatinemia were independent predictors of mortality in these patients, while hyponatremia was for length of stay. So we had limitations with this study because the retrospective design, we're not able to pull as many records, we're not able to actually trace some of the other co-founders that might have been responsible, like medications that were used, and we could not really actually track them. And then also we could not effectively categorize these patients based on other scoring systems like Apache, so it's actually limited our study. And then the fact that we focused on only admission electrolytes imbalances also a limitation to this study. So in conclusion, electrolyte abnormalities are highly prevalent among adult ICU patients, while hypokalemia is the most common derangement. Hyperkalemia and hypercreatinemia independently predict mortality, and hypernatremia is an independent predictor of longer length of stay among adult ICU patients. Thank you.
Data is online. The last.
Good morning, everyone. I am Dr. Choma Ruth Ilabache from the University of Nigeria Teaching Hospital. And I'll be making this presentation on behalf of my team. The title of the presentation is The Outcome of Severe Penetrating Brain Injury in the Intensive Care Unit of the University of Nigeria Teaching Hospital, Enugu. A case report. I'll be making this brief presentation using the following outline. I'll start by saying that traumatic brain injury is a leading cause of mortality and morbidity worldwide, even more so in Africa, in the African sub-region. It is defined as a disturbance of brain function caused by an external mechanical force causing a spectrum of cranium-implicated pathologies. Traumatic brain injury can be classified based on the Glasgow Coma Scale on presentation, where mild traumatic brain injury is described in patients who present with GCS of 13 to 15, and severe traumatic brain injury is described in patients who present with GCS of 8 or lower. And of course, severe traumatic brain injury has a worse prognosis. Traumatic brain injury can also be classified based on the mechanism of injuries into penetrating and non-penetrating brain injuries. Now to the case presentation proper. So we had a 22-year-old male final year law student who apparently fell from an uncompleted 3-story building on campus and got impaled on 60mm rods through his cranium and right lower limb. He was admitted into our facility with a 12-hour history of decreased consciousness, GCS was 8, and impalation injury. The time frame from when he was found to when he was presented, most of it was spent trying to get the right equipment to cut the rod and free him from the impalation. So he had, on presentation, he had emergency frontal parietal craniotomy, he had debridement and foreign body removal on that same day, and then he was subsequently admitted into the ICU. The intraoperative findings were eviscerated brain tissues, rusty impaled rod lodged in his brain, comminuted skull fractures, a deep crater in the impaled fractured bone, and a tense non-pulsatile brain. Other injuries were bilateral C7 facet joint injury, had a damage to the right eye. He eventually lost that eye, and he had injuries on his right lip. So this is a picture that was taken in the emergency room on admission. So that's the 60mm rod. This is another angle. And this is the rod after it was surgically removed. While on admission in the ICU, he required mechanical ventilation and management of neurosepsis, in addition to other supportive care. Samples for microscopy and cultures were obtained prior to surgery, and antibiotics were commenced intraoperatively while awaiting results. Initial blood culture, urine, MCS, intracerebral aspiration, tissue culture microscopy yielded no bacterial growth, but he was prophylactically commenced on intravenous vancomycin, metronidazole, and ceftazidime. Despite prophylactic antibiotics therapy and initial negative culture results, he continued to have high-grade continuous fever, and so antibiotics were subsequently escalated to clindamycin and avibactam with piperacillin and tazobactam. Patients had surgical re-exploration and abscess drainage with placement of external ventricular drain a week after admission following worsening of clinical states and CT findings of multiple pockets of intracranial abscess along the foreign body tracts, resulting in obstructive hydrocephalus. He also had percutaneous tracheostomy done on the 14th day of admission. So following the EVD placement, we were able to get an EVD tip, MCS, which revealed polymicrobial growths of Klebsiella pneumoniae, P. aeruginosa, and methicillin-resistant Staph aureus. And these organisms were resistant to all the antibiotics tested. So this diagnosis led to the commencement of intravenous tigecycline and azathiranum based on recommendations by the microbiologists. Following this, after a few days, there was a gradual resolution of the neurosepsis and improvement of patient's clinical state, and he was subsequently discharged to the ward after 44 days in admission. Traumatic brain injury can lead to sequelae such as infections, as in the index patient, deep venous thrombosis, aspiration pneumonitis, stress ulcers, among others. Prevention of these sequelae, as well as effective treatments when they do occur, may greatly influence outcome. Critically ill patients are particularly vulnerable to infections caused by multi-drug resistant organisms due to their severe underlying conditions and exposure to invasive procedures and broad-spectrum antibiotics. Even in our index patients, the impalation with a rusty rod had already predisposed them to infection from the get-go. So when infections occur in these patients, timely and appropriate therapy becomes a race against time. Challenges in managing this group of patients include a limited pool of antibiotics, like we saw in our own case, and then mimicry of non-infective conditions with infective syndrome. So at some point we were wondering whether this was the high-grade fever, the continuous high-grade fever was due to cerebral causes or due to neurological causes, maybe damage to the hypothalamus. Another challenge is slow conventional diagnostic microbial modalities. Most of the time, before you can get preliminary results, 24 hours would have elapsed. So these are the challenges that face us in managing these patients. So examples of multi-drug resistant bacteria include Enterococcus faecum, methicillin-resistant Staphylococcus aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter baumannii, and Enterobacter species. These are aptly called escape pathogens. In conclusion, adequate source control, adequate infection control measures, as well as antibiotic stewardship remain the mainstay of prevention and management of antimicrobial resistance. And this requires a multi-specialty approach to prevent mortality and limit morbidity of critically ill patients. Thank you.
All right, thank you very much, Dr. Chioma Iluabachi. I don't know if she's online. Is she online to take questions?
Not online.
She's not online.
But it's pre-recorded, and the timing was earlier meant for morning, but so I don't know whether
Okay. So,
Don't be afraid of money that your guy is asking you question. I'm not sure if you're going to answer though. It's just for understanding. You know, when you present something and you say, you look at the electrolytes on admission and you compare that, look at the outcome of such patients, you have a huge gap between admission and outcome of such a patient. And a lot of things will have happened along the line that will not allow you to be able to directly link what happened at admission to outcome. So what people do in the ICU, what researchers do, is to look at those things you didn't or the study did not look at. The severity of illness of each of these patients, if possible from admission and along the line until they were discharged. You cannot compare patients across board and say, okay, their illness actual severity were quite similar. The other thing you mentioned, which was quite interesting, is that you got data from private and public ICU, which is quite good. But I would have loved to see the outcome, because the care offered at the two settings differ. So if you had told us, maybe it was not part of your goal really, what the outcome we had from those in private setting and those in public, I'm sure it will be different, because we know what happens in our private ICUs. Even in fact, getting results even on admission might even be a challenge in some ICUs. Okay, so as much as possible, it would be nice to look at things comprehensively. So please, in the ICUs, at meetings like this, let us, in fact, not even at meetings like this, for researchers in the ICU, let us incorporate severity of illness or scoring systems in the ICUs. It will help us to be able to compare my own ICU with your own ICU, so that I can know that, I'm doing well, I'm not doing well. Thank you.
Sorry to, I think Dr. Paul or Dr. Akona can answer the question on behalf of Dr. Ilaboche. Paul, are you part of the study, please? Dr. Paul, you sleeping? Because, yes, the issue is, I don't know, the reason why I'm asking, it's not a question, it's a comment. Was this case presented at Enugu? Yes or no? So there was no basis presenting this case here.
okay.
Yes.
Last conference.
Yes, now. Is it a similar case or what? The lost students were presented somewhere.
No, it's a different.
The one we are asking whether did he have mental illness is not this guy. But I've heard this presentation of a law student who fell from a three-story building, and where at a presentation, we are wondering whether did he have mental illness, how did it happen? Anyway, if it had not been presented, if I thought maybe it had been presented, but I know that the story is fresh in my head. That means I've heard it presented somewhere. Otherwise, it would be unethical to present it here if it had been presented before. No, second part of the question. To the last, our money, like Prof said, what population of patients did you study? Did you study surgical patients and this anemia in surgical, post-surgical patients, is it neuro patients? I don't think they present with the same electrolyte profile. So, like you said, classify your patients in terms of epidemiology. It makes it easier for us to follow the trend.
I think the patient, the case that came from UNTH, I saw the patient briefly at a private hospital. Before the patient, in fact, the patient came to do scan, but they couldn't afford the cost of ICU, the private hospital. Though the vice chancellor of the university guaranteed, but the hospital said no, that they need at least on deposit. So after some delays, patient now was forced to go to government hospital. So that delay, there was almost 5 to 6 hours delay. So the patient could have been treated more promptly. Maybe they would have gained 6 to 8 hours. Maybe it would have impacted on the length of stay and the outcome. So I think I had a chat with you concerning this patient. As a aside, then for the young man from Ibadan, let me just emphasize what Professor Shinaki said. The severity scoring system, the severity of illness score is a must. So I know that probably the reason why most people don't do it is because of lack of resources. Because you need, at least you need to do a blood gas. And you need to do liver function tests and all that. So, but that is the only way a study can be comparable. So it's difficult for us to really say whether your patient actually did very badly or whether they didn't do badly. But on the whole, at least it's a very good presentation.
Thank you very much, Mr. Moderator. My own comment is about our choice of words when we are making a presentation, when we are publishing. The topic of the presentation from UNTH, I'm happy Dr. Okona is here. He's one of the co-authors, says outcome of so, isn't it? And everybody in this audience, in this hall, were looking forward to knowing the outcome. And there was never any outcome at all. If I were to score this presentation out of 10, as good as it looked, I'm not sure I'm comfortable scoring her 2 over 10. Yes. Yeah. There was no outcome. And you kept all of us waiting for the outcome of the impaled scenario. In fact, I was discussing with Professor Shanusi here that could we be dealing with a suicide tendency? Could we be dealing with other issues, mental disease? These are things that could have been explained in the course of the discussion in 1 or 2 minutes, and then tell us what happened after 44 days. And so there was no outcome. As far as I'm concerned, that was no presentation. Thank you.
Sorry, Dr. Jimmy is the name. I think what I wanted to say has been said, but after 44 days in the word discharge home, I hope there's a follow-up. Let us know what is happening. Because if you don't follow up that young man, and then home, I see you to the ward. Okay. Then, of course, what I wanted to ask the young man is that what do for the electoral imbalance? What are the comorbidities? Disease that they came in with, but already Prof has already mentioned that because without that you cannot give a clear proper comparison of what's happening with electoral imbalance.
Well, on behalf of the scientific committee, I want to appreciate all those that presented. And then I want to also encourage those who did not present to go back and start doing studies. Thank you very much.
Thank you, everyone. Our meeting continues tomorrow, 8 a.m. We can exhaust the abstracts and then commence our AGM. We have a communicate drafting committee, which will be headed by Dr. Rotimi Muyiwa. Dr. Nka should be. Say you're traveling tomorrow morning. Dr. Ojum. Ojum, are you traveling tomorrow too? So Dr. Sivanus Ojum, Dr. Oladoku, has it gone? Oladoku, Dr. Okpara, Dr. Okpara, and Dr. Paul, you see part of their committee. Please, 8 a.m. tomorrow, let's exhaust all that we have so that we can start our AGM. 8 a.m. sharp. Okay. Thank you, everyone. Good night.
Thank you very much.
Accept my speech.
Yes. What right. But you are not reading from the. You are not reading from it. Yes, it's because it's a bit long. So the meeting will end now. So till tomorrow, you look at your schedule. Tomorrow by 8 a.m. there will be abstract presentation. So please log in by 8 a.m. Thank you. Okay, microphone information.
No, give me now. Please, one second, please.
Okay.
The standard books are for sale, but unveiled. So,
Hello.
The cost price was 5,000 naira. So what guys do encourage the posting by buying it as 10 or 20,000 naira. What is very rich? Residents is very rich for exams.
Has taken the
20
copies each
already.
Each. So 20.
Thank you very much, sir. That's